Good morning, everyone. On behalf of VIZAG Spine Club and North Andhra Orthopedic Association, I extend a warm welcome to all of you for the 6th annual CME of SSAP. The theme for today's meeting is spinal infections, which we routinely see in our clinical practice. Now I invite the President and Secretary, Dr. Y. Naishra garu, President of SSAP, and Secretary, Dr. Naresh Babu, to take over the proceedings. Welcome, sir.
So good morning, everybody, and I welcome all the delegates to this wonderful learning session from the stalwarts of the spine. This is a good initiative by Dr. Naresh right from the beginning, and he is doing that for successfully, very successfully, and then it is meant for only the spine fellows and the general orthopedic surgeons. Last time we had 2 times, and then that was so very useful for all of us, and then it was a grand success. And again today also the number of delegates registered here are also huge, and this shows this commitment of the organizers and the wonderful team headed by Dr. Rajshekaran. And whenever you meet him, it is always a new thing. Any times, however we meet him, anytime, it is always a new thing. That is the greatness of this man and his team, Abhay Neni and other spinal surgeons. I hope you will be greatly enriched.
Good morning, dear seniors, teachers and colleagues. It has been a good journey so far for the Spine Society of Andhra Pradesh, and it gives me immense pleasure for the annual 6th conference of our society. And we consistently have Dr. Rajshekaran for so many years, and it's very thankful to him to take time in his busy schedule and give AP Spine Society a lot of interest. I think it has got a special place in his teaching schedule. He takes it personally, and then it's not like a regular meeting where he attends. And this year we are focusing on spinal infections, and we are gathered here to dwell into the spinal infection topics, which is a common cases we encounter in day-to-day practice. And we are privileged to have Dr. Rajshekaran, Dr. Abhay Nene, Dr. Pushpa, and Dr. Thomas Kishan, who are experts in this field. And Dr. Rajshekaran's contributions to spinal infections is an internationally renowned contributions. Similarly, Abhay has internationally documented his philosophy of treatment of spinal infections. And Pushpa is a very good musculoskeletal radiologist. We often get very less time to interact with the radiologist when you face with an MRIs or X-rays and how to deal with it. So we'll just basing on our own clinical experience, we decided now we have Dr. Pushpa to speaking us about spinal infections and radiology of it. And Thomas Kishan is very good educator, teacher, is excellent in his commitments to teaching, and it's very great privilege for having him here. And this concept of this thing is completely different from your regular meetings which you attend. We are here to tap into the knowledge of all the international experts here and get whatever doubts you have, whether it's small or big, just get it clarified. By the time we finish this symposium and go back home, we should be clear in our all concepts and thoughts about the spinal infections. So without wasting much time, I'll just go on to introduction with our faculty. Dr. Rajshekaran doesn't need any introduction, but it's always a privilege and inspiring to just go through his CV, and even for how many times you read his CV, always, I think I need to update every 6 months his CV. This is the last year's CV, but I had just updated recently. And we know that Rajshekaran as chairman and Department of Orthopedics and Trauma, Spine Surgery, Ganga Hospital, Coimbatore, and the largest orthopedic unit in South Asia with 650 beds and 35 operating theaters and 20,000 major surgeries per year and 50,000 new patients, and total outpatient attendance is 1.5 lakh every year. Sir has done his orthopedics from MMC and FRCS Royal College of Surgeons, Edinburgh and UK, and MCH Liverpool, and done PhD from MGR University, Tamil Nadu. And he has been various positions nationally and internationally, and the president of Asia Pacific Spine Society, chair of AVO Spine International Board, and chair of AVO Spine International Research Commission, president of CCOT, president of CSRS AP, and president of Indian Orthopedic Association, president of Association of Spine Surgeons of India for 4 years, and president of International Society for Study on Lumbar Spine, and the president of World Orthopedic Concern. And he has been awarded the very prestigious Hunterian Professorship in 2011, and distinguished visitor to Harvard Medical International Boston, and a grand round lecturer for Dartmouth University, adjunct professor of Tamil Nadu MGR University, and past member and faculty of Annamalai University. He has been examiner for National Board of Examinations, New Delhi, and D.Y. Patil Deemed University, National University of Malaysia, Kuala Lumpur, PhD examiner for Faculty of Health Sciences, University of South Africa. And has been deputy editor for JBJS and deputy editor of Journal of Spine, deputy editor of Global Spine Journal, and Journal of Spine and European Spine Journal, and multiple international awards which you can't even think of or imagine. So North American Spine Society's Outstanding Research Award consecutively for 4 years, 2019, 20, 21 and 22. That has been a great achievement, and EASL's Best Paper Award in 21, and again for Clinical Sciences in 21, and Asia Pacific Orthopedic Association Best Presentation in 21, CCOT Research Award, Asia Pacific Best Clinical Research Award, Asia Pacific Journal Award for Best Clinical Paper, and Asia Pacific Best Science Research Award, and award for the Best Basic Science Paper in 2019. The EASL's prize. One more slide. It's our privilege to just complete it, at least to read it. It's an exhaustive thing, but our fellows and colleagues should know whom we are dealing with and whom we are listening to. And EASL's prize for spine research from 24, 2010, 2013, 2017, and 2023. The European Spine Open Paper Award in 28, and McNabb-Larocque Award of EASL's in 2005. And Sofa Murudanek Award in 96, 2002, 2016. And has significant national contributions allowed also, but Hariom Ashram Olympic Award, BC Roy Award, and publications wise, I think it's we get goosebumps when you listen to these numbers. 444 publications in international journals, and 100 publications in national journals, 597 international and 601 national presentations, 85 book chapters, and chief editor of Video Atlas of Spine Surgery, and ASIC textbook of spinal infections. So that's about Dr. Rajshekaran. Then we are going to have him today completely talking about spinal infections. Of course, coming to Abhay Nene is, sir has done his Spine Foundation Fellowship in 2000, MS Orthopedics from Bombay and University of Bombay, and consultant spine surgeon from We Are Spine, and performs spinal deformity corrections, tumor reconstructions, infections, and minimal access surgeries at Lilavati, Breach Candy, HN Reliance, Safi Global, and many more hospitals. Honorary visiting professor, pediatric spine surgeon at BJ Wadia Children's Hospital, and specializes in childhood spinal tuberculosis and scoliosis and C1C2 fixations. Sir is chairman of Asia Pacific, AVO Spine Asia Pacific Board, and national chairman for AVO Spine India, past chair, and a member of AVO Spine India Research, and the editorial board of Indian Spine Journal, Global Spine Journal, and Asian Spine Journal. He has been awarded the AVO Spine Asia Pacific Educator of the Year Award in 18, and ASSI Dartmouth Fellowship and Scoliosis Research Scholarship, and ISLS Spine Fellow Award in 2002, and Dartmouth Hitchcock Fellowship in 2006, and in Germany Spine and Spinal Rehabilitation and Surgery, and Argentina for Scoliosis Research Society, and Singapore as a visiting fellow, and is faculty chair of AVO Spine Asia Pacific Faculty Training, and mentor for ASSI National Spine Fellowships and Fellowships of FNB National Board, and his special research areas are spinal tuberculosis, osteoporosis, degenerative spine pathology, and National TV Spine Registry. And we have our, big applause to Dr. Abhay Nene, and Dr. Pushpa is our musculoskeletal radiologist, Dr. Pushpa did her MBBS from Vijayanagar Institute of Medical Sciences, Karnataka, and her radiology training includes DMRD in Father Muller's Medical College in 2007 and DNB at Satyasai Hospital in 2009. And she obtained fellowship of Royal College of Radiologists UK in 2015, and she joined senior resident in the year 2012 and worked 2 years at CMC Vellore, and before working as a consultant at Satyasai Institute. And she has also worked as a visiting consultant at Royal National Orthopedic Hospital, Stanmore, UK, where she has an excellent extensive training on musculoskeletal radiology and related interventions. And she joined as a consultant in Ganga Hospital, Coimbatore in 2017 and heads the Department of Radiology. And she is also a course director for musculoskeletal fellowship in the department. A warm welcome to Dr. Pushpa for taking time in spite of her other commitments. She has agreed to come over all the way and giving us the lectures. Dr. Thomas, my very good friend, Thomas Joseph Kishan is a highly accomplished versatile spine surgeon at spine care consultant works at Manipal Hospital, Bangalore, with an impressive educational background, includes MBBS, Ortho, D-Ortho, DNB Ortho, FRCS, Edinburgh, UK. Kishan has joined extensive knowledge on the expertise in the field of spine surgery. He has undertaken prestigious fellowships of spinal deformity surgery at Spine Surgery at Australia and other surgical skills. Also, the opportunity to enhance his skills at the global perspective from Seoul and also at St. Louis Children's Hospital, Steiner's Hospital, United States. And Thomas' his exceptional clinical abilities have gained him Balu Shankaran Award for the best DNB postgraduate in the country. It's a huge accomplishment. And also won Professor Professor M.E. Daniels Gold Medal from PSG for his clinical acumen and commitment to the patients. He has been a great educator and continuously does the PG teaching programs. A very big thanks to Thomas. In spite of busy schedule of organizing a big national event, he has come over here. So with this small introduction, I'll hand over the proceedings to Dr. Raj Shekaran. So we'll start the academic program now. Thank you very much.
Good morning. It's always a thank you, Naresh, for these extensive introductions, and it's a great pleasure to be here. I think this is the 6th year. I think I have been here almost all the times, and it's a really great pleasure because this is not one another academic program, but it's an academic program which everybody participates very well. And this year especially, it's really a great issue because this is not working. That's right. Because we have excellent faculty with us. So I think this is the first time Abhay is joining us. And as you know, Abhay has a special interest on spinal tuberculosis, spinal infections. And he has something up his sleeve which none of us others have. He has in his home one of the most proliferant and most able infectious disease specialist as his wife. So this is something that we can't compete with him against. So Abhay is here. Thanks, Abhay. And he's a great surgeon. He's also going to tell us how to get on with surgery. Pushpa and Thomas has been with us all the time. And they are going to bring in a lot of additional value of what we are going to discuss today. And I'm really happy to see all the stalwarts of orthopedics and spine surgery in this region also here. So thank you so much for the invitation. So when Naresh said, let us talk about something, and we usually choose one topic so that we don't have too many things and discuss little. I always thought it's better for postgraduates to take one topic and discuss it in great detail so that everything will be written. And the reason we chose TB and not all the rest of the spinal infection is because although we say disease is as old as man himself, but it is still not a disease of the past. So here you can see very beautifully, this is the Egyptian mummy, which means many centuries before it was like this. And this is the specimen in the Royal College of Surgeons of England. and that means many decades ago that it has still been there. And every day in our practice, we see a living model of the skeleton and the mummy walking in front of us. So this is something that we need to be really capable about. There are many statistics in India about which we are proud about, but there are also many statistics and numbers which we are not proud about. And this is one. In this very advanced stage, when we are telling that we are reaching the moon, that we have got many satellites up, we are good in nuclear power energy, everything we are talking about. But of all the countries in the world, of top 8 countries in the world, India has the highest number of tuberculosis patients in the world. Still, China had as much as India, but their numbers have gone down dramatically. And we are struggling still with TB. And India accounts for about 25% of the global TB burden, which means every one of the 4 TB patients in the world are from India. And with an estimated of every year, 27 lakh people are diagnosed to have tuberculosis. So, this is something that we have to be really, really careful about. But what is very interesting is that the pattern in which TB spine or TB presents to us has completely become different. I remember when I was a postgraduate, and that was 30 years before, in Madras Medical College, and I'm sure Dr. Shivanand and all the seniors here would agree, we had an equal number of TB hip, TB knee, and TB spine. So in fact, when I was doing DORT, there were so many TB hips, and if a TB spine comes in, then they will say there is a TB spine. Did you see that? People used to be surprised because the ratio was completely skewed for other articular joint tuberculosis and not spinal tuberculosis. But I don't know when is the last time I saw a TB hip. Abai, have you seen? Thomas? I really don't know why it doesn't happen. I initially thought because we are in private sectors, TB hip is not coming. So I asked the professor of orthopedics in Shivanand sir, how is it here? Nobody knows. I have been asking everybody why it is like that. It is completely changed. So the whole dynamics between host resistance and the genetics of the TB, everything is changing. And TB hip and TB knee has completely disappeared. Not completely, but still is very low. And now the presentation of TB spine is completely varied. I think this is the first point I want to tell you. Now this is a classic patient. He is 32 years, 5 months low back pain patient, normal ESR and normal CRP, normal X-rays, and all that he has got is some signal intensity change in T1, some hyperintensity of the vertebral bodies in T2. We call them the modic changes or bone marrow. And what is interesting is in the STIR images, you are able to see that there is a lot of disc hyperintensity. And this is all he has got. So it's a big confusion. I mean, he is a software engineer. Now, if you tell him that he has got a spinal infection, then he is very worried. First of all, you are yourself not very certain that whether he has got this. But a few months later, he started developing a little bit of epidural abscess, and then we knew that it was spinal tuberculosis. So a lot of these patients are simmering with low back pain for a very long time, and then they finally turn out to be spinal tuberculosis. Many of them heal by themselves also. So that makes it very difficult. So you have to be aware that the presentation of TB spine is not just somebody with a gross deformity with high fever, loss of weight. Nowadays, the presentation is completely different. I hope everybody will agree to it. You have to be really careful. Again, another patient with TB, the only thing that he had when he presented is a disc hyper signal intensity. So they are either like this, or the second important thing that has completely changed in the presentation of TB is that this patient, 29-year-old male, weight loss, tiredness, preoperative X-rays, as you can see, is completely normal. He is a doctor. So he is very worried that there is and also the son of another prominent doctor, they are very worried about malignancy. And you take an MRI, you can see multifocal tuberculosis. And this guy is also a doctor doing all his normal routine work, occasional lassitude. But you can see that he has got if you look at this, you will not believe that this is a doctor who is doing his normal routine everyday work, isn't it? So these kind of patients who are presenting with the extensive tuberculosis without much pain, without much clinical symptoms, and without much fever and other things are the same. Again, a 30-year-old urologist and coming for some minimal symptoms, you do an MRI and you find everywhere there is a cold abscess. No much destruction of bone, but he has got a proliferant and huge amounts of cold abscess everywhere. Yeah, please. Abhay, feel
I'd
free.
like to make a point because this is a very relevant point that in the past our impression, the reason for this, why this is the presentation has changed, that in the past we would imagine a TB patient as that cachectic guy in the huts who's coughing away and his beggars are looking after him. What they show in the documentaries. That's not the way a TB of osteoarticular origin presents. Osteoarticular TB is a reactivation of a dormant TB which is there in all of us. So 1 in 3 Indians have TB dormant in us. So all of us here, maybe. So if you do a Mantoux test, it's positive. What does that mean? That you've been infected with TB sometime in your life since you were born. I was born in 1972. Sir was born in 1983. So in so many years, we've always had the chance to get infected. So all of us have a dormant infection, but our immunity has put it down. And when our immunity goes down, and that can be because of diabetes, because of mental stress, because of diet, you go on a crash diet. And that's why now it's affecting the more affluent population who are exposed to this low immunity because of lifestyle diseases. And that's where it seeps in from the back. And that's one of the reasons why MDR TB is not supposed to be so common in adults. Because we've been infected at the time when the germ that is sitting in us is not an MDR bug, because it's at a time when MDR was not yet formed. So that is the reason why, that's a point that I wanted to make. Thank you.
Yeah. So that's also another reason why the national TB eradication program has not succeeded. Like we could eradicate all other diseases, smallpox, everything. But for TB to be eradicated, your nutritional status must be very good. And that India has failed. Congestion, too much of overcrowding, poverty, that has to be eradicated. And because we are not able to do that, we are not able to eradicate TB. But if a person has a good immunity, you will find that his presentation is very, very soft. It's very bland. And all that I want you to do is to make sure that just because somebody is not having a fever, weight loss, or something like what you read in the typical textbook description, you don't need to. Now look at this guy. He's again an adult, chronic low back pain 1 year. But look at his X-rays and CT. It already shows that there has been an infection, and it is also all a part of so much of sclerosis, and it's healing, and you can even see some sequestra within the big shoals, whatever you find over here. Now these kind of things where he has not been diagnosed, he has not been treated, but there is a big interplay between the inherent immunity, good nutrition, good health that is present in these patients, and the changing scenario of the germs, bacillary genetics. So on that side is one. The other side is you still get the ravages of the TB spine. They come to you when these guys are getting married, girls getting married, or somebody coming with the buckling collapse, because now he has the complications of it. So what we need to do as the standard introduction before we start is the first learning lesson for all the postgraduates and the beginners, that the presenting nature of spinal tuberculosis and osteoarticular tuberculosis is completely changed. Okay, so you will not fail to make or think of TB, because we were always told when we were TB can be anything. TB is a big mimicker of all diseases, but TB can be anything and anything can be TB. So TB you still must have it. So we'll start our discussion with a 10-year-old girl who's a student in the hostel. Active in school, pain in the back on and off for few months duration. She has been consulting. In the hostels they have a school doctor. Hostel doctor has been seeing her occasionally. Had little numbness in both feet 10 days before. On inquiry, she says she had a brief period of wobbly legs 2 days ago. Mild kyphosis in the upper back no major pain, no objective neurology. And definitely an X-ray had been done, and this is the X-ray. Yeah. Anybody? Friend? Yeah. Go on. Just tell. Nothing very. Don't worry that it is something hidden or something very catchy. Just take it up and say whatever comes to your mind. There is nothing. There is no trap or anything here. Huh? Don't feel afraid that.
Sir, this is a plain X-ray of an
Yeah.
immature skeletal showing cervical and thoracic spine, sir. I can see in lateral view there is a mild, nearly a kyphotic deformity, sir. Mild deformity.
So mild kyphotic deformity is there? Huh?
Thoracic level, sir. Upper thoracic, sir.
AP is okay. Always start with AP because as a whole, orthopedic surgeons we are genetically negligent to AP spines. Always, whenever we see you give the MRI, all that we want to see is the sagittal MRI. We don't look at axial MRIs. X-rays in every one of my class I show. The student always picks up the lateral view with. Is there anything in the AP view? Now that you know something is wrong in the lateral view, then you can focus on the region and say anything is wrong.
So there is mild narrowing of joint space in upper thoracic vertebrae, sir.
So if you're an orthopedic surgeon, you first have to learn to look at soft tissues. So you know what you will miss, you should learn to first focus on. So in the clinical examination of neck pain, I always say, if the person comes with neck pain, first examine the shoulder so that you will not miss the subtle periarthritis. If the guy comes and says, I have shoulder pain, first examine the neck and then go to the shoulder. So like that, if you're an orthopedic surgeon and if we have another genetic propensity to look only at bones, but here, at least in retrospective, you should know that there is something over here. Yeah? So this is it. So once this was done, then we had to tell the patient, we are suspecting some infection. I was saying the patient requires a bedroom. So now parents very worried and agitated. Now, agitated because of what? So they want to know whether the school doctor was negligent, because now you are saying that there is a small hump. She has been complaining on and off, back pain. Was the school negligent in not taking an appropriate moment? These kind of questions you will face, but you will also have to be really careful whatever you say at that time. One single word, one single phrase will nail the other doctor. So you have to be really careful in how you phrase your statements. And very usually this is, why did the doctor fail to take an X-ray before? Two things. We all are also, we are on this very often. We don't undress the patient to see fully. So small kyphosis, small palpations are never done properly. We don't examine the patient properly. And then this textbook description, patients usually present with pain at the site of infection. Typical symptoms are fever, night sweat, loss of appetite, weight loss. I have seen this in less than 10% of the spinal tuberculosis patient that I have seen in the last many years. So be careful about not missing it over this thing. So anyway, this patient went. What is your learning point? Back pain in a child, any situation is a red flag. Yeah? You know the red flags of back pain, isn't it? And back pain in a child is a red flag, which actually necessitates a higher investigation without waiting. So this is very important. So that's the second learning point. So the MRI is done, and then you have something very florid like this. Yeah. Who would like to read the MRI?
We take it to the other side.
Yeah, Abhay will choose.
Maybe behind. Anyone wants to comment on the MRI? Who third year PG?
So who's going? I heard somebody is here who got the medal last year. Yeah. See, one of the other important thing is don't hesitate to tell whatever you want, because there are many things here which you can easily say. So start off, learn to talk whatever you can learn. Yeah, go on.
So there's a prevertebral abscess and
Very good. So definitely, isn't it? There is a lot of free vertebral abscess.
there's
And
a paradiscal involvement of vertebrae
okay, there is
with
a large destruction of the vertebra over here. Yeah, severe kyphosis, isn't
kyphosis
it?
is there, yes.
Yeah. How many bodies do you think has been lost?
Two vertebral bodies.
So at least two. One seems to have gone for a toss completely, and the other is partially destroyed. But what is very striking is that this patient has got also. See, this is the normal signal intensity. The adjacent vertebra also has changed some intensity,
Hypotenuse.
and this paravertebral abscess is going up all the way farther away from. This is traveling, isn't it?
Yes.
So very much there. So madam is going to take a lot of things, So this actually shows a classic. What do you think? Infection, tumor,
Infection always.
infection, because there is a large abscess over here. Any clue of what it might be? Pyogenic or spinal tuberculosis?
It's probably TB, sir,
Why? Tell 2 points.
because it paradiscal involvement is there.
Yeah, paradiscal involvement. Paradiscal, because in this place is gone, no? Paradiscal is the initial stages. Here you can see that one vertebral body is completely gone. Yeah, and also what is the difference between adult and children? Paradiscal involvement is the 90% or 95% involvement in adults. In children, one of the very common form is body type, central type, where suddenly one vertebral body will completely get destroyed. Yeah?
Yes.
So you think this is TB spine.
Yes.
Why not pyogenic? Anybody? Patient has got no. Yeah. Tell please. Make it very Patient has no symptoms. This is true. Pyogenic infection often presents with symptoms, but on the MRI, any reason why you think it is not pyogenic? Madam will anyway come into the exact differences between this. But what I want to really tell is, so you can say this is the AP view, and this is one important sign which we will come to later. When you take a coronal view, if you are seeing a vertebral body cut, showing the axial cut of the cord or the vertebral canal, can you see here? It's a coronal cut, isn't it? This is the coronal cut. All these vertebrae you are seeing as a coronal cut, but suddenly at the top you are seeing one vertebral cut axial. Now just remember this picture, we'll come to it later. That shows something very important. Yeah, and this is the spine. And here you can see there is extensive vertebral destruction, CT. One vertebra completely gone. This is hugely gone. There's a lot of osteolytic areas over here. You can see that there is a massive destruction over here. So everybody agrees it will be tuberculosis. Very characteristic of tuberculosis. Yeah. And you can see that there is a lot of vertebra gone. And this is what we saw in the X-ray as a soft tissue collection over here. Very characteristic, very nice, typical that you can. Now, what I really want to emphasize here is that we must be capable of doing the radiological diagnosis ourselves. I am sticking my neck out in presence of a famous radiologist here. But what's very important is that we all need to read to know our own radiology. I'm saying this because radiology also has become a very big field. And there are very, very big advances in abdominal now they have hepatic radiologists, they have interventional radiologists, they have neuroradiologists, everybody. And if you're in the periphery or in a college or anywhere where the radiologist is not very well trained in musculoskeletal radiology, sometimes your interpretation after looking at the clinical patient may be much better than a radiologist who is just remotely telling about the screen. Not to talk anything wrong about the radiologist, but you are in a better position to put 2 plus 2 plus 2 is 6 together. So you should know very little. Why do I say this? Now, this patient is a 54-year-old quadriparesis, presented with quadriparesis, has been on ATT for pulmonary tuberculosis 2 years ago. Yeah? So, I didn't have his picture, but they had also scanned his lungs and it showed active pulmonary tuberculosis. And so, 2 plus 2 here is what? Radiologically. That this lesion is also a TB. And he was started on ATT again, and he became quadriparetic, and then he was referred over here. Does it look like TB, madam? So this actually turned out to be chordoma. But you can say why it doesn't look like TB.
I don't see fluid-like collections. It looks more like solid,
Yeah.
and it is very hyperintense. So it could be something like chondroid or myxoid type of matrix. That's why it looks very hyperintense. And also in the prevertebral space, there is the same soft tissue, but again, I'm not seeing any collection.
Yeah. So there is no collection here, is it not? It looks more like a solid lesion, rounded also,
Rounded,
and
in
it
spite
is.
of so much of vertebral body involved, there is no collapse,
Yeah.
which is very common in TB. So.
Yeah. Yeah, encapsulated tumor still holding, and this kind of pressure. You have to keep on seeing your radiology. You should not just looking only at your radiology reports, so that these multiple picture interpretations will get into your cortex. So as soon as you see, you must know, okay, this is not TB. It is not the classic TB picture. And this was reported by a radiologist as spinal tuberculosis. So no fault on anybody, but this is over here. Now this is another patient who in the initial stages of this destruction was also reported as spinal tuberculosis by a radiologist, was started, and then you can see when he presented to us, you can see there is complete loss of vertebral bodies, and he also came with quadriparesis. And then when we did an urgent decompression and sent it for stabilization, and this patient was turned out to be primary lymphoma. But this patient recovered well after 8 months, but this need not be the case. It should have been treated when it was much earlier. Then the patient could have completely avoided the surgery itself. So we need us to be our own radiologists. And so one radiologist is going to tell us how to be our own radiologist. So Dr. Pushpa is going to actually talk to us about if you are looking at MRI or some advanced radiology where you are suspecting infection, how will you approach it? What will you look for in the MRIs? And how will you differentiate between different infections? Dr. Pushpa.
Thank you, sir. You almost covered half of TB imaging as well. Is it on? Yeah. Yes, sir. So I'll be covering not an exotic cases, but I'll be telling the basics of how to identify infection, how to differentiate pyogenic versus tuberculosis, and what are the typical imaging findings you see. Atypical one, anyways, we have to do a biopsy and find out, or we have to do a close follow-up to find out what happens to the patient. But when you see the typical cases, you should be able to identify which is pyogenic and which is tubercular. So let's start. Some prompt is coming over in. about this. Sorry. Continue. Quit. Okay. Thanks. So why do we do imaging? So first thing is we need to confirm the diagnosis. Then we need to know what is the exact extent of the disease, and we need to look at the complications. So these are the three things we want to know when we do imaging. What modality is very useful? As we have seen several examples now, MRI is obviously a game changer. It will show everything you need to address, like surgically or conservatively. So it is based on MRI. So the first thing we do is radiographs, because it is whenever the patient comes with non-specific back pain, usually that is the case, and you end up doing radiograph first. But you should remember radiographs have very poor sensitivity, particularly in early disease. But later in course, of course, they can have 90% sensitivity. So now if you see at this radiograph here, you can see there is nothing much happening, but the patient is having too much backache. So when he came to us and look at the X-ray here, you can see some listhesis of antrolisthesis of L4 over L5, and L5 shows subtle retrolisthesis. There is reduction in the disc height. There is a large bridging osteophyte over here. Some sclerosis you can see, but you can not tell looking at this X-ray that the patient might be having infection. But when you look at the MRI here, you can see there is diffuse edema in the vertebral bodies, and also interdiscal hyperintensity. There is small collection in the epidural space as well. So what does it indicate? There is definitely, if there is collection, that definitely indicates there is infection. So why does this X-ray looking normal? You should remember that about 30 to 40% of mineral density has to be lost before you see some lysis in the X-rays. So in the early stages, you may not see any signs of infection, other than maybe if disc is involved, there may be reduction in disc height. So we should be very careful only interpreting infection, to rule out infection only based on X-rays, especially in early stages. Looking at this X-ray now, again, anyone can describe this X-ray? So I'll tell you this is an infection patient, but you can tell me the findings.
This is AP X-ray of skeletally mature patient in thoracic level. There could be the disc space is reduced at multiple levels in the AP radiograph, and there is soft tissue.
Yeah, very good. So there is soft tissue on the either side of the
either side
spine,
of the-
right? Which is quite abnormal. So you always see a shadow from the aorta on the left side, but
Yes.
you don't see this type of paravertebral soft tissue. Although you can see a small line here, that is normal. But you see there is a large soft tissue here.
tissue.
So this is definitely. But if the patient is having typical features and you see something like this, infection is pretty much sure. But for the same patient, you do MRI. You can see there are multiple vertebrae involved. You see there is a anterior epidural collection which is causing canal compromise and cord compression. And then you see a large paravertebral posterior paraspinal soft tissue, which you can't make out in X-ray obviously. So, and also there is cord compression, severe cord compression. All these findings you will not be able to see in X-ray, although patient might be.
Sorry, can I just a little word for the postgraduates. When you're reading an X-ray, I think it's good to go in some kind of order. So it's called the ABCS of radiology. So A is alignment. So you look at the alignment on the AP, you look at the alignment on the lateral. B is bone. So you look at each vertebra separately. Okay, in the AP, in the lateral. The third one is the cartilage or the disc. You predominantly comment on the cartilage height on the lateral view only. You should avoid commenting on the disc height on the AP view, but sometimes you can when it's very obvious. And the S is soft tissue. So if you go in that order, it's very unlikely that you're going to really miss anything on X-rays.
Yeah, also, when you have one evidence of a problem localized to one region, then you should start looking at that bones more carefully than rest of the bones. So if you see here, so in the bone also, what do you actually see? You see the margins. Now let's take this as a normal bone. So you are seeing the inferior end plate, superior end plate, and the margins very clearly. Lamina, two pedicles which look as the eyes, and this is the beak of the owl. But can you see here? The lateral margins of these bones are all not very clear like over here. Can you see here? Here they are not as clear, and here can you see there is some destruction of the lateral margins. So this is called reverse findings. So once you locate a problem in one region, then you should go back into that region and see it more carefully, so that initially if you have seen, if there was no paraspinal abscess here, all of us might have missed that lateral margins have been eroded. But once you know, then you have to go in and see it once again. So always develop a very systematic method of doing this.
So as you know, as you saw now the X-ray will not give you a complete picture of what is happening in the spine. So MRI is obviously a go-to investigation when you suspect infection on radiographs. Okay, so first thing, it confirms the infection. Second is it tells what is the extent of the disease. And then you can also see some unexpected complications. Like in this patient again, so there is a patient, 74-year-old with diabetes, presented with severe mid-back pain, fever, elevated ESR, CRP and cell counts. So definitely we knew it is an infection. And you can see there is reduction in the, it's not working. Okay, reduction in the intervertebral disc height, and there is some subtle soft tissue changes as well in the paraspinal region on the left side. And again, when we did MRI, you can see that there is changes in the vertebral body. There is irregularities of the end plate. The disc shows some hyperintensity. There is minimal pre and paravertebral soft tissue. Everything points towards the infection. But what was very surprising in this patient was that there was a mycotic aneurysm of the thoracic aorta. So such kind of weird complications are also possible with infection. So MRI plays an important role in picking up such infection. So we have seen patients with mycotic aneurysm, we have seen patients with IVC thrombosis, we have seen patients with where infection has involved ureter and caused obstruction of the kidney. So all these things can be detected using MRI. So MRI plays a very important role not only in looking at the infection and its extent, and also complication other than what can happen in the spine. So if we have to read MRI for all the infection, I'll just briefly tell how to identify these sequences, what sequences can be used. Obviously most of you will be knowing, but I'll be telling for people who are just beginners in case of MRI.
Most of us don't know, madam.
So the basic sequences, the routine sequences, which I use only the routine sequences, frankly, to make the diagnosis and to tell the extent. I don't go for any exotic sequences when it comes to MRI. So we have T1, we have T2 and STIR. And because you people like sagittal, I have put sagittal X-rays, MRs here. So we will be doing in various planes, right? We'll be doing in sagittal, axial and coronal for different, to know the different aspects of the disease. But to make you understand, I thought the sagittal sequence would be very easier. So we have T1 sequence, we have T2 and STIR here. The two things which you have to look for to identify the sequences is the fluid, that is the CSF here. You can see that is the CSF and that is the cord. And these are the vertebral bodies. Okay, so we have to look for two tissues to identify the sequences. One is the fat, so that is the paraspinal fat there, and second thing is the CSF, that is the CSF there around the cord. So if you identify these two structures in the spine, then you will be able to see which sequence it is. Okay, so if the fat is bright and CSF is dark, that is T1 weighted sequence. If fat is bright and even CSF is bright, that is T2 weighted sequence. If CSF is bright but the fat is suppressed, so STIR is actually fat suppressed sequence. So if you see STIR, it shows fat as a dark structure. Okay, and fluid as a bright structure. So fluid bright, fat dark is stir. Fat bright in T1 and T2, and fluid is dark in T1. So this simplifies how to identify these sequences. Why this? Why do we do three different sequences? What information we are getting from each individually? So when you look at the T1 sequences, as I said, fat is very bright. So marrow fat will be very bright. So it will give nice anatomical detail about of the vertebra and bone in general, and also the disc will appear relatively of different density than the vertebral body. So it is easier to identify the structure, like anatomical structure, and can be easily made up by T1 weighted sequences. That's why T1 is more of anatomical sequence. What has happened here? There is complete collapse, and you can see the signal intensity of the vertebral body has completely changed. To know, so in T1 weighted sequence, it becomes very easy because naturally the vertebral bodies are bright because they contain fat. If this fat signal is lost, if it becomes equal to the adjacent muscle, then you say that fat is lost. So once you see loss of fat in the vertebral body, that means it is definitely affected. Why do we need T1 and stir sequences? These are very good to pick up the pathology. Like T1 is very good to pick up the anatomical details. T2 and stir are very good for pathological details. So if you want to see there is an epidural collection here, you want to identify the epidural collection, it is quite easier on stir and also in T2 weighted sequences. The vertebral body edema, so it is very evidently seen in stir sequences. The anterior epidural collection, anterior prevertebral collection is also very well seen, and cord signal change, compression of the cord and cord signal change is also very well seen in stir sequences. So for the pathology, we always rely on T1 and stir sequences, and for anatomical details, we look for and also for the marrow changes, we look for T1 weighted sequences. So these are the basic sequences. You'll be able to say the extent, the complications, the conformation of the infection very well by using these routine sequences. Now, if you have question like if I do any contrast, I usually don't do contrast. First thing is it is very time consuming. Ours is a busy setup. We don't afford to waste time giving contrast when we have all the information required by routine sequences. Second thing is there are studies telling that gadolinium can go and deposit in the brain and cause some changes in the brain, which is not very good. And third thing is it is expensive. Not everyone will be able to spend 1,200 or 2,200 or 2,000 rupees extra. So we avoid contrast. But if we give contrast, it is like people who are not very well trained in looking at the routine sequences, it becomes very obvious to know the extent of the disease. The another important use, I might say, of contrast is to look at the necrotic area. So if you look at the necrotic area, you see that there is no enhancement in the necrotic area. That dark area is actually necrotic area. The peripheral area is all which is infected, and there is a collection. Okay, so when you know the necrotic area is present there, you will not take biopsy from that area. That's the only use of giving contrast, I would say. And sometimes I might have a doubt when there is a collection in the posterior epidural space. That is another area where I'd like to give contrast. Coming to typical features of pyogenic infection. So, based on your present knowledge of MRI, like based on the last few slides, can anyone describe this? So first one is T1, T2, and stir sequence. This is the contrast sequence.
First one is a T1 weighted image of lumbar sacral spine showing destruction of the lower end plate of the L4 and upper end plate of the L5. And second image is the T2 weighted image of lumbar sacral spine showing destruction of the vertebra and collection of the fluid over the posterior aspect of the vertebra and anterior aspect of the vertebra, and there is a little compression of the posterior aspect. and there is a disc collapse and disc destruction at the L4 L5 level.
Excellent. So you can see this is a T1 weighted sequence. You can see that you can see that is the fat. It looks bright. Fat looks bright, and this is T2 weighted sequence. Fat is bright, fluid is bright, and that is still sequence where fat is all dark. So these are the three sequences here. See, look at the vertebral body. This is a normal vertebral body because it has nice fat in it. But if you see L4 and L5 vertebral bodies, they are all dark. So in pyogenic infection, what happens? Even though the complete vertebral body is involved, or if the most of the vertebral body is involved, it won't collapse so easily in pyogenic as compared to TB. I'll tell you the reason why later. And if you see the end plate here, this is very dark and nice, thin end plate. You can see this end plate is all irregular and ragged. There are multiple defects. Okay, and again, when you see there is change in the vertebral body signal intensity, it is very ill-defined. So it is like a haze. It is going in the vertebral body. It is not like clear-cut border is not there between the infected vertebra and the normal vertebra. An intervertebral disc. So look at the intervertebral disc here. Look at the intervertebral disc here. It has reduced significantly in its height. And if you see, look at the T2 weighted sequence, there is a lot of fluid in the intervertebral disc. And epidural collection. So you see epidural collection here. You see epidural collection in T2 weighted and still sequences. And on axial sequences, you are seeing the paraspinal collection. What about this paraspinal connection? Even this paraspinal connection is not having any well-defined borders. It is just infiltrating into the soft tissues. Okay, so whenever you see collapsed disc, and then you see with clinical context, of course, collapsed disc and involvement of the vertebral body without much change in the vertebral body height and fluid in the intervertebral disc collection, which is very ill-defined and infiltrating everyone, this goes more in favor of pyogenic. Okay, not typically in favor of TB. And if the patient has acutely presented to you, this is more in favor of pyogenic infection. Okay, and if you look at the collection also, it is very thick-walled, very irregular, very infiltrating. So that is how the paraspinal collections in pyogenic infection look like. Another example here, again, X-ray shows nothing much. Yeah, please. That's what, like to see so much of vertebral involvement and also the disc involvement with fluid and irregular collection. The collection is actually spreading into the if you see, it is not very well-defined collection. It is going everywhere. It is going into the muscle. It is going into paraspinal muscles. And if the patient has produced very acutely, and you see, in spite of the entire vertebral body involved, and there is no collapse of the vertebra, there is no intervertebral collection as well. So all this put together, you think more of pyogenic. I'll come to few of the examples where these doubts will be cleared. Okay. So another example here, X-ray shows nothing much other than reduction in the intervertebral disc height at L4-5, and there is some signal changes here. There is some destruction of the anterosuperior corner of the end plate. And if you see in the T2 weighted sequence, there is diffused hyperintensity. Again, there is small break in the end plate, and there is a small tiny abscess into the end plate. The disc is collapsed and there is fluid signal in the intervertebral disc, and also there is a break in the anterior cortex of the superior end plate of L5. And if you see at the paravertebral collection and epidural collection, they are very ill-defined and there are tiny pockets of collection. All these again indicate that this could be a pyogenic infection if the patient has come to you with an acute presentation. One more example, again, if you see at the paravertebral collection, pre and paravertebral collection, they are very well defined, they are very thick walled, and that's what is very typical of pyogenic infection as compared to tubercular infection. So let's see the features of tubercular infection. again, I was telling in acute, usually pyogenic infection will present very acutely. This was one patient who came in April 2024 with low back pain. And only thing he had was a low back pain, no, not a radicular pain. But then when we did MR, there was no end plate break. There was just a slight subtle hyperintensity in the disc, and there is a disc protrusion. So we attributed his back pain to only disc bulge and nothing else, because there was no much change in the end plate. So we thought this tiny change here in the end plate signal was just a modic change. So we sent him giving conservative treatment. But within a 1 month, he came back with severe back pain. And again, when we did MR, you can see there is interdiscal edema. There is also edema in the vertebral body. There is a small epidural abscess which has come up now. And when we did CT, there is a break in the end plate and also a subtle destruction of the vertebral body. So this acute presentation again points towards pyogenic. Now coming to tubercular. So can anyone discuss this case? Describe the findings in this case. After that, we'll go quickly, no more questions. Maybe that will encourage them. Answering last one.
There is a plain X-ray of lateral and AP view along with MRI, T1 weighted and T2 weighted images. In lateral view, there is a
Go to the MRI.
MRI.
Just what you see in the MRI.
okay. There is a prevertebral abscess in the T1 weighted image, and there is a collapse of the vertebra along with the cord compression. There is prevertebral abscess also. Sorry, paravertebral abscess.
Very good.
So what distinct differences you see from the previous MRI? Take three
Destruction
different.
of the vertebral
Excellent.
body is
Okay.
there, sir.
Yeah. So massive destruction of the vertebral body is there. Yeah. And if you see the signal intensity changes in the bone also, it is all marked. You can see a very clear distinction between the inflammation and normal bone. And this paravertebral collection is very clear, isn't it? You know where is the margin.
Yes, sir.
You see the axial views. Can't you see it's very crystal clear where the
Margins are.
margins are in. Whereas in the previous one, it was very diffuse and very
Lost, sir. Yes.
preserved.
Yes, sir.
The disc on the MRI is significantly preserved, and that's a hallmark.
Okay.
So this is a PG exam question, that why does the disc get involved in tuberculosis? A
Yeah.
disc is avascular.
Yes.
Okay, so why does it get involved in tuberculosis? Why do you see disc space collapse in a later stage of TB? It's an exam question that will be asked.
Can you repeat the question, sir?
So TB normally affects the affects through hematogenic spread, but the disc is the largest avascular structure in the body. So why does the disc get affected in TB? Anyone?
Too late.
750 watts now.
Oh, really?
So it affects the end plates and necroses the disc aseptically. There's an aseptic destruction of the disc because the end plates get blocked. And so if you sample the disc, it will not grow TB. It's just a sequestrum. So there's no infection in the disc, unlike pyogenic where there's infection in the disc. All right.
Corollary question is, in the plain X-ray, then why do you see reduction of disc space as the first symptom in TB? So disc is not involved, disc is preserved. The reason why most of the time orthopedic surgeons forget about seeing the preserved disc in the MRI is we have all been taught first sign of TB is reduction of disc space. Why does it happen? In the plain X-ray, you can see there is no disc space. But in the MRI, you are seeing good disc space. Why does it happen?
Because end plates get destroyed.
Excellent. So the end plates get destroyed. and the end plates get destroyed in the center more than in the periphery. So the disc migrates into the bone, and so the laterally preserved bone comes into opposition with each other. And so always in the plain X-ray you see the disc is lost, but in the MRI the disc will be intact. So that you should know, remember. Yeah. So these 5 or 6 clear distinct differences, you know, then you can be very clear.
So, when you're dealing something like this, so you have multiple vertebrae involved. Okay, so you have 1, 2, 3, 4 vertebrae involved, and then you have vertebral body destruction. You can see the vertebral body has completely collapsed, and you have the intervertebral abscesses, like ill-defined abscesses within the vertebra. You can see this part of the vertebra is completely clear, whereas the half of the vertebra is actually eaten up. So these are the features which you see in the vertebral body to call it as TB. So ill-defined vertebral body abscess, complete collapse, destruction of the vertebral body, and multiple vertebrae involved. All this go in favor of tuberculosis. Next thing you should see is paired intervertebral disc. So if the intervertebral discs are preserved, that again indicates that this is tuberculosis, not pyogenic. Then you look at the subligamentous spread of the usually what happens, as sir told, there is a hematogenous infection of one vertebra, and then because it is very low virulent, that proteolytic capability of tuberculosis is very low. So what it does is it goes into the least resistant area. So from the vertebral body it goes to the subligamentous space, and instead of going through the disc, it actually grows along the subligamentous space. When it goes along the subligamentous place, that is along the anterior longitudinal ligament, it can't breach that ligament because it is low proteolytic enzyme. It has a proteolytic capability of TB abscess is very low. So it only strips the vertebra from the ALL is actually stripped from the vertebral body. So that there will be scalloping of the anterior part of the vertebral bodies. So that scalloping only you are seeing here. So the subligamentous collection is actually scalloping the anterior vertebral bodies, and eventually it goes for loss of vascularity, and avascularity will happen. So avascular necrosis will result in collapse of multiple vertebrae. That's when the deformities will happen. So all these things you should be able to see. So again you should see these are the intercostal vessels. They are actually nicely displaced. They are not encased. And if you see the paraspinal collection, they are also having very thin and defined walls. So all these are features of tuberculosis. So one is multiple vertebral body involvement, intervertebral abscess, complete destruction, sparing of the intervertebral disc, subligamentous abscess which is very clear and well defined with thin walls. So these are typical features of tuberculosis. When do we do CT? CT mainly we do to look at the bony anatomy, not the soft tissue anatomy. How is the pattern of bone destruction? If you see TB will always cause this type of destruction. So there will be a lot of sclerosis. In center, there will be a lot of floccles of the bone like this, cloud-like bone. Looks like sequestrum in your usual large bone infections. And also these will be small fragments divided. So this looks typical of TB. And if you look at the paraspinal, that also shows nice calcification. So to look at the calcification, either you have to go to CT or X-ray. MRI is very difficult to look at the calcification. This is also very much sensitive for telling that this is tuberculosis. Now, what the literature tells, like whenever we do biopsy, and within 2 days, patient wants to know whether he has to take ADT or so again. Fellows will come and ask whether it is TB or pyogenic. So what we should actually rely on? So we can completely rely on presence of intraosseous abscess to tell it is not pyogenic. Another thing is if there are more than 2 vertebral bodies involved, then you can actually tell it is tubercular in 25% of the cases. Destruction of vertebral body of more than or equal to grade 3, then again high chances that it is tuberculosis, not pyogenic, and intervertebral disc pairing. So these are the few things you can consider to tell, okay, this is not pyogenic at all. But rest of the things, if you see, there is 5 to 10%, even 22% that both of them can be having, like spinal deformity, the abscesses, and vertebral destruction and thoracic spine involvement. All these things can be seen in both TB and pyogenic. So there is no clear-cut demarcation, but if you see certain things which are very much pointing towards to either pyogenic or TB, you should be able to make the distinction. So this case again, same thing. You can see well preserved. So only one vertebral body is completely involved. Then it has gone into subligamentous. It has raised the ALL, and along the ALL it has spread to the adjacent vertebra, and it has involved the vertebral body, sparing the intervertebral disc. Okay, and if you see the epidural space, there is one ligament here. This is called anterior meningovertebral ligament. So this is one of the features of tuberculosis. This will be spared again because it has not, it doesn't have much of proteolytic capability. So this ligament can be spared. So most of the time we also look for this particular ligament. If this is spared, we think it is more in favor of tuberculosis, because in pyogenic, even if there is a small collection, this ligament will be first eaten away. Okay. But in tubercular, even if the epidural collection is bigger, we'll be still able to see this an anterior meningovertebral ligament intact. Sometimes we have atypical infection like this one. So there is a large intraosseous abscess. There is a significant, but you can see even if there is a large intraosseous abscess, there is a clear demarcation between the rest of the edematous bone and the collection. So this is very typical of tuberculosis. In CT, you can see a large sequestrum, and there is diffuse sclerosis of the rest of the vertebra, and the disc is not very well, it is not very well preserved, but it is affected very partially as compared to pyogenic. So this was one of the atypical cases of tuberculosis. Again, this case, because there is lot of vertebral body destruction and also end plate involvement, but again there is clear-cut demarcation between destructed vertebra and rest of the edematous vertebral body. Again, sir had shown one multifocal infection. Here you can, it is very difficult to tell whether this is just a metastasis. If I see multiple vertebral bodies involved, disc space is all preserved, even post-T elements are involved. I don't see any paraspinal or soft tissue collection very evidently. But if you see very carefully, there was one collection here and there was one collection here. And when you see at the T2 weighted sequence, it was mainly granulation tissue. So it was again very difficult to tell whether it was TB or infection unless we did a biopsy of this. After we did biopsy, we could confirm that it was indeed TB. So the last case, TB or pyogenic. Again, you can see complete vertebral destruction, subligamentous collection very well defined. The intercostal vessels are not affected. Vertebral bodies are completely destructed, and adjacent intervertebral discs are not involved. And you can see sparing of the anterior meningovertebral ligament. So this is likely to be TB. So do you have time for atypical, or I can stop here?
How long will it take?
So there are 4 or 5 slides.
4 or 5 minutes. Quickly go through it, then we'll finish it off.
So I should do atypical infection or mimics?
Atypical, I think. Just go through it fast. So
Yeah. So this is one lady who came with sudden onset of back pain, and she was diabetic, no history of fever. Only she came with severe back pain. And when we did radiographs, nothing much was seen in the radiograph. But in CT scan, we could see there is lot of gas in the vertebral body, as well as there is a paraspinal soft tissue, which again showed lot of air pockets. So this was a case of, and when we did MRI, again there was features of pyogenic infection. Like you can see the disc is all involved, and the vertebral bodies are also showing change in signal intensity, which is very hazy. Paraspinal soft tissue is very thick walled abscesses are there, which are very irregular, but air pockets were one which was very striking in this patient. This was actually emphysematous osteomyelitis with paraspinal abscess formation. This was another 66-year-old gentleman who came with chronic back pain for 6 weeks, and he had occasional fever with loss of weight and appetite. You can see multiple vertebral bodies are involved. So all the vertebrae, almost all the lumbar vertebrae are involved, and the signal intensity changes are very hazy. The vertebral body height is very well preserved. Some of the intervertebral discs are well preserved, and a disc, a few of the discs are involved, not all the discs are involved. So, what do you think this could be? So this was the fungal infection. So sometimes fungal versus tuberculosis can be very difficult to differentiate, but multiple vertebral body involvement. End plate can be subtle hypointensity of the end plate can be seen in these cases, mainly because of mineral content. So if you see on the T2 and also on the T1 weighted sequence, there can be subtle hypointensity of the end plates. That is because of the fungal elements, because they have minerals, and then sparing of the disc space and predominant anterior body involvement. All these will point towards fungal infection. Another example, same findings. You can see there is lot of sclerosis of all the lumbar vertebrae, in spite of all the vertebrae showing so much of sclerosis and end plate destruction, reduction in the disc height, and also interdiscal hyperintensity. You can see all the height of the vertebral body is well preserved. The prevertebral collection and paravertebral collection is very minimal. This was a case of brucellosis. What is the important feature of brucellosis is that it involves lower lumbar vertebrae. Sclerosis is a prominent component. There will be large osteophytes, too much sclerosis, and maintained vertebral body height, even though intervertebral disc and small paravertebral collections are visualized in brucella. This was a very nice case of spinal hydatid disease. So there is a lot of cystic areas. It was impossible to diagnose only on imaging. Based on histopathology only, we thought it could be some weird form of cystic schwannoma actually, but it turned out to be hydatid cyst. Sometimes you can see only posterior epidural collection. That is again very much in favor of tuberculosis, which is an atypical finding. So should I tell about mimics or?
No, come back. Thank you, Pushpa. Thank you. Can we change it to this? Thank you, madam. So that was absolutely brilliant. Every time we listen to a radiology specialist talking, we catch a lot of points. So this is it. So just we will go through. Yeah. Okay. Yeah. So this was exactly what she told us, the difference between TB and spine. But I'll just, we will go through very fast to recapitulate. Any one postgraduate, so I'm not giving you time to go through the findings, but just as a man. So this is a 40-year-old male, lot of pain. Everything I'm saying has a value. So patient has present acutely, lot of pain. Disc signal intensity is very high, hyperintensity signal intensity. You can see a lot of edema in the bone, which is not well loculated, and bones are preserved. So what do you think, TB or pyogenic? Pyogenic. Yeah? Okay, good. So this is also, madam told that this rapidly progresses. This is the same patient. Just within 3 months, you can see that he is coming with a lot of intraosseous the huge reactions, and you can see that there is a lot of reaction in the bone, but the bone itself is not collapsing. So that's a pyogenic abscess. So this is a 55-year-old agricultural labor, low back pain for 6 months. And what do you see here? So bone is very well preserved. There is a decrease in disc space over here. Prominent osteophytes both on the sides. Can you see here? This is a typical osteophyte which comes like this in this disease on both the sides. So bone preserved, and within 3 months, the patient has not had any treatment, only an increase in the pain. And you can see that these osteophytes are now become much better. Can you see? Lateral prominent osteophytes beaking and connecting, and sclerosis of the bone increasing in spite of no treatment. MRI shows there is a lot of bone destruction, lot of sclerosis, but no collapse, no major collections. What is the diagnosis? Brucellosis, isn't it? Yeah. So that was very typically said. This patient had a high brucellosis content. And then once you put them on the proper treatment, you can see how well nicely they heal and then get back to normal. Yeah. This one, don't need any description. Come on, what is it? No, talk loudly. You're having the mic, but you're not speaking into the mic. What you just tell the diagnosis? We have discussed it too much, actually.
Tuberculosis.
Yeah, tuberculosis. Everything is there, isn't it? I mean, bony collapse is there. You can see there is a lot of bone collapse. There is a very clear-cut bony edema differentiation. Intraosseous abscess is there. Collection is very nicely seen. Subligamentous going over many vertebral bodies, and the margins of the abscess you are seeing very well delineated. So there is no doubt that it is spinal tuberculosis. Why you are still hesitating? I mean, this is a very good catch. So this is another patient. You can see what do you see here?
Vertebral body destruction.
Yeah, but apart from vertebral body destruction, what do you have? Huge soft tissue, pre-vertebral soft tissue here, isn't it? Associated with vertebral body destruction. And always you will find that the vertebral body destruction looks much more when you are doing a advanced imaging. You can see completely eroded. Most of the base of the C2 is completely gone. You can see it comes up to the odontoid process. That is the MRI. Yeah. Yes. Anybody? No, it doesn't matter. This is not an examination. Just say what it is. Yeah. This is a very.
Biogenic TB, fungal, hydrated.
Tuberculosis, huh? Okay. So this is, I put it as the last case, just to say that you should always have whatever you think, however sure you are that in these circumstances, you should always do a biopsy. Okay, this turned out to be a tumor, and I put it as the last one because however sure you are of in the radiology, there are some instances where you can be really very sure, but these weird areas you should always be careful. This actually turned out to be a neurotumor, so that's this thing. So once you are having all these radiologically, you get almost convinced that it is 99.9% a spinal infection. Then there are another only 100 tests which you can still do actually to confirm your diagnosis or to torture your patients, isn't it? I mean, you can either do that. So also, whenever there is a disease and then it becomes prevalent, the medical industry also progresses very fast in finding out too many tests to confirm. So many of the spinal tuberculosis patients, you can now come, they always come with a bunch of file. I did this test, sir. You say it looks like TB, they'll say, no, sir, I did this gold test, sir, silver test, but still it has come as negative. Then you tell something, they'll say, no, I did even ELISA test, it's come as negative. And then he is not convinced that he requires a biopsy. So there are so many tests available. So Thomas is going to tell us exactly what we need to do and how we do it. This is a very important subject because many tests are misused in our actual practice.
Good morning. Thank you, Naresh, for the invitation to speak today. Thank you, sir, for the invitation to speak today. Thank you, sir. So going to talk about laboratory investigations for tuberculosis. So before we do that, we need to remember that the diagnosis of tuberculosis is based on the 3 pillars. So your clinical examination, imaging, and laboratory tests. So that is important for diagnosis, that is important for follow-up to treatment, that is important to ascertain response to treatment also. So you need to look at all 3 of them before you come to a diagnosis. So there are numerous tests for tuberculosis, which there are some that you should be doing and there are clearly some that you should not be doing. Okay, so before, can we ask the postgraduates, like, so once you've had your patients come with back pain, severe back pain, you've gotten an MRI and an X-ray done, show some pus collection in the spine, what would you do next, laboratory investigation wise? What is the next test that you do? Would you just take them up? Yeah, there are 2 of you.
Your
Yeah.
mic is not working. So either you have to switch it on, speak loud. Yeah,
What-
but the whole hall is full till the end. So
Yeah.
you have to
Complete
speak
blood
in the
pressure.
mic.
I'm sorry?
Complete blood pressure.
Okay, so that is like a hemoglobin, total
Total
counts,
count,
differential
differential counts.
counts. Yes.
And
Number 1,
ESR, CRP.
ESR and CRP. So that should probably be the first line of treatment. What are the significant things that you would look for in these tests? If you're suspecting an infection, So what?
Increase in the total count.
So in TB versus pyogenic, you think there would be any difference?
Leukocyte count can be raised in
Total count itself.
total count.
Typically higher in
Pyogenic infections.
pyogenic infection. Typically higher in pyogenic infection. And ESR and CRP, you would expect that to be
Elevated.
higher. If the ESR and CRP are completely normal, you should go back and doubt your diagnosis. Are you dealing with an infection, or could it be a tumor, for example? Okay. So WBC count, but it's the least useful of the inflammatory markers because we know it's got a low sensitivity. You can have elevated WBC counts due to a variety of reasons. But if it is exceptionally high, then it is more significant. ESR is a sensitive marker of infection, though it's got a low specificity. So it really doesn't tell you whether it's a pyogenic infection, whether it's a urinary infection, whether it's some other infection somewhere else. But it's a good marker for therapeutic response. So if the ESR falls with treatment, that tells you that you're probably on the right track. And a 25% reduction after a month of treatment is a good prognostic marker. And 50% with no change in ESR also have good outcomes. So ESR is a little slow to come down with, whereas CRP, which is elevated in a large number of patients with spondylodiscitis of tuberculosis and pyogenic, there's a better marker. It returns to normal faster, so you know whether your treatment is working or not. And it's a better marker to monitor treatment response also. So this is probably the first line of blood test that you get. The question is, should we get any blood cultures and urine cultures? If you're suspecting pyogenic infection, worthwhile, because see, the thing is, you can do test by test by test, and then it will take a long time. We know the cultures will take 72 hours and things like that. So it is important not to do them sequentially, but probably to do them simultaneously, depending on what your clinical diagnosis is. So if you are suspecting a pyogenic infection, it may be worthwhile getting a blood and urine culture, because you may be able to pick up a bug in the blood and urine culture, which you may not be able to pick up with your biopsy also. Okay. There are a lot of tests that you should not be doing, and these are predominantly the serological tests. They're terribly popular. They've been, this is the guidelines from the government of India. So inaccurate serological tests for the diagnosis of TB is actually, according to this, banned by the government of India in public interest, because they are not very accurate. And one of the most commonly done is this interferon gold, and now there is this quantiferon gold plus, which is supposed to be highly accurate. So Manto is the other one. A lot of patients have Manto tests. In our country, it's a very doubtful value. Most of us have been exposed to tuberculosis at some stage, and there's a high false negative also because of either disseminated tuberculosis, high fevers, post-viral infections, Some on steroids may have a false negative. So Manto is probably not the way to go. The quantiferon TB Gold test can diagnose Mycobacterium tuberculosis complex of various types. It's an alternative to the tuberculin skin test. So what it does is it picks up the interferon gamma, which is released by the T cell. So it's also called the IGRA, or the interferon gamma release assay. It does not distinguish between active and latent tuberculosis, and that is the big problem with it. So it is not an accurate test and should be avoided. So avoid serological tests. The ultimate diagnosis of tuberculosis is microbiological. So whatever you see clinically, whatever you see radiologically, the ultimate diagnosis is going to be microbiological. Whether you can actually see whether you can identify it on a gene expert, or whether you can actually see the bacilli growing in TB culture. So that is those are the tests to be done initially, and those are the serological tests are the ones that you should not be doing. Yeah.
Okay.
More than a question, it's a comment.
Yeah.
That these tests have low value. Why do we keep shouting over rooftops that don't do Mantu, don't do interferon, don't do? Because we are an endemic country for TB, and these only show a host response. They don't show the bug. So all of us will be positive. But if you're a Japanese citizen living in Hokkaido, and your Mantu is positive, there's a very high chance that you have TB. I hope you understand that difference.
Yeah.
All these tests show that you have been exposed to TB, not that you are infected or you are having an infection of TB. So there is a difference between infestation with TB and infection with TB. So what is the infestation rate of TB in Indians? There are 250 people here. How many of us do you think have TB within us?
Latent TB.
Latent TB, not TB infection, but TB bacilli inside us. 200 of us. So 200 of 250 we are all having. So it's called the human biome nowadays. Humans and bacteria love living happily with each other in good harmony. Like Abhay said, you get diabetes, you get stressed out, you suddenly decide to fast on one of these very famous fastings. You won't eat for 16 hours a day, and then suddenly you will get TB because your immunity is coming down. So that's why in our country it is different from
the West.
From the West.
So because if you're traveling overseas sometimes and actually visiting some medical centers overseas, you are expected to get a Mantu done.
Yeah.
And that becomes a bit tricky for people from India. Yeah. So those are the basic first line investigations that you do when you see a patient with a suspected spinal infection based on the clinical examination and the radiological examination. That's the first line. So what do you do next?
Yeah. Okay, good. Thanks very much, Thomas. So can you just put this on? These TB people usually are very poor. I mean, they're struggling for medicines. And, the last thing they require is some 10,000 rupees of unnecessary investigations. And that's why the government of India has made a very, very clear notification that it is not only not necessary, but they have given a very strict implication, has imposed a ban. That's very important. It's even considered to be the level of it is not legal to do all these tests unnecessarily unless you have a need to do this. Okay. So another two things I'll just go because we are a little short of time. How many of you notify your health authority when you diagnose a TB spine? Yeah? But that's only less than 20% of the people. It is a legal requirement to notify your health authority when you have a TB disease. It's very important. It's a medico-legal necessity that you should inform this thing, and you should also have to do this. So since 2012, TB is a notifiable disease in India, which means all cases of TB diagnosed either in the sputum or chest or X-ray or laboratory radiology or even clinical judgment. That's the most important thing. Even if you suspect a patient to have a clinical judgment, they have to be reported to the public health authorities, because this is very important, because the government has to take a lot of effort and they need a lot of data to change their government policies, and then you must always notify your health authorities. Also make sure that you investigate these patients for pulmonary tuberculosis. Yeah? Sir, why do you think you should investigate a patient for pulmonary tuberculosis? Quick, man, you should just come out with this. You should take out the mental, it should be like a conversation. You should take out the mental attitude that somebody is cornering you with a question. If I simply ask you outside the room, you will tell me this answer. So, spinal tuberculosis is not a community disease, okay? So, a lot of patients come and ask, sir, my husband has got spinal tuberculosis. Is it okay that we can live together? Is it okay we can have sex? Is it okay I can now become pregnant? It's very important, you're newly married and then husband or wife has got spinal tuberculosis. So what happens to the household? So you can boldly say them, spinal tuberculosis is not infective. But 15 to 18% of the people have pulmonary tuberculosis associated with spinal tuberculosis, and then that becomes a community problem, especially if they have cavitation and they are an open case for TB. Because even if such a patient is admitted in your hospital, you and all the nurses and the theatre, every people become very susceptible to this thing. So make sure that these people are listening. So in the next 15 minutes, I will just tell us, like we had a excellent radiology talk on what you should see for diagnosis and how to confirm diagnosis. But we also as a surgeon look at x-rays, MRIs and CT, isn't it? And so from a management point of view, what should you see when you see into this thing? So number one, all of you postgraduates and young doctors have to first know the difference between number of vertebral bodies involved and vertebral body loss. Okay? The radiologist will report saying extensive spinal tuberculosis involving multiple vertebral bodies. And there they are counting at the number of bodies which are showing a signal intensity change or a destruction or an erosion. But as a spine surgeon, we are not worried about the number. We are more worried about what is called the vertebral body loss. Vertebral body loss means in the percentage of, if you divide one vertebral body as 1/10 into 10 equal parts, then each of the vertebral body which is involved, you have to find out how much of the vertebral body has been lost, and then you should count all that together, and then you will get a factor which says what is the vertebral body lost completely. Yeah. So here you can see that what is the number of vertebral bodies involved here? It is 2, isn't it? So you have 2 vertebral bodies involved, T8 and T9. But when you calculate the vertebral body loss, it is T8 is destroyed by 0.5 and T9 is destroyed by 0.7. So the total vertebral body is 1.2. Okay? Whereas the number of vertebral bodies involved is 2. Your total vertebral body loss is 1.2. So why is that important? I'll ask a non-spine surgeon. Santosh, what do you think why is vertebral body loss important? Because your collapse, isn't it? So the stability depends upon your anterior vertebral column, and how much the vertebral body is going to collapse depends upon your vertebral body loss and not on the number of vertebral bodies, just showing a signal intensity change. So a good example is this patient, what we saw first. Here you can see that number of vertebral bodies involved is 6. Multiple vertebral bodies are showing small erosions. But if you actually calculate the vertebral body loss, this one is taken as 0.9 and then 0.3 and 1. And for this, when you calculate, you should always look at both the coronal and the sagittal view. And here, this vertebral body, you can take it as 90% gone. But here you see this vertebral body shows a big cavity here, but the lateral walls are quite normal. This is very important. Another thing you see when you are a surgeon, that whether the cavitation is in the middle or there is a complete loss. An anterior half of the vertebral body lost is a risk because it will involve kyphosis. It will involve a collapse. But if you have the anterior wall and it is only a mid-body collapse like this, you are not very much worried. So all these you must take it very carefully, because if you are going to do a surgery and this patient actually requires a surgery because there is a gross collapse happening like that. Now if you go and remove 1, 2, 3, 4, 5 vertebra because they are all involved and you are doing a massive debridement, what will happen? That's a terrible loss, isn't it? Anterior column. And your reconstruction becomes very difficult. And whenever you cross more than 2 vertebral bodies, your reconstruction failure becomes very high. So now if you look at it, you know that all that you need to do is that you need to stabilize, and then we did a spinal shortening and he becomes okay. So that is the importance of vertebral body loss. Another example over here to show exactly what is the difference. What is the number of vertebral bodies involved? 1, 2, 3, 4, 5. Yeah? But the vertebrae are not destroyed. So the vertebral body loss is 0.3, which means you don't need to operate, isn't it? I mean, a conservative treatment will be very good. So the second important thing that you should look at when you as a surgeon are looking at this is the pattern of destruction and whether the bony contact has established. So I just drew this morning and took a picture. So these are the 3 stages by which it's called the natural history of spinal tuberculosis healing. There is destruction, there is collapse. Healing occurs by the normal vertebra above coming into contact with the normal vertebra below and then consolidating. Okay, this is called the natural history of spinal tuberculosis healing. Now, you may see this patient in this stage or this stage or this stage, and that is going to actually determine what is you're going to be in them. And this is exactly what we published many years ago. This is a paper which is very, I'm very fond of this paper because this was my first publication ever. So, very widely quoted also. You can see depending upon what stage it is, and then you can see if you put the initial vertebral loss and the final gibbous angle, whatever may be the stage, your final gibbous angle comes to expected level depending upon what is your vertebral body loss. Okay. So 2 good examples. Now here is a patient. In what stage is he? He has already come into contact here, isn't it? So body to body contact has happened, and if this kyphosis is acceptable to you, then all that he would require is a chemotherapy. And that is exactly what was done, and you can see that has nicely healed over here. And this decision was facilitated by the fact that you saw the patient when he has already stabilized. That's very important. Another example over here, you can see that this is actually a fusion mass of 2 vertebra. 2 pedicles are over here, but they have completely fused and stabilized, isn't it? So you now think, is this kyphosis acceptable to you? If it is not acceptable, then you need to do an osteotomy. And that is a discussion that you have to enter it with the patient when they don't have any other problem. Now, you also need to see the opposite of what the last 2 patients seen is this patient. So in what stage is he? He is in destruction, isn't it? He has not yet fully collapsed, partially collapsing, but there is a lot more that he is going to collapse. And this patient's kyphosis, you know, is going to increase quite a lot. And so you should make good. If you don't want that kyphosis, then he will heal with spinal ATT. But if you don't want that collapse, then you have to. And this is something very dramatic, isn't it? Multiple vertebral bodies involved. And still there is no resemblance of, actually sometimes these half destroyed, everything gets pushed inside. This vertebral body will come and collapse on this vertebral body. And that's called the buckling collapse. So if you see this pattern of collapse, it is not just a radiological report for you that very extensive spinal tuberculosis present. You need to look at it very, very carefully on how many vertebral bodies, where is the normal, and what is the expected pattern of healing. And this will actually come and collapse here, and this patient will get about 140 degrees of kyphosis in the end. And it's much easier to treat this patient now than after you get into a 140 degree. Okay, fourth point when you see your radiology you should know is the difference between kyphosis angle and deformity angular ratio. Anybody knows this? What is deformity angular ratio? Okay, the deformity angular ratio is defined as the curve magnitude per level of spinal deformity is a combined measure of both Okay, if this looks complicated, I'll say, so a patient can have 60 degrees of kyphosis because two vertebrae are gone. Okay, two vertebral body loss is giving 60 degree kyphosis. So each vertebral body level is giving 30 degrees. Another patient who has got ankylosing spondylitis has got a 60 degrees kyphosis, but the vertebral segments involved is from C7 to L2. So each vertebral segment is accounting for 6 or 7 vertebrae. So this is the actual difference. Now if you can see here, this patient has got a 80 degrees kyphosis, but the number of vertebral segments involved is 17. So the deformity angular ratio is only 4.7, which means there is no acute angle or there is no sharpness to this deformity. That's what Yang called. There is no sharpness to this angle. And so when you correct this deformity, the chances of him getting into a neurological deficit. How many ankylosing spondylitis patients like this you see with neurological deficit? Almost never, isn't it? Because their DAR is very, very low. But these patients will get into a neurological deficit, and the incidence of neurological deficit post-operative or intraoperative is also very high when your DAR ratio goes more than 20. Okay, so that is also very, very important. So there you have to differentiate between this we have very well described in this paper. Now if you see the same thing, 40 degrees due to one level and 40 degrees due to two level, so your DAR becomes 20 degrees. So in other areas it may become more complex. As you can see, very, very severe deformity, 106 degrees kyphosis involving 3 vertebrae, so your DAR is 35.3, above 20. So the chances of this patient getting a neurological deficit later is also very high, and the chances of an intraoperative neurological deficit also is very high because there is a huge sharpness to this internal gibbous and the spinal cord is clothed on the apex of the deformity. It's a 6 spinal cord and the ratio. So whenever you are operating on any patient with a DAR greater than 25, be very, very careful because, and of course these are all extreme examples where your DAR is something like 45 and all that. It's a no touch situation where you can almost expect a neurological deficit when you operate. The last thing that you should see is something very important. Anybody here? What is happening? Can I ask somebody to read? Anybody? I'll get a coffee because this is also one of my favorite topics. So that itself is a clue. So what is happening here? Anybody can read here? Yeah, go on. Toppling of the vertebra. So he's just finished a fellowship in Ganga Hospital. So that's it. So most of us when we see here, what would we see? We are concentrating only here, isn't it? So we are saying that this is almost toppling. He also said it's toppling. There is one more vertebra here, 2 complete, so it is toppling. And you'll always, toppling means that the anterior surface of the upper vertebra will topple and come into contact with the superior surface of this vertebra to consolidate. But what allows that? It is the facet joint dislocation. Okay. If you are not able to see this very clearly like this, one more clue for you is when you see a axial view. If you are seeing two vertebrae like this at any time, you can be 100% sure that the facets are dislocated. This is a very common finding whenever the spine at risk. When we described the spine at risk, we looked at only plain radiographs. But if in your MRI or in your CT, they are providing you the the axial cuts, and you get a picture like this where two bodies are found, invariably you will find that the toppling has happened and also the kyphosis has increased. So this is possible by facet dislocation, and you should always in spinal tuberculosis look at facet dislocation, especially if it is a pediatric spine. Pediatric children are prone for facet dislocations, and you should know that in the Madras study of spinal tuberculosis, 90% of patients who had a deformity greater than 60 degrees were all the result of childhood spinal tuberculosis. You might see them when they are 21, when they are 32 or something, but if they had a deformity of greater than 60 degrees, it was always invariably a childhood spinal tuberculosis because the facets dislocate, and this we call it as the functional failure of the posterior column. I'll just hurry through this because we are always looking at the anterior column but not looking at the posterior column. And posterior column destruction we think happens in tumors and other things, but we don't recognize that it happens in progressive kyphosis. So you can see that there is a progressive kyphosis over here, and then you can see that two facet joints are completely dislocated. Now when this happens, you can see that there will be a terrible progression of kyphosis very fast. So this is something that what you need to do. This was a part of my PhD thesis. So when you do a FEM analysis, you find that when there is a collapse and there is a good contact on the anterior side and your facet joints are intact, the mechanical stress at the end plates is only from 1 to 2 MPa. And so you see then these patients actually have these small vertebral bodies actually start growing very fast during their growth spurt, and they correct their deformity. So that is a good effect when the facet joints are intact and you have a large area of contact. In contrast, if the facet joints are dislocated and there is a point contact like this, from 1 MPa it increases to 16 MPa, and anything that crosses 6 MPa, the bone and the cartilages start destroying, and so you will find that these patients, they actually start progressing. You can see that this patient is 40 degrees kyphosis 3 years after treatment. That means it's fully healed, but at 15 years he presented back with 180 months, 80 degrees, 115 degrees, not because of recurrence of disease, but because of the high pressure, the growth plates did not work. And this will, when your facet joints are dislocated, you see D11 vertebra is completely normal, but these two facets are dislocated. Patient is completely cured of tuberculosis, but at the end of 8 years, you can see that this normal vertebra gets completely atrophied like this because it cannot stand the pressure of that over here. So facet joint dislocation is another thing that you should see, and this is actually the one that allows one patient like this to become like this and to become like this. And when 2 or 3 facets are dislocated, then you can see that the anterior column and the posterior column both are destroyed, and these patients get what is called the buckling collapse. Buckling collapse means that there is a total collapse over here, and the entire upper segment and the lower segment are converted to 2 large secondary curves. And if you take a coronal view, you will get this view, and you get such sort of horrible deformities over here, which Boachik termed as omega deformity, and we called it as the anaconda deformities. So these are the few things that you should actually see when you see the MRI and CT. So the radiologist report actually confirms the diagnosis, it differentiates the infection, and it tells you the diagnosis and confirms, but we need to actually look at something in the form of surgical point of view. Yeah. So if you have confirmed all these things, one of the things that we need to do is a confirmation of this. And how do you all confirm? So how many, I'd like to ask Abhay and Thomas. Let's start with Thomas. Thomas, in the case that we showed, large epidural abscess, everything all there, multiple distractions. Madam showed 10 points why it is spinal tuberculosis. So the patient wants to know, should I start treatment or should I need biopsy?
So, I mean,
Now, whatever you do, you can say. I mean,
yeah.
like,
So, the ultimate diagnosis of TB is going to be microbiological. So, the role for empirical treatment for tuberculosis is, I think, in today's day and age, is very limited. I think you can easily go wrong with empirical treatment. So, I think it is mandatory to get microbiological diagnosis. So, if you have a patient who's got a deficit and you don't want to wait for a biopsy, well, you can go in and operate. At the same time, take material and send it for histopathology and whatever tests you want to do. But if you're planning to treat them non-surgically, then it's mandatory to do a biopsy.
even if it is like this, you will say anything, yeah? So this patient. The other problem is, patients say, I have already been on 1 month of ATT. Now, do you want to me a biopsy or not? Abhay, what do you do?
So the deal about biopsy is that we may be very, very confident. We have great radiologists who can absolutely stamp and say that this is tuberculosis based on so many findings, but they can't predict the germ, right? So even if you're totally sure of the disease, what about the type of disease? And now with the 10% prevalence of MDR-TB, you cannot be absolved if you don't do a biopsy, mainly for culture rather than histology, right? So you may find the bug, but you may not find you may find the histology, but not find the bug. I think that's the
I think actually I wanted to bring home this point only. So radiology may actually tell you a lot about 99% accuracy this is spinal tuberculosis, and you also feel that there is spinal tuberculosis. And if the patient has not got a neurological deficit or severe pain, many times you may also be tempted to think, okay, what is wrong in giving 1 or 2 months of TB? Then we can find out. And that's what is happening in 90% of the places. So we have to accept that the possibilities and problems of getting a biopsy safely done in our country is also huge. But the biggest advantage of doing a biopsy is you know the character of the germ. And as the incidence of MDR is increasing, a biopsy is not only giving you tuberculosis diagnosis, but also is giving you very, very valuable information of, is this germ resistant or not. Now, in these medical legal issues, suppose you put them on for 3 or 4 months, the disease progresses, and somebody tells, oh, you didn't have a gene expert, then you are in a little bit of soup. So how do you do a biopsy? Now, slowly, before we used to do biopsy techniques, but now the radiologists have completely taken over us from biopsy. No admissions, they just come, the radiologists do. So madam is going to tell in the next few minutes how to pearls of doing biopsy, and then we go on to principles of ATT. Yeah, after that, yes. Finished? Or?
So while she's setting up, I'm going to come in and say that there is still a rule of
You are-
treatment
yeah,
in
but
endemic setting. Especially many of us don't have access to biopsy. That's not a good enough excuse, but you have to create that access. But let's say that now you're creating that access. Maybe you're teaching your radiologist. But at this point, what do you do? So in case it's a situation where you're in a remote place and there is no access to biopsy, which is not a valid excuse, if you're planning empirical treatment because you're so confident, just make sure you take your patient into confidence. You don't tell him that this is TB. You say that we ideally need a biopsy. Right now, we don't have access to biopsy. So if you mutually agree, we'll take this chance because there's an 80% chance that we're going to be right. Do not tell him that I think this is spinal TB and let's start treatment, because then you'll be on the dock. Let him accept that we are guessworking and then guesswork with you.
Yeah.
Yes.
Who should be doing the biopsy? Should the surgeon be doing it? Should not everybody has got Dr. Pushpa. So should the surgeon be doing it? Should the interventional radiologist be doing it?
So I have an answer for this. Doing a biopsy in an oncological setup is different from doing a biopsy in an infectious setup. So when you do a biopsy in the setting of oncology, 100% if it is going to be an open biopsy or where there is an incision involved, it has to be by the primary surgeon. And even in oncology, if the radiologist is doing, they should know where they are going to go through and what is the ultimate incision that is going to be for the excision of the tumor. But for infection, I think whoever can get a good tissue. I mean, you just need a tissue.
I think Dr. Thomas's question was loaded in favor of people who don't have access to a good radiologist, because an inexperienced radiologist will go for the easiest spot for biopsy. She or he will find pus pocket and take it out, and that may be a failure, and that's what he was leading up to. So I think the correct answer based on his lead question is that if you're working in a remote place with, again, the radiologist is not experienced, you go there to the CT gantry. I have done that in Bombay in Hinduja Hospital for at least a couple of years before a radiologist got good at doing it. And I sit there with the radiologist and tell him where I want the biopsy from. So he's the technician, you're the guide as to where you want the sample from. Drive him into doing it, him or her, and then in a few turns they become proficient at it. I think that's the right way to do it.
And you also need to be sure that the tissue that has been taken is representative and it is sufficient. So otherwise there is always a war of swords between the pathologist and the radiologist. Tissue, suppose the pathologist after 3 days comes with a report. Tissue not representative, tissue not sufficient. And the radiologist is 100% sure that they have taken a good tissue. So you need to be balanced on that also. Essentially, you need a good team. Yeah.
So basically, we do biopsies and we can do drainage procedures and pigtail insertions, and in rare cases we do need cyanograms in spinal infection. We actually do CT or USG guided biopsies. USG guided biopsy is actually when soft tissue is well visualized. There is lot of pus and we are able to see this collection or paravertebral changes very easily on ultrasound. Then it is the best way to do biopsy, because you will see which is the solid component which has vascularity, which is a necrotic component. You avoid the necrotic component and you take biopsy from the wall and the viable part of the soft tissue. So that becomes very easy in CT scan. Ultrasound. In CT scan, you should be you should be planning the biopsy very well. See the MRA before you plan the CT scan, because in MRA you'll have to see where is the granulation tissue, which is the best part to be biopsied, and which bone is, which part of the vertebra is actually involved without any abscess. That part of the bone you are going to take the biopsy from. Okay, if you see literature, it has told that in up to image-guided biopsy can yield up to 48% of the cases, it can yield the result, as compared to surgical biopsies, which can yield up to for 76%. So you can consider image-guided biopsy as a safer and less invasive mode of doing biopsy, and hence it comes as a first line of management. And whether we should biopsy patient with prior antibiotic exposure, yeah, we can still do biopsies when patient is already given antibiotic treatment. And whether CT is better and fluoro is better, actually both are better, but CT, I think it is, you'll be able to see the changes very well in CT and you know where exactly you are going in. So I think CT is go-to modality when we have to do image-guided biopsies. Disc and paravertebral soft tissue will give better yield as compared to bone and end plate biopsies. So if there is soft tissue component and if the soft tissue component is very solid, I will go for soft tissue biopsies, and if not, I will go for disc and as well as the vertebral biopsies. Coming to the instrument, so we use normal T Jamshidi. So this is how it looks like, and now we are using something called as extraction cradle. So this has a nice extraction pocket here. So once you introduce the CT guided biopsy into the bone, you can actually introduce this particular extractor inside the biopsy gun and take out the tissue. So by this you need not actually again and again go in. So once you go in into the bone and then keep on taking out the bone pieces through the biopsy gun. So this is something new we have introduced. Not very new, but yeah, this is very useful. And for the soft tissue biopsies, we use single-use biopsy guns. You can see you can use a safe coaxial. You can place the coaxial wherever you want to enter, and then you can take multiple biopsies using a biopsy gun. So this is called coaxial, and this is a biopsy gun over here. Sometimes what happens, we need to go through the bone, and bone will have lot of soft tissue components. So there is a lytic area, and then there is a thin bone around it. So you have to break the bone, and then after you break the bone, the bone biopsy gun will actually not give any soft tissue. That time what we do is we introduce soft tissue biopsy gun through the bone biopsy gun, and we take multiple biopsies, soft tissue biopsies through the lytic component of the bone. So various approaches we use when we do CT guided biopsy. One is transpedicular route. So we go through the pedicle. So this is actually very safe unless you enter the medial border of the canal. But otherwise it is very safe. So once you cross this canal area, then you are very safe. There is less chance that you will injure any major structures in and around the vertebra. How exactly you choose transpedicular? So if you see here, in this route where I have marked. So if you go through this area, there is mainly sclerosis, there is no lytic areas or destruction. So this will not yield much as compared to the other area where you can still see there is lot of destruction, and also there is some amount of in between normal bone. So there will be lot of, if you see the MRI of the same picture, there will be actually lot of changes in the entire bone. But you should actually go through where there is much of destruction and the normal looking bone in the CT. So if you involve the biopsy tract through and through of this area, you will have better chance of getting a good sample. So that's what was done in this patient. In the same patient, I did disc biopsy because the vertebral destruction was not much, and I wasn't sure. So because the disc was also showing a lot of changes, what I did is, so if you have to enter the disc, this is the better route. Here you see there is lot of bone, so I can't enter through my soft tissue biopsy gun here. So what I did, I introduced my soft tissue biopsy gun through the other route. So that is how you decide which biopsy gun and which route to use to do a soft tissue biopsy, especially disc biopsy over here. So this went exactly into the disc, and then we could take disc samples. Sometimes we have to take costotransverse route, especially in the thoracic spine. Here you can see the entire vertebral body is involved. The pedicle is also involved, and pedicles are very thin. So if I use a thin bone biopsy needle, the amount of tissue what I get will be, sometimes it will be very difficult to go through a thin pedicle. Also when it is all destroyed, I will not have a proper control to go through the destroyed pedicle. So it can slip in any direction. That is very dangerous. So what I do is I choose a costotransverse. So this rib head will give me better support to go into the vertebral body and take a longer segment. So this is a costotransverse route. So rib is giving me nice support. Transverse process is not allowing me to go into the canal, and I can take the entire vertebral body easily. So I will enter from the skin, go through the transverse process and the rib, and I will take the entire vertebral body biopsy. So in one go, you will get a large piece of bone chunk, and you will get a better sample for the patient. Most of the time we'll have to go in the paravertebral aspect also. So here you can see there is a bone destruction. It is very much in the center of the vertebral body. Rest of the vertebral body is showing signal change, but I don't know whether this is just a reactionary edema or actually infected bone. So if I go through the transpedicle, I'll be going through the intact bone. I don't want to do that. That's when I use a paravertebral route. So what I did was, I came through the skin, came from the paravertebral region. I will use I will not go from the center. Rather, I'll include that lytic area, but I involve the either borders, like anterior and posterior border of the vertebral body, go through and through and take the samples. So you avoid taking this part in the center, which can be necrotic. So use the part of the vertebral body here also and part here, and in the center, the necrotic component is also included. So the pathologist will get the picture of the entire thing happening in the vertebral body. So this is paravertebral root. So here there is a chance of injuring the nerve root, so you should be very careful. It is not as easy
time
and
is your-
careful as transpedicular biopsy. So that is paravertebral root. Sometimes we will have to do pre and paravertebral soft tissue biopsies. Again, if you see here, this is all solid, so it is showing solid enhancement here. Vertebral body is not actually involved, too much involved. And if you want to go on this side, it is very near to aorta, and there is a necrotic area here. So it is better to include this area for a biopsy rather than going to this area, which is actually having necrotic area as well as it is very near to aorta. So this was the, and whenever you are doing prevertebral or paravertebral biopsies, especially in thoracic region, you should be very careful with the adjacent lungs and pleura. It can result in pneumothorax. So we should be careful about that. So this patient underwent a paravertebral biopsy using a coaxial system. This is another example where you can see the vertebral body destruction is there. Again, I am not sure whether it is just an edema or actually the vertebral body is having some germs in it. So what I could see is there is a thin area of granulation tissue and collection. So I want to aim to that. So when I see the CT scan, you can see there is a thin rim of bone all around that whatever whitish thing I was seeing in MR. So what I did was I introduced a bone biopsy gun, and then I used a soft tissue biopsy gun through that to get the sample from this. So so that again we can use both the biopsy systems to get a better tissue. In abscesses which are very much liquefied, and if it is more than 150 ml, it is better to insert a pigtail catheter because it will give better results for the patient, and it will have a quicker relief, and you can take out as much as pus as possible in within few days. So we use pigtail drainage for most of our large abscesses, where you can see that you do a small incision, then place with the help of the introducing needle, you place a guide wire. Serial dilatation will be done through the skin tract, and then finally you will insert this pigtail into the abscess cavity. So this was one case where again this is showing the guide wire here into the pus cavity, and then over the guide wire we have dilated the skin tract and introduced the pigtail catheter. So after 2 days you can see it has already completely collapsed. This was a very interesting case. He's a 39-year-old gentleman with complete recovery of thoracic tuberculosis, thoracic spine tuberculosis. But he kept on presenting us to us with discharging sinus in the lower flank. Not even at the region where he had tuberculosis, but way down he was having discharging sinuses. So we didn't know what exactly was happening, because when you look at the MRI spine, you can see that the vertebral bodies are showing fat signal. There is no fluid, very little fluid signal intensity, which can be seen in healing or healed tuberculosis. So there was no active disease as such, very evident on MR also. And when we only thing what we were seeing is a little bit of pus formation in the paravertebral region at the same region, but we were not sure why this paravertebral abscess is keep on coming in the region of healed tuberculosis, and also why he is having discharging sinus very much lower down in the right flank. So if you see again the serial, when you came down, there was no continuity of this paravertebral abscess and his draining sinus. We could on and off we could see one sinus tract like this, but we didn't know whether that is the source of infection. So lower down you can see there is nothing lower down actually, but his sinus was way down near the pelvic area. this was the CT scan. You can see a small sequestrum, and then this is all completely fused, sclerosed. So it looks almost like it is healed. Then we did a sinogram from the lower down, from where he was discharging. So this is a video of that. So the flank area, so it was very much down, and then you can see it is going all the way to the thoracic region. So the contrast is going way up, and it is pooling around that sequestrum which we had seen. So sorry. So that sequestrum was actually giving rise to repeated infection in this patient. So all that contrast was going around that small bit of sequestrum. This patient also had bronchopleural fistula. So from the pleura and paraspinal abscess, it was going into the bronchus as well. So there were two fistulas, one in the lower flank and another one going into the lung. So this was a very interesting case. After the sequestrum was removed and the stabilization was done, he completely recovered from this discharging sinus problem. So, so this is an X-ray picture. You can see the sinus was somewhere way down in the flank, and then the sinus tract is seen up to the thoracic level, and it is also going into the bronchus. So this was a very interesting case. So to conclude, when tissue is an issue, image-guided biopsy is less invasive initial approach for tissue sampling. Complication rates are very less, and also we can consider to do drainage and pigtail insertions in large abscesses, which is very helpful for the patient, and it helps in faster recovery also. Thank you.
So do you all think, I have the mic? So do you all think it's an advantage or disadvantage to have a good radiologist? Yeah, but they also put you out of work in many of the areas that you do. So, but if you're, they save you a lot of orthopedic theater time, admission time. Most of the time when you're doing transpedicular, many of these patients require an admission, a small anesthesia and all that. But CT scan procedures are run so smoothly, and so it's a very, very big advantage. So Thomas will now tell us, you've got the tissue in your hand now. So what do you do with that tissue? So as Thomas is going, I'll ask one question to Abhay. Abhay, if you're a patient who comes to you and you need to do a biopsy, he has already been on antibiotics for 1.5 months, ATT. Would you just go ahead and do a biopsy, or would you wait for some time? This is one commonly asked question in all the conferences. Should I stop antibiotics for some time before doing the biopsy?
So the statistic is that AKT means that chemotherapy sterilizes tissue within a week, which means that once you're on AKT for 1 week, the chance of your biopsy turning out positive goes down significantly from 90% to 30%. That's what I've been told. So at the same time, the statistic also is that if you've been on AKT for more than 6 weeks, by stopping AKT, the chance of you getting a positive culture is not high. So the short answer to the question is there's no point in stopping AKT before a biopsy. You just go ahead and do a biopsy. The good news here, as Thomas will tell us, is that now there is LPA2, which is available, where even if you've been on AKT for some time, your chance of getting a culture right is very high.
Thanks, Abhay.
So Abhay has been told by his wife to talk about LPA surely. That was his last night instruction. Yeah.
So the dictum for biopsy is, this is an oncological dictum, is that you should culture what you biopsy. When I say biopsy, it's histopathology. And whatever you take for histopathology, you should send for culture. So don't go with the closed mind saying that this is tuberculosis or this is tumor. Go with an open mind. Whatever you take should be sent for culture and should be sent for histopathology. That is the dictum, and it should be done for every single case. Okay, so what test do we do on a biopsy material? So we should do an aerobic culture. You will get the reports within 48 to 72 hours. If you trouble your microbiologist, you can probably get some preliminary reports early. A gene expert for tuberculosis, and a histopathological examination. These are the three most important and basic tests that you do on every biopsy sample. Whether you do an anaerobic culture or not is variable. We normally get an anaerobic culture done. The problem with the anaerobic culture is the anaerobes are slow growers. They need to be kept in culture for longer periods of time, and sometimes you need to send them in different media to the lab if there is a significant delay. So, but there are, we know that 7 to 10% of our so-called pyogenic infections are anaerobes, and sometimes we don't pick them up because we don't look for them. So, doing an anaerobic culture is also an important thing. So, yeah, we all know about aerobic culture, so I won't go into it. Gene expert has, I think, probably been the lifesaver, and I think the government actually subsidizes laboratories to do it at a very, very low cost, just so that we pick up more of them. So it identifies the Mycobacterium tuberculosis DNA, and it also gives you shows you resistance to rifampicin. So it shows you resistance to one single drug, and that rifampicin resistance is used as a surrogate marker for multi-drug resistant tuberculosis. Okay, so because the most common resistance is to rifampicin, and that rifampicin resistance is just used as a surrogate marker for multi-drug resistant tuberculosis. It's got a high sensitivity and specificity. It's WHO endorsed. Typically, the test takes around 2 hours, but in large hospitals where they pool in many samples, in our hospital, we get it within 24 hours. But I think the test itself takes 2 hours. So gene expert is mandatory, aerobic culture is mandatory, and the histopathology is mandatory. So histopathology is a gold standard in the clinical setting. So you see the typical tubercles, which is the epithelioid cells surrounded by the lymphocytes, central necrosis, and the peripheral giant cells. In addition, your histopathologist can also pick up fungal elements. Sometimes you may have fungal osteomyelitis, and they may be able to pick up fungal elements. And if they are significant, and you can start them on some antifungals also. And if it's not tuberculosis. This is a newer test. I haven't gone into the more high-tech ones that Dr. Abhinay is talking about, but this is something that our hospital has introduced recently, probably in the last year or so. It's this 10-color gene expert test. So this is to be done when you have a gene expert positive. Then you do a 10-color gene expert test to look for resistance to other anti-tuberculous drugs, predominantly isoniazid, the fluoroquinolones, and the second line injectables like your amikacin and kanamycin and others. So if your first gene expert is positive, then you can look for complete drug resistance using this 10-color gene expert test. TB culture is probably the gold standard, because if you can actually grow the TB bacilli in the lab, well, nothing can beat that. But the only problem is it takes around 12 to 14 days, and this was used predominantly to look for drug resistance. But now with the 10-color gene expert tests, we have that option now instead of a TB culture to look for drug resistance. So you get a culture sensitivity report from the TB culture report. So instead of that, you can use the 10-color gene expert test. Ziel-Nielsen's test for the spine, not very effective, because we know the spinal tuberculosis is paucibacillary. Pulmonary tuberculosis, you'll probably get better positive results with the AFB state. But in spinal tuberculosis being paucibacillary, your chances of picking up the bacilli are smaller. So those are the tests that you do. So biopsy, what you culture. Biopsy means histopathology, what you culture. Culture, what you biopsy, should be one take-home message from this talk. So you should do both. And a gene expert it's available everywhere now. The government subsidizes it. I don't think there's any reason why we should not be doing it.
Yeah. This is an important topic. So anybody has any questions for Thomas?
Yeah.
Abhay, anything?
Yeah, so that I think so. If clinically, and radiologically there is evidence of infection and the gene expert is positive, then I think you should treat it as tuberculosis.
So which is better, gene expert?
Gene expert, the accuracy is very high. Histopathology, it all depends sometimes. Depends on the histopathologist. Sometimes it depends on where you take your specimen from. You may not get the classical tubercles that is
Granulomas.
diagnostic of tuberculosis.
Sir.
Sir, what is your methodology? How do you send the specimen to get the maximum yield of that particular result? How do you send the specimen for the gene expert? Suppose you take the biopsy from the bone, and sometimes you can get from the tissue, and the gene expert and all these things are very good in identifying in the fluids, it is better than that. But in the tissue, when it is mixed with blood,
We send them in normal sterile containers
Sir.
without using any formalin or saline.
So that's the most important thing. You should not mix it in formalin. So we have to have all the theatre personnel knowledgeable about it, that they should not mix it in formalin. Yeah. No, sir, you can just
Five
send it the
samples, 5 samples, 1 in formalin, and rest in empty bottles, sterile bottles.
nothing added to it. Formalin is for HP. So just simply like that. Only the tissues just in the this thing. Don't mix it up with anything else.
Anything on negative biopsies?
Negative. Then it becomes a big issue for the.
Almost 90% of the reports, we are seeing non-caseating granulomas, and gene expert is invariably negative.
So smear positive, gene expert negative is a classic of atypical mycobacteria. And that's not uncommon. Atypical mycobacteria form a colony in most laboratories, and it becomes a contaminant very often. So basically, if it's smear positive, which shows the red dots, but gene expert negative, think of atypical mycobacteria.
But many of them are responding to a routine ATTs.
They will, but their requirement is much shorter. So atypical mycobacteria, you need 3 weeks of antibiotics. So, but you'll end up giving them 1 year of antibiotics, and that's where a good TB expert comes into play. We guys can't use our brain. We don't have that much brain as surgeons. We are just.
Another point, CBNAT comes weak resistance to rifampicin. What should be the line of
Mostly
treatment?
I'll cover that,
It's
but
going to talk
if you
about-
don't mind, I can say that now. That CBNAT, which is gene expert, goes through threshold cycles. So if the threshold cycles needed are more than, I think, 200, 120, it starts saying it's low positive. If it's low positive, there's a very high chance, very high possibility of a false positive rifampicin sensitivity. So if it's gene expert positive, low threshold, means high threshold of many cycles of CT, you can't rely on the gene expert sensitivity of rifampicin. And that's where gene expert ultra comes in, which has now one more column called the trace. So it's low and then trace. And if up to low, it is still sensitive to rifampicin sensitivity. Am I clear?
So weak resistance means we can go ahead with the regular medication.
Yeah, you can't. Well, you're on uneven ground. You should send that sample for LPA.
Okay.
If it's weak positive, you should send that sample for LPA, and until then, think of it as primary TB. Is it clear to everyone? Because this is a problem. Sir is asking a very pertinent question in real life practice.
We had a nurse in our hospital. She underwent fusion. The specimen came weak negative.
Weak negative.
Weak positive.
Weak positive.
So there was difference of opinion among TB specialists. They have advised second line drugs.
That is incorrect, because you can't rely on this report.
Yeah, she was scared of all the side effects and
yeah.
complications.
Yeah.
She underwent only regular medication and she got cured.
Exactly. So because it's unreliable, so you should have sent it for LPA. There's another trade secret at this point, that actually Gene Expert Ultra is the same kit. You just need different software. But the government is stuck with these old kits that are going to expire, so they are not put Gene Expert Ultra as the standard of care. Actually, that should be the current standard of care. but they need to finish those kits. That's why. So in private practice, we never send for Gene Expert. Now we are sending it for Gene Expert Ultra. It is 8 times more sensitive. You need that much less bug to be able to pick it up.
Good.
Just one last question, sir.
Yep.
What if the biopsy comes back negative? So you have a radiological, Dr. Pushpa has said there's a lot of pus everywhere. You've done an excellent biopsy. We know that the pickup rate from the biopsy is clearly not 100%. Clearly not 100%. So you have a patient who's got symptoms. You have a MRI that has got infection, but you have a biopsy that is negative. What would you?
I would beat the pathologist into submission. Because this is such a subjective diagnosis, and pathologists sometimes very casually look at it and say, we can't comment.
Okay.
You go back to the lab, sit on their heads, tell them this is the evidence, I think it's TB. And they'll start looking around and they'll start finding the infection. But if it's biopsy negative and Gene Expert negative, you're talking of something else. Then maybe you're wrong and the pathologist is right.
So what would you do?
I mean, a repeat biopsy. There's no other way.
Repeat biopsy, or do you do something empirically, or?
No, I would repeat a biopsy.
Repeat a biopsy.
Yeah.
I think you'll have to put everything together,
Yeah.
So if I would put on a scale of 1 to 10, clinically, what do you think? It's high on TB. Radiology, you go and sit, just like you go and sit with the pathologist, you go and sit with the radiologist and then talk to them, and then they are saying 100% it looks like TB. And then there is some granulation changes seen, but not so typical of TB. That's what the pathologist writes. So if you put all these, still you may just cross the green mark of starting antituberculous drugs. And then, as Sabai said, you have to go and talk to the pathologist, because very often we just put spine in some, not even a case history or something. We just write one small line and send the biopsy. So they also look at it very, very cursory. So whenever there is a doubt, it's very important that you go back. I just call this as surgical pause. I always tell in our unit, whenever there is, you don't need to treat this as another patient. So there is a problem here, you need to take what is called a surgical pause. You go back and look at everything, whatever you can see in the patient, talk to the pathologist, talk to the radiologist, and usually there will be a common clinical consensus. If that is not reached, then definitely you have to get a repeat biopsy. Worth it. That's it. Okay, good. So we finished 2 wonderful things on tissue biopsy, then what? And then we are now coming into the realms of conservative or surgical therapy. I think we'll go on to that next on when you will operate and when not to operate. But one of the most important things that we know is that the very powerful effect of antituberculous chemotherapy on the healing of tuberculosis. So, you get, now this is a famous statement, everybody knows, uncomplicated spinal tuberculosis is a medical disease. Surgery doesn't have a role in it. And even if the things are looking so bad as this, so you can see this, you can frighten any of your patients into submission for a surgery, isn't it? You explain to the patient 8 levels, there is abscess, pus is there, this is the spinal cord, and you can see that here there is no spinal cord seen, the spinal cord is compressed. The patient and his wife will say, please take him to the operating theatre immediately and please cure my husband. These are all things that you can really frighten your patients by showing them a lot of pus here, everything you can show. But you see that it's completely resolved 100% with ATT. So the power of ATT is really, really good. Now this is a child who has got a huge retropharyngeal abscess. C2 is involved. And this it's a big question of what would you do? Would you aspirate? Would this patient go in for a respiratory shock sometime? Or what is going to happen? And this patient was not even aspirated. It was just given a ATT, and you can see the excellent resolution that happens without this. To have operated on these patients unnecessarily is actually put a big problem into that, isn't it? So you also, when you go in, all these bone will be very mushy. And when you are curating, everything will come off, and then there will be a big defect, and it requires a basically major column. And lastly, just to show the power of this is a patient not of mine. It's actually Abhay knows this patient. This is Dr. Shekhar Bojraj's patient. I don't know how many conferences he has shown this patient. I have shown this all around the world. And what do you think? This, if a Western mind or a Western surgeon sees this, he will be panicky, isn't it? I mean, one vertebral body completely involved, higher level, mobile cervical segment, and there is a big compression over there. Well, you need a brave person like Shaker to put them on anti-tuberculous drugs. And can you just see the resolution and healing? Absolutely, isn't it? I have many more examples of this, which may make you think that surgery for TB is totally unnecessary. But you have to go carefully between instability. The one thing that differentiates there is instability, presence and lack of instability, and the intactness of the posterior column. But you can see how beautifully it is resolved, and this is the moment. Can it be better? No. But you can also see that the Madras study of tuberculosis was one of the highly quoted papers. Ambulatory chemotherapy achieved favorable status equally as radical surgery without any complications of surgery. But for the success of ATT, the success is in the hands of the surgeon. Also, how much to give, how long to give, what is the dosage, and you have to really emphasize. We as surgeons think that it is so uninteresting, and it is not our duty to explain about the need for ATT to the patient. So we just operate and then let a nurse or the junior most doctor to explain about the need for ATT. When I was a resident to Professor Shanmusundaram, I found that with any of these spinal tuberculosis patient, he will call the wife or the mother and say, you need to take these medicines for 6 months, otherwise your husband will get brain tuberculosis and die. He was routinely telling this to everybody, and then I went into the literature and saw whether spinal tuberculosis gives rise to brain TB. Then one day I asked him, sir, it's not given anyway. He said, no, it will never give rise to. But if you don't tell it, anti-tuberculous drugs are so expensive that in 6 weeks they are feeling much better. 2 months they are feeling completely all right. 3 months they will stop therapy. So you need to frighten them out of their wits. And the most important thing is to call the mother or the wife and tell them that if you don't take it for 6 to 9 months, he is going to get brain tuberculosis. And that ensures compliance of ATT. So the success, so we need to be not just surgeons, but we need to be surgeon physicians over here, because even the success of surgery depends upon adequate chemotherapy. So when to give, how much to give, how will you frighten your patients into compliance, and what is the dosage, everything will be told by Abhay.
Eloquently said that your best weapon against TB spine is a good physician who can give correct AKT. And you can't believe how many mistakes we make. And the primary cause of MDR TB in the country or in the world is actually faulty prescribing physicians. That's a statistically noted most common cause. So we are the culprits actually, right? So just upfront is the case that, that this is a case that I have messed up so many times. I think went in 3 or 4 times. As you can see, it's still not a well done case, but eventually it got retrieved by correct AKT given by my wife. Okay, so the uncomfortable truth here is that no amount of good AKT, the good surgery will work unless you have correct AKT. And on the other hand, good AKT or anti-COX treatment can actually salvage a badly done surgery also. And we have come in a full circle now. We had an era when we would be non-operative treatment because we'd have no surgery, we'd have the skills. And then we had aggressive anterior surgery where we would excise the disease. But now we have come back to the era of chemotherapy as the primary line of treatment because we have got great advances in the field of microbiology and in pharmacology. So I'm going to try and cover these, but I'll knock off a few of these because they've been covered. and we'll just go by the flow. So the famous statement is that TB in the absence of grotesque deformity in neurology is a medical condition, right? Dr. Moon, Dr. Tully, they've all said that. But how do you interpret this? How do you interpret this condition, right? Or this statement? So let's put up a case here, and am I allowed to go to the back also? Because back is being ignored. So maybe this group? Are you okay to answer? So that one, this patient came to you with brisk reflexes, walked into your clinic. Would you advise surgery? Conus compression and hyperreflexia.
No, sir. We'll put a ATT first.
Anyone? Thanks. Anyone would advise surgery? So that's a very heartening response, because 5 years ago, everyone would have advised surgery in a group like this. Because one of the indications is neurology, right? Dr. Moon said, Dr. Tully said that if there's neurology, you need to do surgery. And this patient has hyperreflexia. But she walks into your clinic, right? So that's not good enough indication. You can't extend that statement into saying that hyperreflexia is also neurology. We as surgeons tend to do that, and we actually published 50 consecutive patients with cord compression on MRI scan, not just CSF column, cord compression with brisk jerks, but who walked into the clinic. We conserved them prospectively, and 47 of them did not need surgery. So just FYI. Okay, so this is called you say.
No. So Abhay, what is your hard stop for recommending surgery on day one?
So in terms of neurology, for me, the hard stop is a non-walker, someone with grade 3 power or less. I would, I don't have I'm going to say balls to conserve them. I don't have the guts to conserve them. I would succumb to surgery. Having said that, it has happened more than once that people who were non-walkers, I put them up for surgery, but they were not fit. And by the time they got ready for surgery, they became walkers. So they also actually pulled out. But actually, as a clinician, I don't know, Thomas, grade 3 power with cord compression soft.
I would probably go towards surgery, but the other problem is in our practice, we see a lot of patients who come from out of town, from far away, from other parts of India. Now, putting them on antituberculous treatment is always a dicey thing, because we don't know what they will go back and do.
Yeah, so I think
it a couple of times, and they've come back and said, you've done the wrong treatment for me. Because they've developed neurological deficits. So sometimes, I don't know, logistically, patients whom you are not able to follow up on a regular basis should, unless you can really ensure good follow-up, patients with significant cord.
I fully agree. I think my talk is extremely biased from a tertiary care center, Bombay City kind of practice. But I think this brain TB example was great. If you have a patient coming from far away, just tell them you'll get brain TB, and you better. Actually, we admit them. So we admit all these guys. We put them in the hospital for a week, give them actually steroids also, and monitor them and scare the daylights out of them before we discharge them.
So I have a different. I mean, it's almost same like what Thomas and. You have to look at it as a whole thing and be sure that whenever you are taking a tricky decision, a lot depends upon the patient and whether your follow-up is tight on this patient. Because if you're not sure of your follow-up, then a one-time intervention of cure is much better than where you have to look at them. So the way I follow is that if a patient comes and complains or anything about neurology, that means he is aware, his relatives are aware that there is a neurological component. And at that time, it becomes a little risky not to intervene, because if he progresses or something, and there are always so many of your orthopedic friends, if something goes wrong, will later tell, oh, you went with little difficulty and they didn't operate, so that's wrong. So, but as Abhay said, hyperreflexia, extensor of the plantar, but the patient is not aware that he has got a major neurological deficit, is a very good candidate for conservative therapy. The minute the patient points out to you, I am having a little wobbly, I am having a little unsteadiness, I have numbness, that means it has gone into his head, and then it's a little risky to keep them.
We call it darna mana hai. Darna mana hai means don't be scared, just be brave. But that's again to the patient clientele that I deal with. Also, one big important thing is, as a surgeon, when you read the MRI, you should differentiate between hard compression and soft compression. Like when there are white pus pockets, it's in your favor. But when there's a bone that's impinging, don't conserve, right? So can I then ask this table, the seniors, You already saw the case on the right. Dr. Raja showed you that case, but I'm comparing that to a case on the left, which is more than one body involved, and it's a junctional tuberculosis. What do you think is a likely outcome? Natural history. Just guess. I mean, that should be good. It'll be okay. It won't kyphose. Does anyone feel it'll fall into kyphosis? More than one body involved? Junction of kyphosis and lordosis. Some people are nodding, but both of them actually did equally well. Okay, for those who can't see. So what I'm trying to say is that the scope of non-surgical treatment is extremely high. If you go back to the anatomy of this one, there was no present kyphosis. So there was no collapse happening. It was more like a concertina collapse. Dr. Rajasekhar can come in on that. But if there's a concertina kind of a collapse, it will still heal without kyphosis. Again, this is a bit of a guesswork. There's no hard criteria here. All I'm showing you is cases that have healed. So, there's no discussion on that. There's no question. Okay, what about this abscess? Which of you would be tempted to drain this abscess? Put your hands up. How many would want to drain this abscess? The large psoas abscess. How many of you would not drain this abscess? Put your hands up. Okay, that's again good to know, because the past, if you see the S. Das book of surgery, all abscesses need to be drained, right? But that's not true, at least in tuberculosis. We don't have that much experience in pyogenic disease. But in TB, you would drain an abscess if the physicality of the abscess, means the mass effect, is causing a problem, like a retropharyngeal abscess causing you breathlessness, or maybe something like that. But otherwise, you don't drain abscesses unless you want biopsy. If you want, it's one of the easiest place to put a needle in and get biopsy. And from our recent study, we know that abscesses can give you as much data as granulation tissue. In the past, abscesses were, never to be biopsied. But today we get great smear and we get great gene expert on biopsy of the abscess also. All right. Okay. Again, coming back to this, how much would be the predicted kyphosis? How many bodies are destroyed here? As you can see, multiple bodies are destroyed. So ideally, this should have kyphosis. But again, a concertina collapse. None of these have come like that. So they all will heal well. All right. The question of bracing and how long to put them in bed remains unanswered. But the short answer is I practically never brace them and I practically never put them on bed rest. I just tell them the threats of what may increase the kyphosis. So avoid reaching out, bending, heavy impact activities, etc. But anyone who comes walking stays walking. They're never put on bed rest. And I think brace is frivolous because they wear it only when they come to your clinic, but otherwise they don't wear it. I don't think there's any data, that promotes the use of a brace in a potentially unstable spine, right? So the first commandment of non-surgical treatment is that the scope of non-surgical treatment is extremely high. And we need to use that because that's our great benefit in 2024. And we need to use that and not succumb to the threats made by the MRI. You know how the MRI looks, all right? Just moving on next is what about clinico-radiological diagnosis? We spoke extensively about this, so I'm just going to have 2 slides on this. So these were all patients who were on AKT empirically. There are 8 or 9 images. How many of you, please raise your hand, feel at least half of these are tuberculosis? Put your hands up. At least half of these. And how many of you feel none of these are tuberculosis? Put your hands up. The response rate is very low, but none of these were tuberculosis. And now you think back, okay, in a real life situation, you probably would have thought these are tuberculosis. And someone had thought these are tuberculosis and they were sent on AKT. All right, and all the diagnosis is completely confounded. And again, in a closed group, I can say our most senior TB expert has been taken to court by a patient because he put, in good faith, he put the patient on AKT without biopsy and it turned out to be lymphoma. Okay, so you don't want to be in that trap. Even in a village setting, if you're giving empirical AKT, please confide with your patient that you're giving AKT without biopsy. What about these? None of these look like TB, right? But all were actually tuberculosis. So you know what Dr. Rajasekhar said in the first slide. Anything can be TB and TB can be anything. So atypical presentations on radiology of, is extremely high and hence cut the guesswork. The second dictum is that thou shall not make a clinico-radiological diagnosis of tuberculosis. Full stop, dubara mat puchna, however confident you are. All right? Moving on, thou shall start chemotherapy only after biopsy, culture and drug sensitivity test. Now, why is this important? From Dr. Thomas's talk, you know that you need some data before you actually start AKT, not only because there are multiple bugs that look like TB, atypical tuberculosis like we discussed. There are other situations where it's not TB, but it's another granulomatous infection. And there are other situations where it is TB, but it's a non-sensitive TB. So you need to have that data in your hand, and you can't say that ये TB है मैं इसको AKT दूंगा. That's a pretty commonly done thing, and there was some resistance to the idea that there's MDR TB in spine for the reason I told you in the beginning, that it's a non-pulmonary tuberculosis. It's a possibacillary disease. There should be a very low incidence of MDR TB, but now we know that that incidence is high, and we've also reported an XDR TB in a child in the spine. All right, so it's getting big on us, and you don't want to, be caught napping when this is getting big on us. And we are the TB capital of the world, India and China, right? Okay, now what do you do when, what did this surgeon do? He saw that the patient was doing fairly okay, but the MRI was a bit worse at 3 months. How many of you would add ciprofloxacin in your treatment regimen? Put your hands up. I like that everyone's saying no, because mostly everyone adds ciprofloxacin, and that's absolutely incorrect. There is no theory or no practical, benefit of adding one drug to what you think is a failing regimen. So you have to decide. You either decide that this is getting worse, or you decide that it's a radiological paradox, but the patient is getting better. You can't put one foot here and one foot there, and by adding a ciprofloxacin, you're creating if you thought it was resistance, you're going to create resistance to ciprofloxacin. I mean, all the floxacins also, right? So there's no role of adding one drug to a failing regimen, and hence the next important dictum is that all of us should have a tight protocol of chemotherapy, and you can't be jumping ships with every patient. That protocol has to be tight because the disease is the same. Whether you're treating it in Andhra Pradesh, Tamil Nadu or Kashmir, the disease is the same, right? If it's primary TB, that's the medicine that it needs, okay? So that protocol, what we follow and what we would like to propagate is a primary of a sterilizing treatment where you sterilize the bug. Actually, it takes less than 6 weeks for the bug to get sterile. So some of you may have read the papers from China which showed ultra short chemotherapy for primary TB. Well, the disease will go away, but that's not the problem in TB. The persisters are the problem. So you consider a person healed if there's no recurrence. You don't consider a person healed if the TB is gone away from his body. And to kill the persisters, you need this long therapy. All right? So don't get startled if someone says that in 6 weeks my abscess is gone and I'm feeling fine. That's expected. It's not some miracle of God. All right? So you want to give that EHR for 4 to 10 months after, and we'll talk about that a little later. Now, the question is streptomycin. How many of you in osteoarticular TB would add streptomycin? Put your hands up. So the correct answer is that there's no role of streptomycin. There's no known benefit of streptomycin. We as surgeons feel that injection will be absorbed better, but the inherent inborn Indian resistance to streptomycin is 30%. All right, barring the the side effects of streptomycin and the whole issue of taking injections. What about vitamin D? How many of you give vitamin D? And do you know the role of vitamin D? So do you know that in the past, treatment of TB was to send a patient to a sanatorium and they would get better? That was because they absorbed sunlight in the sanatorium. They got vitamin D, and vitamin D actually enhances the T cell regulated immunity, which actually kills TB. And one of the common reasons why TB is on the resurgence is the presence of, there's a ubiquitousness of low vitamin D amongst all of us because of our lifestyle. And hence, vitamin D deficiency is one of the risk factors for TB. So make sure that all your patients are on vitamin D. Why not HR? In your continuation phase, we recommend HRE and not just HR, which is again going against what the textbook says. Is everyone clear on what controversy I'm raising? Why do you want to continue ethambutol besides INH and rifampicin in your continuation phase? Because the inherent Indian resistance to INH is as high as 16%. So one out of every 5 of us are resistant to INH to begin with. So if you have a sensitivity report which says that it's INH sensitive, you don't have to give HRE. But if you don't have that report, it's better to give HRE than HR for your long continuation phase. Is that clear? Any doubts? Any questions? Just stick your hands out and ask. All right. Okay, I'm assuming no questions. Now this is a standard male, 35-year-old male, good BMI, after 2 months of culture proven AKD, primary tuberculosis, started taking medicines, but still got worse. What's the possible cause? He was not a defaulter. I've given a clue. Yeah, it's a fixed drug combination. And surgeons are suckers to take that fixed drug combination. It's easy to write AKD4. fixed drug combinations are meant for people of 40 kilos. Is there any 40 kilo person in this hall? Please put your hands up. None. There are no, my leg is 40 kilos. Okay, so you cannot be giving fixed drug combination just because they're convenient to be, convenient to prescribe. And low dosing is the most common cause of drug resistance. It's not the patient's fault. It is your fault. All right. So avoid taking fixed drug combinations. Remember the dosage of, again, this dose, we learn it for a third MBBS and then we cleanly forget. So what my wife, this is all my wife's slide. What she's devised is 3 quiz questions after this, and I'm going to ask you the quizzes, okay? But just remember that black box there. You must tell the patient that rifampicin has to be taken on an empty stomach. Otherwise, it cannot get absorbed. And you must tell the patient that INH can, or your AKT can cause high colored urine. Otherwise, they get scared and stop AKT until they get your next appointment. Okay, so these are the minimum things that you have to tell your patient. Okay, so 62 kilo patient. What will be, who's brave enough to, take this up? 62 kilo patient, what will be your dosage? INH, rifampicin, ethambutol. Does anyone know dosage? Okay, I'll just, for the want of time, I'll skip this quiz, but this is the dosage. So what's striking out is that the ethambutol is not 800. This is not a heavy person. She's 60, he or she is 62, which is an average weight. But even then, ethambutol is 1000, not 800, which is the standard that we think. And PZA is 1750, not 1500. Okay, what about this one? 40 kilo. 40 kilo actually falls in the PED's purview. And you see the INH dose has gone down. It's gone to 200. So you don't want to overdose INH because it can cause toxicity. Okay. And what about a standard 92 kilo, big fat adult? You see the doses. See the Z. Okay. So obviously it's confusing, and we are not high IQ people. We are surgeons. So leave this to the physicians, or you get your math right and give it right. You can't say that, boss, ye main bhul gaya. That's not acceptable. All right. So there's one more slide which I was not aware of. There is a maximum ceiling dose. So if your patient is obese, you still can't give more than this dose. Okay? Because after that, it's not effective and more toxic. Again, trust me, these are my wife's slide. I'm going to forget all this 2 days after this meeting. So are you, even though you're taking pictures. So leave it to a sensible physician. All right? Okay, so the next one is that thou shall administer correct doses of AKT. Okay, Dr. Leela says that. Yes.
Sir, if the patient is responding with the ATT for 3 months, if the patient is put on weight from 40 to 50, can you increase the dosage of the drug?
You have to. That's such a good question that we overlook that as the patients get better, one of the greatest way to know that he's responding is weight gain. And you need to keep adjusting the doses as per the weight. Thank you for bringing this up. All right, so who's going to take this up? Maybe it's seniors? Senior? Pucho? Chalega? So, what are the best 3 second-line drugs? So you are convinced in your head that this patient is looking resistant. You don't have any culture data with you. So which would be the first 3 second-line drugs that you want to add?
Like fluoroquinolones wellness.
Okay. So again, this was a trap. I'm not picking on you. The answer is please don't start any second-line drugs. It's not in our purview to start second-line drugs because of the next few slides. The next few slides are so complicated that you'll realize that you're best that you sit out of this. Okay. So it's not our business to start second-line drugs. We need to refer to a chest physician. Okay. So I'm quickly diverting a bit, and I'm saying in a standard way, a standard chemotherapy would work like this. But every time things don't go right, and you can have deviations in the way you're actually, the world is moving. All right. So if you have this situation, so the patient is actually getting better, but the radiology is slightly worsened. How many of you would consider this patient healing? Put your hands up. Very few. How many of you would think he's getting worse? Put your hands up. So many of you are non-committal. That's not okay. We are all committing. You have to commit. Okay. We need all hands up because we need involvement. So I think I'm on Leela's side that radiology comes after clinical. So if your patient is clinically clearly getting better, you would think of this as what we call a paradoxical reaction, where there's a fight between the drug and the bug, and there's more necrosis that's formed. That's called a paradoxical reaction. It's an immune reaction. where you might find more soft tissue, but that does not necessarily translate to more disease. So when Dr. Thomas told us that the criteria of recovery are first is clinical, second is radiological, and third is laboratory in order of priority. So if clinically improving, radiologically worsening, don't bother. What about this? She's like rapidly better at 3 months. Disease also completely healed at 3 months on the MRI. How many of you would stop AKT? This is in order of reinforcement. I can see no hands up, which is a great sign. So don't stop AKT, continue AKT to throttle the persisters, right? So the monitoring criteria, as we discussed, are very, very clear, and follow that order and follow follow your clinical feeling rather than. So here's a case in point. This is a lady who, or a man from Bombay who was completely clinically okay at 6 months, but his MRI looked like that. So we said we should give him some more medicine. So we gave him 6 more months. At 12 months, he was jumping across the Bombay local trains. So he was asymptomatic to the core. And I said, now it will be a sin to give him AKT. So we stopped chemotherapy. But out of curiosity, we were wondering what the hell are those big pockets there. So we called him back at 6 months and got an MRI again and see what it shows. Okay. So the takeaway message here is that you got to differentiate between sterile soft tissue, which is the debris, the necrotic debris. It's not infection. It is sterilized infection or sterilized pus. So a chest physician who's treating lung TB with pleural effusion will stop chemotherapy at 6 months, even if there's pleural effusion, because that is sterile fluid. The body's job is to absorb it. It's not the job of the medicines to absorb it. Okay. So don't interpret this as disease if the patient is otherwise fine. What about role of PET scan? How many of you strongly believe that a PET scan is a great tool to diagnose TB? I can see a good nod here. You do believe that it is? Yeah.
Because she was talking about the pyogenic thing.
Yeah.
I go for the pyogenic non-invasive thing for the MRI. After MRI, I go for PET scan also because it has a high sensitivity and specificity.
Yeah. So I actually think diametrically opposite. So I'll just show you this case. Like we were forced to operate this senior guy because we were told it's a malignancy based on PET scan. It turned out to be a standard tuberculosis. And I personally have had a dozen such cases where the PET scan has not been able to differentiate infection from malignancy. It could determine. I'll take your view in a minute. It could determine high metabolic activity, but not differentiate between disease activity or infective activity versus malignancy activity.
I differ for it because they said that the bacteria they uses the glucose. So where there is a bacterial infection, I'll go and check for the PET scan.
But how, if there was malignancy, how will it show?
Malignancy, the glucose will not be used because the PET, the glucose metabolism is important.
Yeah. So as per your information, it will show different results in a infection versus a tumor.
Yes, tumor
Okay.
is resilient, but in case of infection, that is a pyogenic infection, highly specific and highly sensitive.
Okay. So we'll leave this because what you say also makes sense. Do you have any inputs on PET scan, or that's not your field?
It's not widely available. It's not widely available. Like I would not do it because we know it is infection, and then we need to do a biopsy. So there is.
There is a confusion because in one of the big cities, one of the centers they have PET scan. And we want, if the patient is affordable, I like to say.
You use it in practice, sir? You've used it in practice?
If
Like
there's a
it
doubt,
is.
I'll go for it.
Doubtful
If it is
cases.
affordable and if it is available. In Pune and Mumbai, it is available.
Yeah, it's available easy. The question was this. Because now, I'll tell you where I'm coming from. In the north, people are using PET scan to determine disease activity. That PET scan positive means continue AKT. And that's, I think, BS.
No, just to comment on query. So you're using PET, but will you take it as a confirmatory for infection, or is it possible to start a medical trial on PET without biopsy? That is the question.
Sir,
Is
it
PET
only
will
for the doubtful cases, I'll go for it. When if it is a it is straightforward case, okay, but there is a doubt. Then it is a non-invasive.
when the histopathology is doubtful, then you go for
Or
PET.
if I feel that it is something like a pyogenic, because the mechanism and it's highly sensitive and specificity in case of infection. That's the thing.
So I think this is a great discussion point, and maybe Naresh, we should keep this as one of the unsolved queries of today's discussion, and we'll go more into depths of it because I very strongly believe that it's a useless test in TB, but Sir here believes it is. And like Shankar, for example, Shankar Acharya in Delhi is doing PET scan regularly for all TBs, and he uses that as the endpoint of his treatment, which I firmly differ with, though he's a good friend of mine. So all I'm saying is you shall monitor treatment very closely because there's no hard criteria of recovery. All right. So now the next thing is that there are adverse reactions with TB, and they're very, very common, and we should know them because the patient is ultimately you're the captain of the ship. But again, as a surgeon, you're not aware of this physician-based things. The commonest thing is nausea, and you got to monitor the SGOT, SGPT levels, and there's actual dictum of how to treat AKT-related hepatitis, and I think the next slide will bring it up. So as you can see, I'm not even bothering to read this because it's too much information for a surgeon. And once again, I'm bringing up facts that you want to get a physician to be doing this stuff. It doesn't process well in our heads. 3 times is okay, 5 times is not okay, which drugs to stop. There's a whole criteria. If there's a AKT-induced hepatitis, this is the criteria to be followed. You can't differ from this. So personally, I feel let your physician handle this. I'll give this presentation to everyone. So it'll be in your, you can just mail it to everyone. There's no problem. So you don't bother about taking photos. There's another one which sometimes gets missed, and that's this. That if it's a woman of, it's basically fights, I mean, it interacts with contraceptives. And there are incidences of ladies becoming pregnant while on AKT because of their AKT. And that's again something that we would laugh about, but in the family, it's a big crisis. So you want to be aware of that and you want to inform that to your patient. It's not possible for us to do it. Let your physician do it. All right. So the next one is look for and manage side effects of AKT. Okay, as a physician treating. And then finally, how long do you want to continue AKT? And that big fight, I think, has been resolved. So in the past, people would give chemotherapy for 18 and 20 months also for osteoarticular tuberculosis. But we did this randomized prospective control study, and this came after Dr. Rajsekharan got up in one of the meetings and said, I have never given chemotherapy for a standard primary tuberculosis for longer than 6 months. And all of us were, really? Because we were all giving 12 months plus. This is back in, I think, 99 or somewhere. He won't even remember. But based on this, we started this prospective trial, and we actually studied 50 patients randomized to 6 months of AKT and 50 patients to 12 months of AKT. And these were all culture-proven primary TBs. And the endpoint of treatment was not healing. The endpoint was lack of recurrence 2 years after stopping AKT. So this became a class 2 data. There are very few class 2 data available in spine literature. And this suggested that there is no difference between 6 months of AKT and 12 months of AKT, which means that, of course, because the numbers were only 100, we could not use this. This can't be used as one of the takeaways, but it's a pilot study. But the recommendation can easily say that you don't want to give more than 12 months. You may not be able to wait and say 6 months, but definitely not more than 12 months. All right. So I'll end here. That's the take-home message. That you want a high, though there's a high index of suspicion, get a biopsy and culture for all, make a systematic non-surgical protocol, and remember that TB is a medical disease today.
I think this was one of the most important talks for the day because all the disasters that happen in the treatment of spinal tuberculosis happen with disasters of chemotherapy management. I think this is something you either do it less or do it more. And I know for sure some of the very famous spine surgeons in North India are still giving anti-tuberculous drugs for 18 months. And there is even one very prominent surgeon who says, I was talking to him, he said minimum 24 months, maybe 36 months. I don't know. I mean, it looks absolutely ridiculous in this modern period, but that's what is there. But we need to have a very clear idea of this thing. So before we go on to the inauguration, and after that, we have one talk by Abhay on surgical treatment. No? Okay. MDR. No, after that. Okay, MDR means you can do it now. Okay. Pushpa. So how do you, one of the things that was talked about healing, quick. One of the things which we talked about was how do you know that the patient is responding to the treatment? And we know clinically good appetite, putting on some weight, feeling of good feeling, no fever, no sweats. That's one part of it. The second part of it is ESR coming down and CRP coming down. And something that is increasingly being used now is MRI. And actually, the government of India guidelines itself is very surprisingly including MRI as an important part of assessment of healing of spinal tuberculosis. So, because so you want to ask a doubt? Yeah.
Mike.
So in the starting of the lecture, sir mentioned that this neurological deficit is not the indication for operative management. As I am just a postgraduate, we are studying till now that if a patient is having a neurological deficit, that it is an indication for operation. And also, like I was just thinking, suppose if a patient comes to us in the future and if he's having a neurological problem, but instead of doing surgery, I start with ATT. And just in case if the situation becomes like from bad to worse, the patient will definitely will say, because people if you treat them, it's okay, it's their right, but if other way around, it will become more difficult. So
Yeah, good. I'm very glad you brought up that question. I think what Abhay asked is, what is the threshold before you will think that the neurological deficit is fit enough for surgery? So that's what we said. Patient objectively does not have any problem. He is walking into the consultation room by himself, and you are examining him, and he has hyperreflexia, which actually is a neurological sign.
yes.
So then you do a plantar. Plantar is weakly positive, which again is a objective neurological sign.
Yes, object.
But subjectively, he is not aware of any problem in himself. It's like cervical myelopathies who come to us. You examine them, there are some hard neurological signs, but the patient thinks that he is completely all right. Is this sufficient enough to order a surgery? That's what was the question. So we all agreed that wherever the patient is not having a subjective, no, he doesn't come and complain to you. If he comes and says, I have got walking disability, I have got some gait disturbance.
Sir, as a doctor, aren't we supposed to prevent disease to progress further, sir?
No, but if you're going to operate, there is also something called unnecessary prophylactic surgeries. And this would come into that category because we have hard evidence that these signs do not require surgery. That is number one. Second is, you also have to know, in your experience as you grow older and you see more patients, you will know there are many patients who have only hyperreflexia who get operated and get an intraoperative complication and they become paraplegic. So any surgery which is not necessary it should be 100% no, and that's why we are discussing quite a lot. At what point of time will you start operating? I think subjective symptoms or not, objective small hyperreflexia and some numbness in the foot, you can safely put them on ATT.
Oh, then, sir, indications.
Provided there is no instability of the spine. I'll just come to one of the lectures on instability of TB spine.
So you should definitely not fall into the trap of defensive medicine, because technically even a small abscess, if it's not treated correctly, will turn into neurology and kyphosis, and the same argument will hold true. The patient will come and hold you responsible. But there has to be a logic to it, right? So we go by evidence based, and we have created evidence to say that if there's neurology which is of a certain grade, you don't need to do surgery. So your patient will not hold you back. Of course, this is subject to the fact that the patient understands, the patient going to follow up. Just like you have to be a good doctor, he has to be a good patient. So if he's not going to be a good patient, then things can go haywire no matter what you do. And compare the risk of surgery versus the risk involved in surgery versus the risk involved in not doing a surgery, and then take a good decision. So in your exam, when you get a patient with a big abscess, but just some wrist reflexes walking around, don't say surgery. That's the takeaway as far as your current life is concerned. Thank you.
Any motor deficit is there, motor deficit, you have to do surgery in our circumstances. Sensory, there is no need.
Sir, if the patient is taking ATT for 2 months and he lost 15 days if he's not taking drugs, one second situation if the patient is not taking 2 months default. So can you start from 4 drug regimen or like in 2 situations? One patient is for lost 1 week, second case is lost 1 month or 2 months duration.
This is
difficult questions.
this is a perfect question because this is something what we face very frequently. Somebody who has, I don't know whether back sitters they could decipher this question. Patient comes having taken medicines for 2 months, felt very much better, discontinued medicines for 2 months, and now they are coming and seeing. So would you take into account that they already had 2 months and then put them only on the rest of your calculated time, or would you start afresh?
So the red flag for default is 2 weeks. If someone has defaulted for 2 weeks or more, you would put that person in the red flag category, which means that you think in your head that this could have turned resistant, but you still continue primary AKT and see the response, but you monitor more closely. Of course, the other options being to do repeat a biopsy and then get an LPA or a pyrosequencing and identify, but that becomes too aggressive. But if he's defaulted for like 6 months, then of course you want to treat this as a whole new disease. So basically, be more watchful if he's defaulted for anything more than 2 weeks.
So I'd like to ask, because all the seniors are here, how often do you see resistance in Andhra Pradesh? Because there is a big difference between North and South India, I feel, on the exact incidence of Shivanand sir. What is your how often you see resistance for any kind of tuberculosis?
So many times it's not like old days, sir. The healing and the clinical symptom, they do not reduce as regularly as in old days. There is the reason we send it for biopsy most of the times, especially not only in spinal tuberculosis, the rest of the joints. Also the symptoms, when they do not come down for, we
But
send it
how
for
often
H.
there is a documentation of resistant TB in your practice? In the medical college, sir, Shivanand sir, how often do you see? Because I see very, very less, extremely less. In a year, I see 2 cases of resistant tuberculosis, only that. But in North, especially if you talk to Dr. Anil Jain and of course the Bombay group, Abhay Nane, the incidence of resistance is very high.
Same, sir.
High?
No, sir. It is
Low.
not high.
Low.
I have some inside information from microbiology department.
Inside information.
Yeah,
How did
my
you
wife
get the
is a
inside?
microbiologist.
This looks very sneaky, and you got a
So,
girlfriend there or something?
My wife.
Wife.
So there have been reported cases for resistance, sir.
How much? What is the exact percent?
Very less number. Very less, but they have been reported.
No, there is resistance, but sometimes when you hear presentations from Mumbai or Delhi, Anil Jain, he speaks, he says 28% resistance and all, which looks...
This and in particular too, I am talking about our orthopedic specimens, very extremely less.
See, it should be just the genetics of, probably we are having different strains also, completely different mycobacterium strains. Or I don't know whether we are more immune to, there is also a difference in gut biome. Now they have found, depending upon what bacteria you have in your gut, that is the one actually that breaks the rifampicin and then makes it resistant. So it's all very different.
So
Yes, sir?
before starting on ATT, confirming the diagnosis, as per the NTCP or now it is NTEP, they say that there is no entity like empirical treatment. No empirical. So is it the empirical treatment without confirming the diagnosis is propagating the drug resistance? The second thing
One of the problem is that when you're starting on an empirical treatment, neither you are very sure about your diagnosis, nor is the patient. I have had some patients who come and say, I was there for 3 months and I stopped. Then I ask, why did you stop? They say, anyway, there was no confirmation of tuberculosis. Doctor போட்டு பார்க்கலாம்னு சொன்னார் சார், நான் நல்லா தான் இருக்கேன், அதனால I stopped it. So when you have something written, then the patient also knows, oh, I have tuberculosis. Otherwise, it's a mind game for both the patient and also for the doctor. So it is also very proved that non-compliance is very high in patients who are having empirical treatment for tuberculosis because they are not convinced. After some time, they think that they are overdoing it.
The concept of middle path regime still holds good, sir.
The concept of middle path regime holds good, but where is the middle path? I think the goalpost has been shifted a little bit. We'll come to it when we are talking about surgical case. Yeah.
Okay, let's see the MRI features of healing spondylodiscitis. What are the things we have to see? So here you can see the patient is on ATT for 8 months, and these are the follow-up scans. So I have put T1 weighted sequences here and T2 weighted sequences here. So what are the things you look for when you're looking for healing? So this is in the duration of 8 months. So you can see there is a large paravertebral collection here. So first thing you see is whether the paravertebral collection is going off. So here the paravertebral collection has completely gone. And then second thing, you have to look for the disc spaces. Okay. So if you see in the healing phase, the disc space is actually getting worse, and also end plate irregularity is also coming up. But this is a normal healing pattern, so you should not be worried that okay, disc is getting more destroyed and end plate is looking more irregular. So that can happen in healing tuberculosis. But what we should be very carefully looking for is the paraspinal abscess. If the abscess is getting cleared, and if the vertebral body, so if you see there is an abscess in the initial stage, but later on the abscess cavity is gone, and in the T1 weighted sequences it is getting more fatty. So if the fat is replaced in an abnormal bone, then it indicates there is healing. So in T1, you see for the vertebral body fat fat replacement, and in T2 and STIR sequences, you look for resolution of edema and also resolution of the soft tissue. So here you can see there is a resolution of edema, and it is becoming more sclerosed and more fatty, and there is complete resolution of paraspinal soft tissue also. So this is the paraspinal soft tissue in the initial scan. In the later scan, it is completely disappeared. So this is a good treatment response and complete healing. So another patient here, again, what I wanted to tell you is that we should be looking for the vertebral body edema and paraspinal soft tissue. But disc space can completely collapse, and the irregularity of the end plate can look more severe in case of healing TB sometimes. Okay, so you should be very mindful about it. This is again the another case. You can see there is actually no much destruction here. The vertebral body also looks sort of okay, especially on T1 weighted sequence. You can see there is little change in the vertebral body signal. Tiny collection is there in the anterior aspect. So only this much was the finding initially. But once the therapy was given, you can see the complete disc has collapsed. There is end plate irregularity. But what is stating that there is healing happening because there is lot of fat changes in the vertebra. So end plate changes and disc height reduction is not a criteria to tell that there is disease progression. Only you have to see for the vertebral edema to resolve and paravertebral soft tissue to resolve. Another patient here, you can see there are multiple changes happening. So there is soft tissue, there is end plate irregularity, disc is also involved. And when you see, this is the patient where there is initially the thickness, paraspinal soft tissue thickness was only 1.1. But in May, that is within a few months, after a few months of treatment, that is within 3 months, they have done repeated the MRI, the thickness has increased. So this can also happen in early stage if you screen. So it is not, unless the patient is feeling there is a deterioration of clinical findings, there is no need to do MRI, because MRI might show changes which are not related to healing in before 3 months. So you have to give a gap of 6 months. So based on all these things, what I want to tell is there is no much guidance on soft tissue or vertebral changes on MRI that signify the response during the treatment. So and also you should know that radiological evidence can lag up to 3 months. So patient might be getting better, but imaging will take 3 months to show that the patient is getting better. So you should not entirely rely on imaging, but you should see how the patient is doing. And despite of clinical response, up to 5 to 6 months of chemotherapy, MRI might show increase in disease. This is mainly because the granulation tissue breaks down and the abscess might get bigger, and also it could be because of the bacteria are getting killed, and that is causing some immune response in the body. So there can appear that there is edema increasing and all those things, and also the abscess is looking more liquefied and more bigger. That can happen in 5 to 6 months of chemotherapy. So it is better to ignore and not to do MRI very frequently unless the patient is feeling very, very worse. And also radiological healing or clinical healing is, it has to be individualized. So you can't treat all TB patients as same. You should actually look into patient as individual patient and treat him accordingly. So whenever there is clinical worsening and along with there is increase in radiological features, that's when you do repeat biopsy and change your treatment course depending on how the patient is presenting. So Central Tuberculosis Division of India came out with new set of recommendation for imaging to describe the endpoints and it has to be, they also told that it has to be on case basis. So they've told X-rays has to be taken every 3 months or so, and based on clinical response, you can repeat the MRA at 6, 9, 12 and 18 months. And once the patient is completely okay, every 6 months for 2 years, you can do the imaging. Coming to PET scan, I didn't include because I don't have much experience in PET scan. They have told that TB might show the healing in PET scan very fast, like within 3 to 4 months of therapy, it can show the response well in PET scan as compared to MRI. So to conclude, I would like to say always interpret radiology with clinical findings, especially when it comes to healing. Remember, radiological healings lag behind significantly. It's up to 3 months, and so it is better to image wisely and interpret even cautiously. So thank you, and I want to thank Naresh sir. Actually, the amount I have prepared to teach is more than what I learned today. So I am really thankful for all the seniors who taught so much today in this short duration. I really enjoyed the session. Thanks Yesa sir also to include me in this program, and thanks Thomas sir and Abhay sir for sharing their knowledge. It was really wonderful being here. Thank you.
So one question, Abhay is going to talk on if there is no good healing, then what do you do? How do you treat MD or tuberculosis? So just before that, I'll ask Thomas one question. Thomas, patient is not showing sufficient improvement. What would you do? I mean, are you going to cover this in your talk? So what do all of you feel? Patient comes and says, I'm not feeling so good. I initially felt better in the first 1 month. After that, I'm not feeling good. I still have some pain. And what do you do? Do you re-biopsy or what is your...
So I think we should look at all three factors of those three pillars that I spoke about. So clinically, the patient is not feeling too good. Go back and get the laboratory test repeated again. Is the ESR, which was beginning to fall, has it started rising again? And does the MRI and your imaging looking far worse than it looked initially? So I think it's going to be a combination of all the three factors before you decide that the patient is not responding to the diagnosis, to the treatment. So number one is, are you on the right path? Are you on the right diagnosis? If you are on the right diagnosis, then are you giving adequate medications? Do you need to change medications? And things like that. And the last option for if it is confirmed tuberculosis, then make sure that you're not dealing with drug-resistant tuberculosis. If it's confirmed tuberculosis, not drug-resistant, not responding to conservative treatment, then probably a surgical debridement and instrumentation may be the way forward.
So Abhay, would you re-biopsy or would you operate on this?
I think my strongest foothold would be if I had a diagnosis and a culture to start with. If I have that, then I'm very, very confident, and the chance of things going out of my system are very low. But you all must know that there's something called secondary drug resistance that happens while you're on treatment, and either because of faulty dosage or the patient not being compliant or faulty absorption because of some drug interaction, the patient develops drug resistance while on treatment. And this has to be thought of, and that's where MDR-TB comes in. So I may take the cue and go ahead and show this case where someone got worse while on AKT. Everything was, correct, and yet the lady was getting clinically as well as radiologically worse. And this is where you got to think of MDR-TB. And our first publication of spine MDR was way back in, I think, 2009. And we showed 25 cases of spinal MDR-TB, which was unheard of at that time. And we followed that up in 2 years with 111 cases, because I worked in a hospital which was where the microbiologist was the number one. She is still the number one microbiologist for tuberculosis in the country, I'm going to say, Dr. Camilla Rodriguez. So all samples would come to her, and we had this huge database of MDR-TB. So basically, with spine TB, no matter what your background or where you practice, don't eliminate it in your head that it could be an MDR-TB. There's a high chance, or there is a chance that it will be an MDR-TB. All right. So tackling drug resistance, I think definition is most important. Did you all know that drug-resistant tuberculosis, the definition of MDR is resistance to INH and rifampicin. We are not even talking of the other drugs yet, all the betacolins, blah, blah, blah. So because these are the best drugs available in TB, no matter how you look at it. They may be easy, they may be cheap, they may be easy, but they are still the best sterilizing drugs for TB. And if you're resistant to these, you're on the bad wicket to begin with. There are other definitions. So there is monoresistance, which means drug resistance to any of the second line drugs, where you don't treat this as an MDR, but you just add 2 new drugs. There's polydrug resistance, which means that there's 2 or more first line resistances other than INH and rifampicin. And then there's extensively drug resistance, which means that at least one of the injectables you're resistant to. I'll give this presentation to you so you don't have to record. Hopefully you'll have a PDF version of this on your email. And then there's XDR, and XDR makes things very, very bad because you have very few drugs available, and we have recorded a case of spine XDR TB. But the worst is this, the red at the bottom, and we are coming back to a pre-antibiotic era because now there's totally drug-resistant TB that's been discovered, or Dr. Zari Rudwadia put it in Times of India before it came and there was a big controversy. But the fact is that there are cases floating around which are totally drug-resistant tuberculosis, and unfortunately, we are the culprits. You and me are the culprits. So try not to contribute to this menace of drug resistance in the future. This is the current statistic that prevalence of MDR-TB in newly diagnosed patients in India is 3.4, but this includes pulmonary, which is much higher than osteoarticular, and prevalence of MDR-TB in patients who have received AKT in the past, and you'll get a bunch of these in your practice, is much higher, 25 to 35%. So someone who's had a past history of TB, suspect MDR. And in children, so I think we recently published, before children, the estimated, spondylodiscitis being MDR in the world is 5,000 cases a year, which is again a big number because we are the drug capital. And we published recently in the Spine Journal the incidence and outcomes of MDR-TB in pediatric population. So the difference in pediatrics versus adults is pediatrics is de novo infection. It's not a reactivation of a dormant disease because they've just been infected. And right now the bug doing the rounds is resistant bug. So in Wadia Hospital, it's 2 out of 10 kids with TB are MDR-TB. That's a sickeningly high number. And their results of surgery, because most of them end up needing surgery, are much poorer than results of primary TB. So that's the data available. When would you suspect MDR in all these situations? It may seem very intuitive to you, but you have to think about this in every patient you see. If there's no clinical improvement or worsening despite 3 months of treatment, think of a secondary MDR being, in the process. Inadequate doses, history of irregular drug intake, known contact with an MDR case in the community, a person who's diabetic or HIV positive, alcoholics, drug addicts, and appearance of new lesions while on treatment. And this can become a bugbear in your treatment because you feel the main lesion is getting better, and boom, you find a small abscess in the lumbar spine. And that again should light up your tentacles, and you've got to start thinking whether there's a resistance going on. Because the resistance may not be all or none. There could be an in-between where some drugs are working, some are not. But eventually that's going to become all or none. So the minute you suspect that, you want to get on the job and maybe biopsy. Now this is a very busy slide because it's a list of second line drugs. So if there are 100 people claiming to do one thing, means no one person can do it well, right? Which means none of these drugs are actually so effective because they are all, because there's no solution, they are finding new solutions, right? And this is an even busier slide, which is the complications of these drugs. All these drugs come with side effects. So if you think as an orthopedic surgeon that with these heavy medicines, expensive big names, I can stamp out second line tuberculosis, you're absolutely wrong, because second line drugs are less effective, more expensive, and have more side effects than primary line drugs. So the simpler the better. Okay, so that's a takeaway message for you. And remember, the mortality in MDR TB, death, is 10%, almost equal to breast cancer. So MDR TB is not just an infection or the TB that you're made friends with all your life. It's a completely different animal. Don't let it affect your spines. Just to touch upon some things that were not covered, because this is such a big menace, that the new molecular tests have come up, and just a few slides on some of the confusion that we had. That Gene Expert confirms TB early and tells you about sensitivity to INH and rifampicin. Okay, and that's good enough information for us to start with. Results are available in 2 hours, and it's a kit, so it can be done in your backyard. Literally, you don't need to have a fancy laboratory. Accuracy of detection of resistance is 98%, which is again very, very strong. That's why Gene Expert, which is actually a commercial name, and CB-NAT, which again is a commercial name, have come into vogue. Okay, the problem is that it comes in these cycle thresholds that we discussed, and if it's a low cycle threshold, which means that more than 28 cycles had to be done to detect TB, the chance of it showing rifampicin resistance. So rifa sensitivity can show false positive. When it's actually resistant, it can show that it's not resistant. All right. So that's where Gene Expert Ultra comes in, which is the current standard of care. The statistics are self-explanatory, the stuff on the right, and you want to send most patients for Gene Expert Ultra. And here they have the next source, which is trace, and hence even low CT, your rifa sensitivity accurate. And this can make a heaven or hell difference in a given case, like so in your clinic. The case that happened, it would made all the difference for this lady's life, right? So don't take it lightly. The next one is so what is the protocol? The protocol is that if you do a Gene Expert and it shows high, medium, low, or very low, okay, you can send the sample for LPA even though if it was smear negative, because LPA will give you data of 12 new drugs, and it's far better, and it's like 2,000 rupees or something. It's not like frightfully expensive. The disadvantage is it's not a kit. You need a lab which does LPA. Okay, if you're in that trace bracket, even with Gene Expert Ultra, you want to send for something that is now available, known as TB pyrosequencing XDR. All right, and that is the new thing that's available, which actually tests everything that the LPA tests, but is far more sensitive. As far as the Gene Expert is concerned, these are the points you got to remember, and each point is important. A negative Gene Expert does not rule out TB. A positive test does not indicate a viable or a living organism. And see the last line, or the next line, a patient with a past history of TB treatment with no symptoms of reactivation. So he's been declared cured for more than 2 years. If your Gene Expert comes positive now, think of it as a dead bug, or think of it, interpret that with caution. All right. And AFB smear positive but Gene Expert not detected, consider atypical mycobacteria. I think these are the 4 points that you got to remember. Don't take Gene Expert as the absolute gospel truth, which now we are getting used to making that as the absolute black and white truth. There are some loopholes there. And so what about LPA? The line probe assay is a much better test because it gives you a far better menu of sensitivity. However, like I said, it used to be not done when there was a smear negativity, which was a very high situation in spine TB. But today, if the AFB smear is positive, no brainer, send the sample for LPA. If the AFB smear is negative, send for Gene Ultra, which you do anyway. And if the Gene Ultra is positive, anyway, send it for LPA. And remember, all these samples should have gone for the midget, because midget is still the gold standard. And there are more and more situations where Gene Expert is negative, but midget comes positive after 3 weeks. So don't not send your sample for midget. Histopathology, smear, and midget are a must. And Gene Expert is an add-on, and LPA is an add-on. All right? I'm saying this again. If Gene Expert is negative, you don't hang your boots if you think it's TB. Wait for the midget to come positive or negative before you actually say TB or not TB, because that's a far better test than the Gene Expert. And then pyrosequencing is the new test. I don't know much about it, but you can ask your microbiologists. It's the new test which is more sensitive but gives the same data as LPA, and it is useful if the patient has been on AKT for longer than 6 weeks. Okay, And then the newest test, which is still not come in, is the whole genome sequencing, which promises to give a menu. Idli khayega, vada khayega, that type of a menu. It will tell you which drug, how much sensitive per patient. And it's a genome-based test. So it does not matter, whether your biopsy came in right or no. It's a genome-based test. Okay. So I think that is the new things about MDR. As far as the treatment is concerned, all you need to know that there's a standardized treatment, which is a standard treatment with or without the data. And there's an individualized treatment when you have the data of that patient, clinical history, sensitivity pattern, etc. And we don't have to then go into the second line drugs. Just that currently in the Times of India, day before yesterday, there was a new article about a very short course treatment, which is a super short course treatment that the government has actually approved. It has not been tested for osteoarticular TB. So put your hands up and don't use that treatment. And I think this is just to impress upon you that all these names are beyond our purview and it's not our business to be treating MDR TB. So I'm just going to try and impress that upon you. So this was a question I asked some time back and the answer remains the same. Please don't bother getting into treatment. So the surgeon's role is to find a good TB physician or an infective disease physician. I'm saying this because across the globe, all of them don't have the capability. You can't shut your eyes and say every TB physician treats MDR well. So you have to develop that rapport with yours. I have no choice because I sleep with her every night.
That's what I wanted to tell. The best solution is find a good infectious disease person and marry her.
Marry her. And get it right the first time. Okay?
So you would see that we are surgeons, but actually we are discussing more about medicines. But that is the secret of success, because after some time we all realize that to operate is very easy, to stabilize the spine is very easy, but the success of surgery exactly depends upon whether the organism there is killed or not. So whether the disease is eradicated or not actually gives the success for surgery, and so we need to be really focusing on our drug schedule, drug compliance. So now in my practice, whenever an operated patient comes, they'll give the X-ray to my hand. I'll just keep the X-ray down and first ask them the question, are you taking your anti-tuberculosis drugs properly? Patient will always say yes. Then you ask your wife, his wife, then he will say, sir, appappa udra. You have to, if you confine your first few minutes of discussion with the patient about the medication and not look at the X-ray straight, they also understand what is the most important things out of this. So this is something very important. And the statistics which Abhay put is really frightening, because death rate of MDR tuberculosis is the same as breast cancer. And I had one of my aunties who had breast cancer and then had MDR after a few years. She had to go on the second line of drugs, and she said breast cancer treatment was far better than MDR tuberculosis, because those drugs are really killing actually it kills the TB, but also kills the patient because they have so much of side effects. So it is the onus of all of us to be very careful that we are not increasing the problem of MDR or XDR in our country, because after that, any one of us can die by DR. I mean, if that happens, we are going to the pre-antibiotic era, and everybody who gets a tuberculosis will die. I mean, that's going to be a terrible thing. So Abhay is just ready to hop on the flight, and so we will get his opinion on his approach to a surgical patient. So everything has been done, and for some reasons we think that the surgery needs to be done. How would he approach? He has got a nice algorithm. We will discuss about this later also, but Abhay will give the algorithm before he goes.
So I can confess that this algorithm comes out of the teachings of one Dr. Rajshekharan. We've heard from him over and over the years, and that's how you create this algorithm, because the best experiences come from him. But I'm trying to say that we call ourselves TB experts. The whole world, wherever you go, India, TB, and they want you to, they discuss TB with you. But this is what's going on in our country. These are all cases that I have seen in my clinic. Some of them I have even operated. So we are messing it up. We are not getting it right for sure. And the world thinks that we are the big experts, but actually we know that we are, screwing it up again and again. So can we have a surgical algorithm which is a more uniform method of trying to treat TB surgically, rather than you doing your thing and me doing my thing? And again, on the basis of the learnings of our teachers, we've gone through this algorithm. So when obviously you know the indications of surgery and we need not discuss them, but deformity and instability become two indications which were not discussed. Remember, in TB, instability is a transient concept. It may be unstable now, but the disease is going to heal and it can become stable again. So don't use instability as a major indication, but all these are soft criteria. Instability, deformity, again deformity, a 60-degree kyphosis may not mean much in the cervicothoracic junction, but a 10-degree kyphosis in the lumbar spine is unacceptable. So don't use degrees as your go-to. Don't use instability at a given point as your go-to. On presentation, of course, there's instability, but while treating, is the disease drying up and healing, or is it drying up and remaining unstable? So these are the questions you want to ask yourself. But eventually, the goals of surgery are these. And you want first adequate samples, you want a good decompression, you want to reconstruct if there's a defect, you want to fix adequately, and then you want to back up with correct AKT. If you falter on any of these, you're going to not get it right. So you can get number 1, number 2 right, but don't do number 3. It's not going to come out right. So all these 5 goals should be achieved in your surgery, no matter how you do it and whatever your experience is. So when you make an algorithm, you have to only think as a surgeon, as a technician, as a carpenter, you got to only think of 3 things. Is this a wet or a dry disease? If it's wet, it's mobile. If it's dry, it's fixed. Is there kyphosis that needs correction? Because 10 degree or 20 degree doesn't matter. In your opinion, at that point, does it need correction? And what is the comorbidity of the patient? So what wicket are you batting on? Is it a good batting track or it's a flop track, Kanpur wicket? Okay. And that's the algorithm that we've followed, which my mentor, Dr. Bhojraj, has actually published in the JBJS, and it looks pretty simplistic. Okay, but we'll just get into some details of this because there's nothing that simple in spine. So if there's an anterior lesion, first let's start with the very rare posterior region, simplest operation, just decompress from the back. This is extremely rare in spinal tuberculosis, so we'll just leave this at that, leave one slide for this. But if there's an anterior lesion, you want to ask yourself, is there kyphosis or not? So when there's an anterior lesion, in the past we would say anterior lesion, anterior surgery. But we know the morbidity of anterior surgery, and we know a whole lot of us who are younger have not been exposed to the technique of anterior surgery. So it's today no longer easy to say anterior disease, anterior surgery. It's got a whole lot of caveats to it. So if there's no kyphosis, you don't need to reconstruct kyphosis. You can do this entire surgery from the front, take away the disease, reconstruct, and it's a direct attack surgery with the graft under compression. You're not messing around with the nerves. The chance of neurological deficit is low, and you reconstruct what God gave you, and that's it. Okay. The caveat being that you should be able to do that surgery because many of us are not exposed to doing that surgery. Okay. Now the problem, the other advantage is shortens fusion level. So you're literally reconstructing anatomy. I'll tell you the problem with this surgery is that, like, where would this fail? Barring lack of training, where would this surgery fail? So if you mistake that instability, so if you miss the posterior column, and it's not uncommon for the posterior column to be physiologically involved. It may not be anatomically involved. It may be, this is of course a case of GCT, and that's why the posterior column is involved pathologically. But in tuberculosis, it rarely affects the posterior column. But the kyphosis could have failed the posterior column, as Sir showed. Facet dislocation, facet subluxation, interspinous, it's just like a 3-column fracture. So if you have not identified posterior column instability and done a pure anterior surgery, it's going to fail like it failed here. Or I think I have more cases where it's failed. Okay, clearly this one can't go for anterior surgery. This is TB. I hope I'm getting that point across clear. So here's another one. This is my case actually, and I did this child only from the front. Here the posterior column is intact. If you see, it's intact, but it's physiologically failed. See the interspinous disruption here. So here an anterior surgery is day 1 failure. The column is going to keep collapsing, and you have to do a back and front surgery here. So that's your sucker trap. And of course, it will fail if you've not got a good disease control. This is before the time of MDR. We did this lady from the front. This was a good case for anterior, but we didn't get the chemotherapy right, and the disease recurred because it was actually MDR TB. All right. So if you don't get good disease clearance, your anterior surgery is going to fail even in the right indication. Now, what if it's an anterior surgery with no kyphosis, but the patient is not fit for an anterior job? Calcified aorta, fulminant pulmonary tuberculosis, concomitant. You can't do an anterior job there. So what would you do? So we've all perfected the art of doing anterior resection from the back. The advantage in TB is that you don't need to resect this whole thing. If it was a GCT, you need to resect it. In TB, all you need to do is clear the middle column, which is messing with the cord. You don't need to resect TB. You need to decompress and get adequate sample. Correct? Decompression of the middle column is eminently possible from the back. Resection of the anterior column is tricky from the back. Okay? Even for less skilled surgeons like us. So this is a very, very good option. And today, mostly we are doing this for anterior diseases, where we go transpedicularly and take away the middle column, keep the anterior column as it is, or reconstruct it when necessary. Remember that if you have not reconstructed the anterior column, there's a potential for that column to collapse. So if you want a controlled collapse, sublaminar wires help, because it's like a fireman sliding down the rail. You know, there's a concentric, without kyphosing, it collapses, and that helps healing. This is that approach where you do a laminectomy wide, go around the pedicles, go through the pedicles sometimes, take away that middle column alone. Okay, so decompress the cord and then put your instrumentation, and that's the end. So it's not so hard now for us to do, especially because we are now getting used to doing T-lifts. So this elderly lady with multiple comorbidities comes with a surgical spine, which means she has a deficit or instability that's pinned her down to bed. I would do this kind of a surgery here. Big, long, posterior, quick fixation, 1 hour, 15-minute surgery, and just decompress the middle column and get out. So it's like a splintage surgery with decompression. All right, here's another one. So we do a lot of these with Hartzell rectangle and sublaminar wires, but you could do whatever you like. Remember that screws are very rigid and they will not allow a collapse. So if you put screws and not reconstructed an anterior column and you expect it to collapse, your screws are going to break or the screws are going to back out. Be ready for that. All right, just like in osteoporotic spines. Now, where does this fail? So you choose this easy escape route, but there's a potential for it to fail. And that is when the kyphosis is too high, where you misjudged the kyphosis correction, or if it's a growing child. Let's see some examples. So here's a growing child. And we did the same surgery because at that, this is 1979 or 80, Dr. Bhojraj's patient. Or maybe 85, because 79 he was not old enough to do this surgery. But in the late 80s, so you see the posterior fixation is done because we don't know what to do in the front here. And it's failed. All right. We have one of ours. This is a very recent case from Wadia Hospital. Once again, cervicothoracic spine, 5-year-old kid. We were really at a loss of options. Despite me, coming here, beating my chest about this algorithm, I really don't know what to do with this patient. Okay, so the best we could do, Arjun and myself, we did this. So we did the same transpedicular approach, went from the side, decompressed the middle column, got some kind of a fixation. There's no holes in the cervical spine. We put rib grafts, etc. I think we put fibula also over here, but it promptly failed because the kyphosis was too much for this surgery to hold. And it was a growing child. All right, so those are the traps when you plan a transpedicular decompression. Now, if you have the third situation where there's an anterior disease with kyphosis that needs correction, the surgery to do is a back and front surgery. So from the back, correct kyphosis, from the front, reconstruct the column, and that becomes your best bet, especially in the lumbar spine when you want to save levels. But in the thoracic or thoracolumbar spine, you can do the whole job from the back alone, because then the size of the graft and the size of the reconstruction is not so critical. So if you're planning a posterior only approach, because most of the times the disease is a thoracic or thoracolumbar disease, if you're planning a posterior approach for reconstructing the anterior column, you could either choose to reconstruct that column or you could choose to close and dab that column down like you see here. Okay, so this is a case of lumbar TB. Okay, but not this one, but the next one. This would still go ideally for a back and front surgery because you want to save levels. It's a pure lumbar TB. So go from the back, correct kyphosis, create a defect, go from the front, decompression, put in a robust graft or a cage, and you got the best optimum result. But in the thoracic spine, you can sometimes cheat. All right. So one option here would be to go from the back, clear that anterior column, and then close it down like this. So there is no anterior defect. You've got a bone on bone, and the chance of this construct failing is very, very low. But the two things that you've done right here is you've got the biomechanical axis correct, and you've got the anterior column automatically reconstructed. If you leave any of this out, then you're in trouble. Okay. So that is what is called the PSO, or the pedicle subtraction osteotomy, which actually closes the anterior column. And this is a good case in point. Okay. I think most of us can practice this surgery on T-lifts. Lumbar T-lift is exactly this. You're going to the middle column and the anterior column through the side. And if you learn to do that, then you can do thoracic T-lifts, and then you can start doing these surgeries. Okay. Again, this is that approach. And if you feel that, so when will this fail? Yes, of course. When will this fail? So it will fail if the bone stock is poor, because you're relying on your posterior lever arm to completely take care of the spine. And if the lever arm, because the anchors are poor, it's going to fail. And if too much kyphosis correction is needed, again, it's going to fail. All right. So be wary of that. If a high degree of kyphosis, like this is our patient again recently from Wadia, where again it was a no-win situation. I like invite all of you to guess, what surgery you all could do here. We put in a fibula strut in the front, but even then, it's a very poor result. He's hanging on, but it's not a great result. So be watchful of your anterior bone defect. If the bone defect is very large, then don't do this closing job and rather reconstruct the anterior column like this, where you go through the pedicle and take away the anterior column, put in something there, and you get a much better reconstruction then. So in a case like this, where there's a large defect in the front, the option of closing becomes a poor guess, and you want to then reconstruct that and learn to reconstruct it from the side, so you get a 3-column this thing. This is one of my first cases, so it fails if you're technically not adept to this. This is one of the first time I did this, and you see where the cage is hanging. It's right behind the aorta. So it's technically challenging. It's not one of the easier surgeries to do, but nowadays we do it in 90 minutes. It's like quick. So if you keep doing these cases, you'll learn. And the trick is to learn how to do. Again, this is my case right from the beginning. The problem here is that it's the L5-S1 junction, and no cage sits very well over there. So here, the next time I would want to go back and front. I would not want to put a cage from the back. So my take-home message is look for kyphosis, look for the patient profile, and follow a technique which, or an algorithm which fits you the best. Thank you.
Any questions? Any questions? So you could see that this is an algorithm which was proposed by Shekhar and Abhay quite long ago, when anterior surgery also was a very big played a part in TB, because the surgery for spinal tuberculosis came from Hong Kong, and Hong Kong people firmly believed that anterior disease must be treated anteriorly. But their philosophy actually gave a significant progress to spine surgery, because to approach spinal tuberculosis from C1 to sacrum, they described the anterior approaches. And virtually every single anterior approach to the spine came out of the Hong Kong study of spinal tuberculosis. But now we have already completely turned all around. So in the late 90s and early 2000, when we think of spinal tuberculosis, approximately 50-50 was posterior and 50% was anterior. I can't remember of doing an anterior surgery for spinal tuberculosis for a very long time, except for large lesions of lumbar spine and lumbosacral junction occasionally. And we do about 60 to 80 spinal tuberculosis every year. And maybe in the last 3 years, I have done 3 anterior surgeries. Of course, cervical is different. But if you come, so everything can be done posteriorly. So post-lunch, I would just give a small algorithm what we follow, because now the dictum is the front door to the spine is through the back. So all surgeries, how you approach, we have a different algorithm which we have published recently, so I will talk about it. But before that, I will hand over to Naresh for the lamp lighting ceremony.
Thank you, sir. Thank you very much.
Just like front door to the back is through the back, front door to the spine is through the back. Today we are having the lamp lighting ceremony at the end of the ceremony. Before lunch.
Thank you very much for, without coffee break, you have been so generous to keep us engaged for so long. I think it's a wonderful opportunity we all had, sir. So it's a customary to have a small inauguration, just 5 minutes inauguration, and followed by oration by Dr. Abhay Nene, and then we'll disperse for lunch, and then we have post-lunch sessions. I request Dr. Leela Prasad, the Secretary of VIZAG Spine Club, to start the inauguration proceedings. Yeah.
Good afternoon, everyone. We'll have a very ultra-short inauguration. First, I would like to invite our course director, Professor Rajshekharan sir. Just standing. Yes. Next would be our chief guest, Professor Sivananda Yaru. Next would be our guest of honor, Dr. Abhay Nene. Observer from AP Medical Council, Dr. Satyar Prasad garu. President of Spine Society of Andhra Pradesh, Dr. Y. Nageswara garu. Yes. Our faculty, Dr. Thomas Kishan. And Dr. Pushpa Madam. President of VIZAG Spine Club, Dr. Lakshman Rao garu. And for the founder president of SSAP, Dr. Uday Kumar garu. Secretary of NOVA, Dr. Varma garu. So we'll have a formal lamp lightning. So faculty, please stay back. We have a small felicitation. First to Rashid. I request Professor Bhavani Prasad garu, sir, to felicitate our course director, Dr. Rashid. I request Gopi Krishna garu to felicitate our Dr. Abhay Naini. I request Professor Loknath Garu to filtrate Thomas Kishan. Next. My parent. Dam. Next, Madam Pushpa, Madam. Please come. I request Dr. Verma to filtrate AP Medical Observer, APMC Observer, Dr. Varprasad Garu. I request Maruti Krishna Garu to filtrate our chief guest, Sivanand Garu.
Good afternoon, everyone. I welcome you all to the 6th SSAP, jointly organized by VIZAG Spine Club, North Andhra Orthopedic Association, and Department of Orthopedics, AMC. And I have the proud privilege of taking this mic today because I was the founder president of SSAP, that is way back in 2015. Courtesy Professor Rajshekhar sir and Dr. J. Naresh Babu, who took active part at that time. And this is the very venue where we started our first SSAP. And then we are all lucky. Our generation of surgeons, including youngsters, are very lucky to listen to the legendary Professor Rajshekhar sir and his Ganga family, Dr. Pushpa. We had her many times. And Thomas Kishan sir, and then Abhay Neni, very eminent spine surgeons. You are very, very lucky to listen to them because you may be seeing them in the YouTubes and many lectures, webinars. But this is the physical interaction is something really a unique feeling. I consider we are all lucky. I hope SAR has a special award affection for Artho of VIZAG. Thank you so much, sir, for all the round affection. Hope SAR will continue the same service in the future also. And also this topic today selected very ever-changing subject. Maybe SAR was doing at PG at that time, 1982, sir. Maybe you are PG then, 1982. 1982 at Varanasi conference, that is the first conference I attended as a postgraduate. SM Tuli was one of the organizing secretary and TP Srivastava was the other organizing president there. There was this tuberculosis was extensively discussed at that time. At that time, that middle path regimen was very popular. So one side, pure conservative treatment, there are arguments. Other side, Hong Kong radical people. And middle path regime, then they advised, please prefer middle path regime. So Hong Kong group, one side, and our other conservative, that is the middle path regime. Ever since 1982, since SAR has written a book, SM Tuli sir, later so many changes have come, including now surprised to see 6 months ITT is enough. Now the study has proved that. So many controversies regarding the test reports. We were the Manto test generation. Now so many things have come now. And at this moment, And Sir has been a role model for many of us. Like his Ganga product, another Ganga product is there with us. That J. Naresh Babu, where is Naresh? So he has been carrying the torch and the flag of the academics from Ganga family. And also see some of my postgrads also did fellowship at Ganga. Many, and our present generation of PGs also getting trained there. Thank you, sir, for allowing them. Sivananda, thank you for giving them an opportunity. And so I'm not really active these days, but I'm proud that my student and my colleague Sivananda is carrying the torch, academic torch, and he is keeping our flag high. And then at this juncture, I am proud, really proud to announce that our own J. Naresh Babu has won 2 international awards this year. Really a great achievement. Give him a big hand. And he is a proud product of Ganga family. And then the one prize is ISSLS prize for the best spine research in basic science and bioengineering 2024 at Milan, Italy. Very, very unique achievement. Really, very few people will get that. Really, we are proud to be. I am proud to say that he is our contemporary. And then another award, Scoliosis Research Society, Thomas Whitecroft Award 2024, San Diego, USA. So really, Naresh, you need a big felicitation, but as of now, we wish you all the best, our blessings and best wishes. So as our blessings also will be there always with you. With a few words, hope that please try to clear your doubts, all doubts. Please don't feel hesitated. Any doubts regarding tuberculosis or any other thing, sir is there. Eminent surgeons are there. Thomas sir is ready to give clear all your doubts. With a few words, I thank all the faculty, including SR sir, and then the organizers, Leela and his team, Lakshmanrao sir and his team, for doing wonderful job, and the sponsors also, and my younger generation. Please take the opportunity. Any academic event is useful. Don't ever think that you can get this from e-Google. You will never get that. Only physical interaction only. No e-teacher can replace that. With a few words, I wish you all the best. My blessings to my postgraduates. My regards to my seniors and my colleagues. Thank you so much.
Thank you, Uday Kumar sir. Thank you very much for coming over and taking time. So it's the time now.
So good afternoon, all of you. Sir, it is our great privilege that having you in this particular meet. And you are always supportive to the North Andhra Orthopedic Association. On behalf of this North Andhra Orthopedic Association, we are grateful and immense thankful to you, sir, for the entire team who has come here, sparing their valuable time, and they are giving. Ma Saraswati has come here and directly Saraswati is speaking, and everybody is enjoying this particular academics, and at the same time it is a beautiful learning event and interactive session. Greatly it is enhancing and enriching knowledge for all juniors, seniors, and we are clarified a lot of myths which has been lodged in our brains for a long time. Such things are cleared. So once Saraswati came means automatically everything will come. So Lakshmi always it follows. The knowledge is the money, and always everything will come. Follow the Saraswati. So that is you are the standing example, and your love and affection to the Andhra Medical College, because being a head of the department of Andhra Medical College, we are sending our postgraduates with your kind heart you accepted. For that I am extremely thankful to you, sir. Extremely thankful to you. So this help is really a boon, and the young minds ignited like anything, and they will go in a future endeavors, they will succeed in their aspects. and you told one word to the post-head. That post-head really, the Srivatsa, is telling me that. So aiming low is a crime. He always remember that word, and he always says to me, and he always say that particular word. Whoever the new post-head is entering into the department.
Small aim is a crime.
Yeah,
Small aim is a crime.
Small aim is a crime. So that small aim is a crime sentence is following, sir. So everybody wants to think big, and they try to achieve this. This is just because of your thought and inspiration to the young students. So this process will be continued with your great love and affection, sir. So thank you very much, sir, for your love and affection.
Thank you, Sivananda sir. Thanks for staying back. I think I know we have some family emergencies happening, but I took time to stay back. So very kind of you, sir. Thank you very much for being over here. So we have come to the customary Professor S. Rajashekaran oration for 2024. We have initiated Professor S. Rajashekaran oration last year, 2023, and the inaugural oration was given by none other than Rajashekaran sir himself. And this year we are fortunate to have Dr. Abhay Nene presenting us the oration for this year. So short introduction to Dr. Abhay Nene. So we heard of him so much on academic front, and there are so many other shades of Dr. Abhay Nene which we are not aware of. So born on 19th May 1972 and married to Dr. Amita Nene. So he has been talking about the infections specialist, and he got his fellowship training on Spine Foundation from Dr. S. Bojraj sir, and MBBS in University of Bombay, and he got abroad training from Dartmouth Hitchcock University and Germany, Argentina, and Singapore as well. And he has been AO Spine Educator of the Year 2018 and Dartmouth Fellow and SRS Fellow and IESILS Fellow. And he works as a consultant spine surgeon, performs spinal deformity corrections and tumor resections at Lilavati, Breach Candy, HN Reliance, Saifi Global, and many more hospitals. And honorary visiting pediatric spine surgeon at BG Wadia Children's Hospital, Mumbai, and specialist in spine TB and scoliosis, C1, C2 things. And he is now the chairman of AO Spine Asia Pacific and national chair of AO Spine India. And member of AO Spine India Research Commission and editorial board of many journals. And there are so many other things to Abhay Nene which we are not aware of. So he is a avid sports person. And you know him enjoying the way he live his life, and sometimes it's and we can envy his lifestyle. So avid sports enthusiast is spine consultant for Olympic Gold Quest and Go Sport Foundation, and he is a regular feature of I think those guys who are following him during COVID. He has done a excellent the social media content lockdown like docs. That was very well appreciated. If you find time, then just go back and listen to them. Apart from this, Dr. Abhay Nene is a regular half-marathon runner and having completed over 20 half-marathons all over the world. And an avid cyclist, having cycled some of the world's toughest routes, including from Manali to Leh. So just imagine from cycling from Manali to Leh, it's reaching 17,500 feet. Over 6 of the toughest Himalayan passes. And this is the favorite pose. Those who is following him over Facebook, you can know. So wherever he goes, I think, I don't know what he does there, but he does the same thing again and again and again and again wherever he goes. And it's done the tour of Nilgiris, the India's longest cycle race of, and been top 30 finishers in 2014. And wow, Iceland team finisher. So team cycling across the perimeter of the Iceland. And an epic 60-hour non-stop relay rally cycling right from the New Delhi to Bombay. So you can't imagine all those things. So non-stop 60 hours rising and raising 2.5 crores for the Cancer Children Foundation. And he's an everyday trekker and having scaled Everest Base Camp and Kanchigonga Base Camp and some of the India's highest trekkable peaks like Stock Hungary and at over 20,000 feet in 2016 and another 6,000 meter peak at Somatang in 2021. So Abhay Neni also has a say other face of first for him is Abhay moonlights with the rock band and called the Flunkies, and is as a backup vocalist and guitarist. So there's so many shades for Dr. Abhay Nene. We are fortunate to have him here. All over to Dr. Abhay Nene for his oration. How old is he? So, what do you think?
So, it's really a pleasure that Abhay is here to give this oration. So, the first time I met Abhay was in Delhi. I don't know whether he remembers that. Very well, yeah. So, there was a ISSS meeting there, and the organization was very, very bad. I mean, everything had gone wrong, and we had to completely redo the whole program. We had to put down everything, and the organizers were nowhere to be seen. And I was the joint secretary, and the secretary also was nowhere to be seen. And I really needed help to get something done. And out of nowhere, Abhay came, and then we both sat down and then did the whole thing. And I was really amazed at the willingness that he was giving to the society behind the scenes. That was the most important thing. There was no way he was connected with the society. There was no way he was going to get the credit for what he was doing. But he was willing to sit down behind and do the whole thing. And at that time, I told Professor Ingalalikar and Bojraj and Arvind that the next star of ASSI in the future is going to be Abhay. I mean, he's one guy whom we have to look at, and he's going to be the future star of India. And I was thinking little longer he'll become a star, but he's already become a star at very, very young age. So he's 34 years old, sir. So that's the answer for this. I'm very glad that Abhay is giving that.
So no matter what I am, I want to grow up and become the Raja of spine. I think that's a sentiment that echoes with all of us. And I think everyone here wants to be the Raja of spine. And you know what I'm talking about. So I'm going to try in the next 15 minutes, declutter a pathway that may help us, be a 10% of a Raja. At a time, there can only be one Raja in spine or in any field. But we can try to emulate as much as we can. And it's easy to say you just follow the guru, right? The guru gives you the way and you just follow the guru. But in reality, that's not the truth. And, you want to emulate, you want to do everything that your mentor does. But there are so many obstacles that actually get in the way of you getting to your path. And to follow the guru, you have to follow the principles that the guru, has. And I think the 4 dimensions to be a good spine surgeon, and we'll unlock the 5th dimension right at the end. The 4 dimensions, I think we all agree, would be to be an astute clinician, to be a skilled surgeon, to be an updated academician, and then to be an inspiring leader. So if any of us aspire to be anywhere near the Raja of the spine as we grow older, I think these are the 4 virtues we'll have to work towards. And let's try and break them down and see what the Raja did and how you can do that same thing at your level, right? So as far as acquiring clinical skills goes, it's not easy, right? It's not easy to acquire clinical skills because it's an experience-based art. The number of patients you see, that's what gives you that feedback, and you can't acquire a clinical skill overnight. You can't pass an MS exam and say, I've acquired my clinical skill. So if you, again, look at your mentor, what does the Raja do to acquire clinical skills? Well, he continued to study in a time when it was not necessary. He had a business to go back to, a family hospital to run. But he continued to go all over the world acquiring knowledge, which was not necessary. I think we all can swear and say that he would have been as successful if he still didn't go on chasing his clinical acumen and, building up his clinical acumen. So he got the MCH ortho degree, back in 1990 when it was not one of the common things done, and that's a picture of the young Raja. He traveled and invested time. I think that's a bottom line, that you need to take out time from your schedule, because every time you're updating your clinical acumen, you're actually missing out on business. Your business is to be in the clinic and seeing patients. But remember, this is the reverse investment. When you invest time traveling, seeing, attending here, I'm so happy so many of y'all are here and y'all are not, doing your practice or knocking off a fractured spine, because this is going to lead to you getting better and bigger as we go forwards. Okay, he rubbed shoulders with the top clinicians. So merely being around, what sir said right now, the physicality of meeting and being around people who are knowledgeable, who exude that kind of clinical composure, will make you a better clinician, and you're doing just that. And then he continues to learn, right? So there's no ceiling to it. Like madam said, that we come here, we've learned more than what we've taught. I have learned more than what I taught in the last 4 hours. So you continue to learn and continue to look for places where you can get your knowledge bits. And for example, Raja conducts this meeting at the GOSC, right? The Ganga Orthopedics Spine course, which is the operative course, Ganga Operative Spine course. The first session is a clinical learning session. And that is probably the best session of the course, where all the faculty are sitting together and learning from each other's tips and tricks. Because surgery is an art, it's not a science. So all of us have different methods of doing the same thing. And it's not in the textbook, and it'll be no lecture. It'll happen when you start discussing how do you solve this problem, sir, and how do you solve this problem. And from the different corners of the world, you get more and more information. So the more you engage in this activity, the more enriched you're going to get. And that's one way to shorten your learning curve. Right? Otherwise, you're going to just have to live those 25 years as a doctor to become, an enriched clinician. Okay, now what can you do? Before that, what does Raja do even now? So he sees his patients himself. This I've got from reliable sources. One of them is a 6'4" Dr. Ajay Shetty, who confirms that every case that Raja operates is seen by Raja. And that's not true even for me. Even I sometimes operate a patient who I've never seen. Okay, what else does he do? He discusses difficult patients. And it's not uncommon for me to get a call from someone from the Ganga team that this is a pediatric deformity, what would you do? And I'm like, you're asking me, I've learned from you. But they're still asking, right? So there's no shame in asking, discussing, and getting someone else's that extra bit of information. It may mean nothing in the end, but there's a high chance what you get from that person is worth its weight in gold. And discussing difficult cases rather than going and doing Kavilya, mere ko sab aata hai. Discuss, take opinions and be open to those opinions, and that's going to make you a better clinician. Right? What can you do? You're still just a 1 year, 2 years post-MS person. How can you be an astute clinician? Right? So you start early. You remember you're in the trap that unless you're experienced, you're not good. But if you're not good, you can't be experienced. That's the trap that a young orthopedic surgeon or a young spine surgeon is caught in. So the steps that you can work is, the number one is to work. Like keep work as your primary, objective. And you saw all the fun stuff that I do. I started doing that only after 40. From the age of 28 when I finished, or 27 when I finished MS, 15 years I worked like 16 hours a day. And I'm sure Raja and Naresh and Leela and Thomas and everyone has done that. So there's no substitute to hard work. This can't be said in a more relevant place than here. The more you work, the more number of patients you see, free, whatever, opinions, on phone, on WhatsApp chats, the more you'll be enriched. So work. Keenly look over the shoulders of your boss. So you may be opinionated. You all, for example, may feel that no, 12 months AKT is not good enough. But at least hear my opinion. Because you may then start to understand why someone else thinks like that. Right? So everyone has a right to, having an opinion. But everyone should also listen to other people's opinion. When you keep looking over the shoulder of your boss, you'll start understanding the nuances as to why he conserved this disc and why he operated this disc, or why he proposed fusion for this stenosis and he decided to decompress this stenosis. It can't be explained in books. So hang with your boss hour after hour. It may be torture sitting in the clinic. Sometimes your boss will say, boss, now you go. But you say, I want to sit here till you're here. I want to see every patient that you see. And in my mind, make a plan and see if it matches with yours. And that's what really helps you building your own plans. Of course, diversify. Because sometimes we get stuck in a logistical trap that I've been taught by so-and-so. So this is my way of thinking. This is the Ganga hospital way, or this is the VR spine way. That's not true. There are many ways of skinning a cat. So the more you travel, so I must admit that I've learned as much from Dr. Rajshekaran as I've learned from my own boss, Dr. Bhojraj, my mentor, right? Because the more you travel, the more aspects of treatment you get. And for that, you need to have an open mind. So don't be closed-ended on what has been taught to you. And of course, stay curious. The meaning of stay curious is that supposing you say, look, this MDR-TB is not in my thing. I don't want to. But I want to be curious. I want to. Why not? Your brain is so big. You're only using so much of it. Why not go back and read about the treatment of MDR-TB and next time come here and give me the lecture of how that MDR-TB should be treated. So stay curious. Don't put anything outside your purview. Everything is in your purview. The more you want to do, the more you will be able to do. All right. So that's in your hand. And because there are no limits, it's not like my IQ ends here. I can only do a laminectomy. There's no limit. And you can just keep learning and get better and better. So the black box here states that you got to give this time. You got to be patient. You got to keep reading up. You got to keep discussing. You got to keep taking opinions. And most important, be compassionate. Because if you have compassion for your patient, because your patient is going to be your teacher. If you want the best result for your patient, you will do all those things. If you want to just get the bill out of that patient, you will not do any of this. So you'll have to make that differentiation in your head and ensure that if you deep down want the best treatment for your patient, you will need to do this to give the best available treatment. All right? So the Ganga Hospital philosophy, if you see, which is Dr. Rajshekharan's philosophy, is that the team that he built was, built by passion. The people who are in the team, and you see some of them here, think the same way, act the same way, behave the same way, do the same, their outcomes are the same, their thought process, is the same. And that's what binds us together. All right? So this is all that comes from a very, critical interview, which I'll share you the title of that, and all of you should go back and read that interview. I had the privilege of actually listening to that live at the Global Spine Congress, where the philosophy of how to build a team came up, and you'll hear this again and again. The bottom line is that you work for outcome and not for income, because we as doctors are service providers. We are not professionals making money. A banker is or a lawyer is very different from a doctor. Okay, our primary job is to give service, and making money is a byproduct. If you give good service, you'll really make good money. It should not be the other way. Okay, the next part is being a skilled surgeon, and here there's a bit of a dichotomy, because many of us are born skilled. We have that artistry in our hand, and I think I'm going to err on the fact that Dr. Rajshekharan is born skilled, because he was a good surgeon right from the start. Having said that, he still put in effort, and if you see, all the advancements in surgical techniques have started from the Ganga Hospital, whether it is osteotomies for anaconda spines, which we had never heard of before, to endoscopy today, which guys like me look down upon it, but he's still at the forefront of it. His team is doing endoscopy spine and doing anaconda spines. So upgrading your surgical skill is again a requirement, even though if you're a skilled surgeon to begin with. What if you're not a skilled surgeon to begin with? How do you work around this? And this is where I put in my passion. And I was not a skilled surgeon to begin with. I hope I am one now. But I decluttered that thought process in my head, that if I want to be a skilled surgeon, what are the attributes? What are the minimum attributes that a skilled surgeon needs? And you would all agree that these are those attributes. And you would also agree that the most of them are physical attributes. They are not genetic attributes. They are physical attributes. How steady your hand is, how dexterous your hands are, what stamina and resilience you have. And hence, I would say that physical fitness becomes a mandate for all of us. We are actually medical sportsmen. Surgeons are medical sportsmen. We are not physicians. We are not brain people. We are touch, feel, hand, sense people. And we need to be sure that we are on the top of the game of this modifiable factor. Even the most unfit person can put his head to it and become fit. It's a modifiable factor. If you're unfit, you're at fault. You can't blame your genes. Everything can be worked around. So all I can say is that you want to invest in fitness, because everything that you need as a surgeon is what a sportsman needs in his practice, or an army man needs in his practice, a soldier, or a policeman needs in his practice. We are in the same category of physically endowed people who need to give physical attributes, and we can't have a second best option. We can't come out of a surgery saying that it didn't come out well, it was third best, I could have done 2 times better. Every patient is his one and final surgery. And so I would beseech you to invest in fitness. So all the stuff that I do is for my own kida. It makes me feel happy, it gives me a high, but also it keeps me fit to do the long scoliosis surgeries because the moment of panic happens 3 hours into the surgery. And if you have not practiced that resilience, when you're running a marathon, at the end of Leela will agree with me, at the end of 18K is when you start bonking. And that's when you need to bring your A game to finish the marathon. Otherwise, you're a non-finisher. Similarly, the epidural bleeding or the big injury will happen 3 hours into your surgery. And that's when you need to bring your A game. And that's when your endorphins need to come up to the party and they need to make you think correctly. Otherwise, you start, going all over the place and making wrong decisions. And that's the difference between a captain of the ship and a sailor. And you're going to be the captain of the ship when you're the lead surgeon. So invest in your fitness. Besides that, update your skills regularly, and cadaver courses are the cornerstone of updating your skills, because that's where you can be closest to doing an experimental surgery. So don't miss any cadaver course available in your area. Unless you mastered that technique, whatever the course, just go and keep doing stuff on cadavers before you start doing it on people. Visitations, because you'll see surgeons using different hand skill tricks. In different places, people use different tricks, and you can imbibe those. Again, they are not given in, in books. One thing that I believe firmly and I practice is I do one new surgery every year. Every year I do one surgery that I've not done in the last year. So it started with TLIF, it went to C1, C2, something that I was not taught as a part of my fellowship, something that is not in the part of our curriculum where I practice. So the last year I did a sacral chordoma. No, I think that was year before last. Then I started putting cervical pedicle screws. So every year there's something new that I would aspire to do, which I believe will be of use in my practice. I go seek out a person who can teach me, and I learn it and I try to do it in my practice. Try to do that because it will help you exceeding, because surgery is an ever-changing skill. And you got to be curious always to know what's going on. I think endoscopy is on my list, because the way Ajay has sold it to me, I think I must learn at least some bits of endoscopy. So maybe in the next year or so, I may want to do some endoscopic surgery. And one way to do it in a small city is to partner with surgeons who, for example, if you have a bad osteotomy to do, and don't give it up, you try to get a person who can do it and do it with him. You will learn the art of doing that surgery once you've assisted that surgery once or twice, and you have enough mentors here who are happy to come in and help you and give you a hand. All right. What is the next thing? Updated academician. You have to be an academic surgeon to be a Raja of Spine. You may be a great skilled surgeon, busiest, and think about it. You may know a few dozen such people who are the busiest surgeons, who are making the most money, but are nowhere in the academic field. Would you respect that person more, or would you respect another person who takes out a Sunday in his family time just to teach people who need to be taught? You would respect which person? So being up ahead in the academic circuit is one of the investments you do. And one of the key things that I say is that if you ran a business, you would spend 30% of your income in advertising. Think of this as your advertisement. Now that I've come here, that many more people have seen me, known me, and they will think well about me. It's a pure recognition that I've got. Ditto as advertising, right? So think about it. If you're very commercial, you're still taking out that 30% time in academics. What did the Raja do, right? In his academic frame of mind, there was learning. So you first learn yourself. There's research, and then you start teaching, and that gives you self-development, right? So you have to begin early. It has to be a frame of mind. The frame of mind should be that I want to be a good academician and then a busy surgeon, not the other way, okay? You want to get involved in smaller groups. So you may say that who's going to listen to me? Well, your colleagues sitting around you would want to listen to you. And you start at that level and start building yourself up, rather than saying that no one in this circuit will listen to what I say if I come and stand here. So work within your limitations, but keep working up. Never say no, obviously. So if you see the list of, academic titles that Dr. Rajshekharan has, you will realize, the way to go. There's no need for any of this. There's no need. I mean, he has a hospital to run. But even then, to stay in front of the academic business, this is what you need to do. So from your end, join online courses. These are early starts. You can do this early in your life. Join webinars. You can do this at your time, at your discretion. You can keep watching this again and again. This has become so easy. Attend minimum 2 academic meetings a year. I'm going to say 1 a month. Spend time attending academic meetings, because you will learn a lot. Read recent publications on clinically relevant topics that you treat. Plan visitations, that comes up again and again. And become a part of your local academic body and attend their meetings, so you can start at a lower level and then aspire to become ASSI, SRS, blah, blah, blah. Right? There's there's no ceiling to the top. As far as research goes, I think none of us, can argue that there's only one person who's the most cited researcher in the world who represents us. Okay, and if we want to emulate that, you want to just go and see what sort of research and awards the Raja has got. And it can be awe-inspiring, but remember, awesome and inspiring. It should inspire you also. You should get inspired to do this, and we'll try and declutter the way. What can you do? So start by maintaining records. If you want to aspire to become a 500 publication guy, start maintaining your own records. Every disc you do, every patient you see, it's not so hard, it's just time consuming. Start writing up chota case reports for the Indian Orthopedic Journal, for the Indian Spine Journal, etc. Then start collaborating with colleagues to increase your database, and work on clinical case series. You can do clinical case series. I treated 30 discs with cervical radiculopathy conservatively. That's a clinical case series, low end research, but it's still a research. So it gives you a frame of or a flavor of researching. And then attend courses, because it's not a part of our curriculum to learn the art of research and the art of publication. So you need to attend separate courses. They're available online, they're available offline, where you learn what is statistics, how you read a paper, how you write a paper, what's the writing language, which journals require what minimum. For example, the New England Journal of Surgery, you need to register your research before you start. Otherwise, no matter what your data is, they are not going to accept it. So that's a taught art. So look for courses that teach you about publication and scientific research and attend it. As far as teaching goes, I mean, we are rubbing shoulders with the greatest teacher of our generation. And what the Raja does is, even now when he started, okay, like you and me in 1994, he still engaged in journal clubs, seminars in a makeshift area. This is all coming out of his own words. This is interviews from Dr. Rajshekaran. And that now has moved on to their hospital becoming the largest providers of formal orthopedic and spine education. Right? So that's the pathway to the top. So at the bottom, if you start working, you build up a good base for the top. And today, more than 282 doctors of our country and 212 overseas doctors have been through their fellowships. And this is again dated. I'm sure today the data is even more. And you obviously know the credentials of the hospital that they work in. And this has all been brought up by that 1994 beginning, where they sowed the seeds of academic discussions and journal clubs. And that's what you can do. And I mean, there's no end to the amount of awards. This will be like a feature film if I keep running it. So I'm going to just move on. What can you do in terms of teaching? Who wants to listen to you? So start with a permanent assistant. So many of us are shy to have a fellow. You can start with having a less qualified person, an MBBS, homeopath, whatever. Because the minute you have a junior with you who's a permanent, he's going to keep picking your brain. And then you got to be answerable, and you start raising the entire standard of the unit. The minute you get a spine fellow, post-MS guy, the responsibilities on you increase triplicate. It's like having a child. And you have to then up your game to be able to sustain that guy's thirst for information. He's the generation ahead of you, right? Start speaking in local bodies. It could start with your building or Rotary Club, and then, moving on to your local spine or orthopedic club. Then start making local state level presentations. Don't be shy to submit papers which get rejected. One day they'll get accepted. And then finally start a fellowship program, because that's what will build your internal pressure to learn and to do research and to do good academics before you then form a teaching unit like the Raja has. And then finally, you want to be an inspiring leader. To be an inspiring leader, you need to know what leadership is. It's easy. It's man management. So identify what your peer needs and give him that. That makes you the good leader, right? So you start with a solo practice, move that into a practice group, and then you can have an institutional practice and become a person who can lead the world like the Raja has today, right? So work hard. The Raja of spine has worked hard to set the example. He's shown the courage of his conviction. He's passionate about everything that he does. He networks at every level, and here networking is not in a bad way. When I was showing this lecture to some of my colleagues, they said, one thing you missed is that when he talks to me, I feel like he's apna. He's talking at my level, on a personal level. That networking, I go back with a very, very positive frame about the person. And that's a very, very, acquired skill which you have to put in time and effort to do. So if I meet someone, I need to talk to him at his level. It's humility, and it breaks the barriers, and it makes everyone at one level. And it's a great way for a leader to be. A leader has to be in the team, not on top of the team, right? So the best leaders that you have worked with you and not ahead of you, right? right? And then lead from the front, lead with example. So understand people's strengths and weaknesses around you. You can start with the maid at home. Um, there has to be trust, there has to be support and backing, and you have to give them what they're looking for, and retain good talent at all cost. So there's no cost that can actually cover the cost of a good human talent, which is going to be your workforce. And leading from the front is the most important. This is the research, this is the paper that I'll encourage you to read. This is an interview of Dr. Rajshekhar. It's a 3 or 4 page interview. It's out there on the internet. So you all can all go through this, and everything is given there. It's almost like the Gita of creating an academic leader or a surgeon leader. All right. So in terms of leadership, develop a good team, and that's what's going to back you. And then with that, you can develop an institute from a unit and become, like I said, the world leader. We are trying that at our level. We have formed We Are Spine, and I keep asking Raja and Ajay what next, and we are chipping away at the block. You can form that kind of a team also. Now all these 4 dimensions covered. Finally, what is the 5th dimension? Do you agree or no? Like, this is the bottom line. If you are humane, if you have integrity, if you have empathy, if you have humility, and if you have family values, you become a cut above the rest. And think about how many people can combine the first 4 with the 5th. That's a very, very deadly combination, right? So this will make what you are. I mean, I don't have to, further talk about this, but I mean, the words are self-explanatory, that if you have this in you, everything else will follow, and you will become the next big person in your community. Okay. There is a family that supports you, and in the end, no one else supports you as much as your family. If you can involve your family in your successes, they can be there with you in your failures also. And that is something that that no other cultures in the world have, that we have, and we can fall back on that. So in the end, to be a good doctor, work for outcome, not for income. Think global, act local. It's your practice, it's your service, it's not your business. We are not businessmen here. We are not looking at every patient as a patient, but you're treating people, right? Engage in good work-life balance. Cultivate extracurricular habits so you still have the strength to do your curricular work. And stay curious, absorb goodness. With every person you meet every day, you'll find something that you don't have. Try to absorb that and hang on to that, because that's one more addition in your personality. And become a wholesome person rather than a good doctor. Work hard on building resilience and conquer the 5th dimension by dreaming big, finding a role model, allotting prime time to non-professional activities, something that doesn't give you income, whether it's academics or whether it's extracurricular activities, and be a mentor. That's the only way you will evolve and become a lambi race ka ghoda. Thank you.
So that was an excellent perspective of analyzing the Raja of Spine. And you have been so fortunate that Sari is here and you are here. So we need a big round of applause for Dr. Abhay Nene and deserves a standing ovation for so much of content just analyzed. I request Sar to speak a few words.
No, what I mean is that, it's Abhay is somebody whom I love, admire, and respect quite a lot. So it's really humbling to have this lecture done by him. But one thought I was thinking when Abhay was speaking is the topic of this lecture could have easily been how to be Abhay Nane of spine surgery also. I mean, it's just that Raja is a common name that can happen to anybody. And so when Abhay, it's recorded? So what you do is, when all of you hear it back, you change the first slide and put it as how to be Abhay Nane of spine surgery, and still the lecture will be very good. So that's the best way. Thank you, Abhay.
So I request our president of SSAP, Dr. YNR sir, to join, and I request Rajshekharan sir to give away the oration certificate to Dr. Abhay Nene.
So, a very good afternoon to all. On behalf of the organizing committee, I think I wish to express my sincere gratitude to our distinguished faculty members whose expertise has been the foundation of this conference. So, a special thanks to Professor Rajshekharan sir, whose pioneering work and profound insights into spine infections have greatly enriched our understanding. Sir, your leadership in the field continues to inspire us all and are deeply thankful to your valuable contributions throughout the conference. My deepest appreciation to Dr. Abhay sir for his illuminating lectures and case discussions. His approach to complex spinal infections has added a whole new dimension to our understanding. We also would like to thank Dr. Thomas Kishan sir and Dr. Pushpa madam for sharing their invaluable knowledge on spinal infections. The insights you provided on diagnostic challenges and advancements in radiology have given us a clearer understanding of the complex area. And finally, to acknowledge and thank our sponsors, Johnson & Johnson, Sun Pharma, and Jayon, without whose support this conference would not have been possible. Your contributions are highly valued, and we are deeply grateful for your commitment to advancing spine care. And finally, thanks to the delegates, your participation and enthusiasm have made this conference interactive and dynamic. So now I think we will, after a 2-minute video from NAOA, we'll break out for lunch for 15 minutes and come back for the post-lunch session. Two announcements. There'll be 2 announcements right now, a couple of minutes, and then we'll break out for lunch.
Good afternoon. Sorry to stand between you and lunch, but just a quick announcement. We are organizing the National Conference of the Association of Spine Surgeons of India, ASICON 2025 in Bangalore. It's in January between 16th and 18th. We promise to have an excellent scientific session. We welcome all of you to please attend the conference. I think we're going to have something for everybody depending, on what level of seniority you are. But a special request to the postgraduates and the young surgeons, we have designed the largest spine cadaver course that we have. There are 18 modules that covers every surgical technique from the C1, C2 to the sacrum, front and back, including minimally invasive, open and endoscopic. So we have 216 delegate seats. So please do attend. I think it will be a fantastic opportunity to enhance your skills. And please, we look forward to seeing all of you at the conference. Thank you very much.
Good afternoon. On behalf of North Andhra Orthopedic Association and us, we are conducting a state conference in Jan 31st, February 1st and 2nd of 2025. Please, all of you are welcome and get registered in the website. Thank you. We'll break out for lunch for 15 minutes and come back for the post-lunch session and have a talk.
So post-lunch, we can have a free talk with sir. We can discuss whatever doubts we have in surgeries or treatments, and then anything specific thing you have to clarify, sir can have a small presentation on that. Lunch. Okay. Welcome back after post-lunch session. Request everybody to take seats. Yeah, so sir has to take flight at 4 o'clock. Now we have 2 options, whether there is a lecture on how to correct heel tuberculosis, or sir is willing to answer whatever questions related to tuberculous spine, a conservative surgical evaluation. You can just interact with sir. We will go for discussions or lectures. Both, both till 4 o'clock, sir has to leave. Algorithm.
Hello. Yeah. So while they are setting it up, I just want to bring one aspect which we discussed, and there may be a loss of clarity on what should be your approach if a patient has neurological deficit. So in something as important as this, there cannot be an answer which is like that, you know. So you have to modify it to each patient separately. First of all, the question is, what is the neurological deficit with which the patient comes to? And here we can divide it in two ways. The patient or the patient's relatives. Sometimes if the patient is a child, and then there is a concerned father and mother, and if they have already noticed a difference in neurology. So if they have already noticed a neurology, I would actually put that, and then you are seeing some compression in the spine. And the father and mother ask you questions like, sir, in the MRI there is some compression of the spinal cord and all that. I mean, that's a very clear case where you need to operate. Not because that patient may not recover with anti-tuberculous drugs, but if they form that part of 15 to 20% who will deteriorate, then you have no answer to tell them why you did not operate before. So you would fall on the side of over surgery for these people, and then you would operate. So patient knows that they have a problem, and there is very clear-cut evidence of compression of the spinal cord. What Abhay was telling was when the patient is not aware that there is a problem, and this is very, very common. For example, in cervical spondylitic myelopathy, approximately 25% of patients, when you examine them, they have a neurological sign, but patient will not know anything. And then when you ask them to do this quick test and all, he himself will look surprised that he is not able to do it correctly, and he will keep on doing and trying why he is not able to do. Or you are trying to make them into a tandem walk and they are not able to do a tandem walk. So that is the first time the patient himself is knowing that there is a problem. That is okay. But if they are just coming with some hyperreflexia or just plantar is extensor, but otherwise is walking well, never had a symptom, these patients, you have an option. I mean, you can still operate, but scientifically it is not strictly necessary. That's what Abhay was saying. I mean, it is not strictly necessary because most of them will become, or almost all of them will become completely okay. And then if for any other reason you don't need to operate for them. Like a patient comes with hyperreflexia, but is at the danger of needing surgery for deformity. I mean, he has the potential for a collapse. Then you would operate. That means you are hitting at two fruits with the same stone. Or a patient has come with just hyperreflexia, but you look at the MRI and CT, there is obvious instability. You would still operate. Because anyway, now the indications are two, and there is one other strong indication in which you have to operate, so you will still operate. If you choose a middle path regime in a patient who has got a neurological deficit, then there is a lot of onus on you that you must make sure that you are counseling the patient, you are talking to them a lot. They also form a part of the decision making, and then you must strictly form a good documentation. You write the patient's neurological status on that day, and then you have to write and say that this has been discussed with the patient. We have opted for a conservative treatment, and patient has been counseled that in the first instance that the neurological deficit becomes worse, we will definitely operate and sign in front of them. That's very important. So you are saving yourself. But when the patient already has a neurological symptom and it becomes worse on conservative therapy, that is a definite indication for surgery. Similarly, a patient does not have a neurological symptom. You have started them on chemotherapy, and 1 month later they come with even a mild form of neurological symptom. That is a fresh symptom. Then also you will operate. So it is not correct to say that everybody with even minor neurological symptoms require operation, but you have to be really careful in these scenarios. So there was some 2 or 3 doubts. Any other doubts or any other clarifications you want on this point? No. So this also was asked to me by 2 or 3 people during lunch. So should we give a brace when you have a patient with thoracolumbar tuberculosis who has got, then we look at the vertebral body loss to decide how much the patient will go in for a final collapse. So suppose a patient has a vertebral body loss of 1.6 and we think that his final deformity may be 60 degrees or 55 degrees. And if it is a young girl or somebody, they may not want it, then you're thinking of operating. The question is, can you avoid the operation by putting them on a brace and put them on anti-tuberculous drugs, and then will it get better? So what do you feel? How many of you put all your patients with spinal tuberculosis on brace? So you may put it for pain relief, but how many of you put them on a brace with the idea that it will prevent a collapse? So braces will never prevent a collapse. So that is number one. It's very good to say don't operate on everybody because 4% is going to die. And if you operate in lesser hospitals, 8 or 9% might die. When you're going transdiaphragmatic and operating, if your follow-up care is not good, they will die. And we also don't want people progressing in neurology, progressing in pressure sores and progressing in deformity. So he gave a criteria to do that. So that was a landmark philosophical thought process. We are grateful to Julie for that. But modern days requirement of patients is completely different. Now suppose you have a patient who has got a cervicothoracic deformity, who's an entrepreneur. He's flying all over the world every 2 weeks, and he has got a 1.5 or 2 vertebral body loss, and you tell him go and lie down for 6 months, you cannot travel, you can bear your pain, if you lie down you won't have much pain, and you will have a 70 degrees cervicothoracic deformity. If you are wearing a coat, it won't be necessary, but if you take off your shirt, it will be obvious. So what is the goal post now? He won't accept it. I mean, he would say, operate on me, I need to move. So now suppose one of our children, if my son has got a TB spine, and then there is a grade 1 power difference. Scientifically, it has been proved that these 90% of them will recover. But all these studies are taking what? At the end of 1 year, they will say 90% recovery. But what do you do till that 1 year when they are lying down in bed? You won't accept it. I mean, if you are a postgraduate and you have to give up 3 months of your education, is it okay? The university will not accept that. You cannot say, I had TB, I followed Julie's regime and I was lying down in bed for 4 months. They'll say, okay, extend and come back for the next year exam, isn't it? So there are a lot of ifs and buts. So that's why in a conference it's easy to say this is this, this is this. But when a patient comes, the patient comes with separate demands and separate packages. So you have to put everything into alignment. If the patient's father or mother asks you 3 times, so are you sure it will recover? Are you sure it will recover? Are you sure it will recover? You have to say, I'm not sure, I'm operating on you tomorrow. Because they are a separate group of people. They don't mind operation, but they don't want paraplegia at any cost. We will also be the same. Absolutely, we will also be the same for any one of our family members. Professor Thuli also brought the middle path regime for many of the government and district hospitals where surgery was not at all possible. And the science and the safety of surgery and the technology of surgery and the implant surgery is completely different from 2024. So how you would adopt that policy in this present day, we have to look at it and be manageful of that. So it is really true on a philosophical scale that you don't need to operate on everybody. So we see about 120 to 130 TB spines every year, referred from all over. We operate between 50 to 60 every year. But the reasons will be very different, not just on Tuli's middle path regime, but it may be that something very important. So last year I operated on a patient who had TB spine, unable to walk, full neurology is normal, everything. So the girl had to get married in 1 month's time. So there were many questions of postponed marriage, that this boy was coming from USA to get married, all complications. They said, if you operate, can she get married in 1 month and walk around and participate in all this thing? Otherwise, she was in so much pain she could not even move. So, but in the textbook, can you write indication of surgery is 1 month marriage? No, it is not possible. I mean, that is a special situation. So there is always these one-off situations which make you operate. Okay, sir. Yeah.
Good afternoon, sir. Sir, if the TB spine, we are starting ATT along with supplements. For pain medication point of view, if you choose NSAIDs along with tramadol and pregabalin, gabapentin, how long can you give, and what is the rationale on that? And my doubt is how long can give that NSAIDs in the older age group in that? So if the pain is persistent more than 1 month or 2 months.
Well, Thomas, how long will you give NSAIDs? Oh, you didn't hear the question.
I didn't hear.
Okay. So it depends upon the patient and how you are monitoring the patients. So they need pain relief for about 6 weeks. So suppose somebody is needing a high dose of pain relief even after 4 months, then you're sure that his response is not good to whatever you are doing. So if somebody needs a very high dosage of medication, even after 6 weeks or 8 weeks, then first I would think, are we on the right track? Because by then it should be much lesser. If the patient is going in for a pseudoarthrosis, then they have a lot of pain. And one more person whom you have to operate immediately is a patient who has got a stiff spine, either by a dish or ankylosing spondylitis or for any other reason. If they have a stiff spine, they are number one indicators for surgery, because they have so much pain and that stiff spine will not allow them to collapse. So the TB also will not heal for a long time. So more than 6 weeks, if they need a high dosage, I will review the diagnosis. I'll carefully look at the radiology to be sure that things are going all right. And then you have to monitor their kidneys and other things, keep changing and playing around the, nowadays patch is there, everything is there. But more than 8 weeks and all reading a high dose, then there is something you have to be careful. Pregabalin you can give for years together. I mean, we are worried about pregabalin, but neurologists live on pregabalin. I mean, anybody who comes for anything, they give pregabalin for years together. That is okay, no problem. You have to just encourage the patient as they walk. Any other doubts? So one of the things that we discussed today extensively is deformity in neurology and instability. So instability is the most important thing that TB, which we don't recognize very often, because deformity progresses because of instability, and there is a anterior column loss, it progresses. And one of the things that we don't recognize is that neurology also is because of lots of time due to instability. Now, if you find a very straight column, and most of the slides which Abhay showed fantastic healing, you will find that they did not have a lot of kyphosis. They were all maintaining the alignment. In the presence of a good alignment, even if you have a big cold abscess inside, they don't get a neurological deficit. But if there is a small translation moving like this, then the patients will get a lot of neurology, because the spinal cord gets severely compromised not by angulation but by translation. So you have to identify that there is a instability in every patient. You have to do. So a patient who comes in with just hyperreflexia, he doesn't know that he has got neurology. But if I see instability in the spine X-ray or in the MRI, I would operate, because I know he is a very potential candidate for a sudden increase in neurology. So all put together, it just boils down to the fact that we need to have a clear idea of what is instability in spinal tuberculosis. So with effective chemotherapy, surgical indications have been reduced to neurological involvement and instability. And instability is an area that needs to be really covered. So this was a multinational, international study. Nearly 68 senior surgeons from all over the world participated. And we asked them lots of questions as, what do you think causes instability for TB spine? How would you assess it? And this was like a Delphi study. So it was getting the core wisdom of the 68 top surgeons from all over the world who are treating high level. So many of them told that it is young age. They said cervicothoracic junction, severity of kyphosis, vertebral body loss, and spine at risks. So this is the 5 signs, 5 factors which the 68 surgeons put high in the rate of causing spinal instability. Now, in addition, you can see they opened about what is called surgical candidacy. That means what in their opinion may also push patients towards surgery, where they would agree for surgery. And that you can see here, intractable pain restricting ambulation. So this is one of the questions asked. So although they said pain can be outside instability also, if the patient has intractable pain, hyperreflexia in the presence of gait abnormality, bowel and bladder disturbance, neurological deficit, so many of them felt that you should be immediately operated. But these are the 5 factors which they told for instability. So in this, we asked them to place them in the order of what they thought was the highest risk factor. So they put spine at risk signs as 97% important, deformity angle as 97, which is also very high, vertebral body loss as 94, junctional involvement, and age at time of presentation. In addition, there were 20 other features which they had told low. I have just put it on this order. So let us see one by one. So young age at presentation. So 58% considered age at 10 years. So if you have a person who is less than 15 and especially who is less than 10, then they are patients who are very highly prone for instability. So children have 3 times more incidence of instability than adults. So we put young age at present. So less than 15 years, if the patient is there, we gave a score of 1. Secondly, they all felt junctional involvement either at the cervicothoracic and thoracolumbar junction, also to be an unstable situation. Now in your practice, you look at where all you have severe kyphosis. Many of them will be from T8 to L2. I mean, their apex is usually at T9, T10, T11, T12. So the lower thoracic and the upper lumbar area is the highest prone for massive kyphosis, because the facet joints at the lower thoracic spine dislocate very easily. They are coming out of the ribs and they are joining the lumbar spine, so the facets easily dislocate. In contrast to these 2 junctional areas, cervicothoracic and thoracolumbar areas, craniovertebral junction and lumbosacral junction are relatively more treatable by conservative methods. Because in the lumbar spine does not kyphose, it only subsides, because the facet joints are vertical and so they will have subsidence. So we did not give any marks for this, but we put for lumbosacral junction. So cervicothoracic and thoracolumbar junction, there was 0.2. And severity of deformity at presentation, they all felt will be, so a deformity of 30 degrees was considered unstable, and we wanted to put it as 40. There was a huge discussion on that, and we settled for 30. And then the deformity angle ratio. So this was also what we described this morning. So if the deformity angle ratio was more than 15, then it was given a score of 2. And if the total vertebral body loss was more than 5.5, it was given a score of 2. And if the spine at risk sign was present, then it was given the highest score of 3. So this was the decision of all the 68 surgeons from 28 countries. So this is the final score. So if you have an age less than 15 years, cervicothoracic or thoracolumbar junction, deformity greater than DAR greater than 15, vertebral segmental ratio greater than 0.5, and spine at risk sign, total 10. And then if you have a score more than 3, if it crosses 4, then it is definitely unstable and they require surgery. So this is what, then it was validated in so many places. So just a few examples. So you can see here that there is 2 vertebra involved, and then you can see here the score actually comes to 0. So there is no instability, the vertebral body loss is there is no deformity, there is no spine at risk signs, and it is 0. So even though there is a cord compression over here, the alignment is maintained, and so this does not require surgery. So we treated it by conservative methods. So conservative management, good healing in 9 months. You can see the same patient over here, completely healed, and there is no increase in deformity also. So just like this, whenever there is a case like this where the MRI looks very alarming, to give you a guideline, or even if you are deciding to do a conservative treatment, to give you the backing or scientific backing that a surgery is definitely not required, you can use this scoring. So this is very important. So this is another patient. So 27-year-old female. So T9, T10. So still it looks bad. Many of us may be tempted to say that it requires definite surgery. So score was only 2. So decided to treat it, and you can see that it has completely healed very well. So only thing here you will have to determine, like I told in the morning, you can calculate what will be the final kyphosis, and if you think that is acceptable, then these can be treated conservatively. Sorry. So in contrast, there is another this is the same patient we saw this morning. So you can see that everything is very high here. So the score is 9. So you need to do a surgical management. 11-year-old female. So you can see that there is a definite spine dislocation. You can see here spine at risk sign is 3. Everything is 3. Then our score is 6. So the surgical management is opted. So you can use this validated score. I mean, this is the published in Global Spine Journal 2022. So it is a free download. It's an open access journal, so you can easily get this over there. So any doubts on this? So otherwise we'll just go on to the next and last topic that we are discussing on what do you do for people with established deformity. So this is a major issue in India. So because we have this problem, and one of the first reports for using this technique came from our hospital called the closing opening wedge osteotomy, and we called it as the COVO, and it was published in the European Spine Journal. And now the thing is true that whatever you want to operate, you can operate only from the posterior side. So what made this posterior only approach possible? And the most important thing is that wide bilateral costotransversectomy approach gave access to both sides. Previously, if you did bilateral major costotransversectomy approach, the spine became so unstable, these patients were completely worse off than before. But the choice of having a pedicle screw allowed a tri-column purchase. And so you could decompress on either side whatever you want, but if you put adequate number of pedicle screws, then the tri-column, because the pedicle goes from posterior column, goes through the pedicle middle column, and also takes a purchase in the anterior column. So this was possible. And facetectomy approach gave good anterior access. So here you can see that if you want to go to the anterior side, you just need to stabilize it and remove the facets over here. And once you remove the facet from one pedicle to the other pedicle, then the whole vertebral body was right in front of your eyes. So you could do a very thorough decompression, and then you can even put in a cage easily. And then now it is called, as I told you, the front door to the spine is actually through the back, and this made it possible. So following this dictum that almost all the surgeries can be done from posterior side for kyphosis, so we brought a new classification for kyphosis, which was published in JBJS in 2018. So on this basis we treat what type of surgery to do. So the classification has 3 classifications. That's also, I can send Naresh the PDF, he can send it to all of you. So it is based on the columns. So type 1 is if both anterior and posterior column is intact. And a good example for this is ankylosing spondylitis. In ankylosing spondylitis, both the anterior and posterior column are intact, there is no destruction. Also Scheuermann's kyphosis. Yeah. Type 2 is either one column is deficient. And TB, lot of TB which can be treated conservatively comes into this because it's an anterior column disease and posterior column is usually intact. So it is type 2. But when the kyphosis increases more than 60 degrees, TB becomes type 3 because there is a structural deficiency of the anterior column and a functional deficiency of the posterior column, because beyond 60 degrees the facet starts dislocating. So it becomes type C, and type C was divided into less than 60, more than 60, and last one is buckling collapse. So this was, depending upon that you can actually decide what is the surgery you want to do. So type 2 was the one which usually you had, but what we have to understand is that as the collapse occurred more, then there was a functional deficiency of the facet joint. This is actually one of the things that I showed this morning itself. So this is not type 2. So although the structural destruction is only in the anterior column, there is a dislocation of the facet and the posterior column also is functionally lost. So this is not type 2 kyphosis of TB, it is actually type 3 of TB. So once you know this, then it becomes easy to what to do. So if it is type 2 and your posterior column is intact, then all that you need to do is that you need to settle this correct, and so you do a wedge osteotomy and then you close. So what is called the closing osteotomy from behind. And to do this easily, all that you need to do is to do a good laminectomy. If necessary, you can just remove the facets here and then clear up this area. And if you think you can shorten the spine at the same time, then bone to bone contact will come. Or if you want an immediate stability, you just put in a small cage over here. So on day 1 itself, the anterior column is also reconstructed and your alignment is brought back to normal and the patient can start walking from the next day. So that is the big advantage. So if it is type 2 and it is less than 60 degrees, then all that you need to do is a posterior closing wedge osteotomy. Now, yeah, but if you have a gross deformity of type 3, where the deformity is more than 60 degrees, then if you follow the same principle and you take a wedge like this and then you close the wedge, then you will find that you have severely shortened the spinal column. So as a result, you will find that your spinal cord actually gets too much compressed, or it will herniate out of your laminectomy defect. Either way, this is a big recipe for neurological deficit. So this was the work of Kawahara and Tomito. So they caused acute shortening of the spinal cord in dogs, and they found that when you shorten it by more than 2 centimeters, then you can see that there is a kinking of the anterior spinal artery, and then the patients went in for acute neurological deficit. So any patient who has got a kyphosis of more than 50 degrees, then you should not do a posterior closing osteotomy. What you should actually do is that you not only close it posteriorly, but also actually open it anteriorly. So this is called the posterior closing and anterior opening osteotomy. So this is called the COVA, which we described, and then this is now the one of the standard methods. So you can see that this is what will actually need to be done. Now, if your Sudhir Srivatsa actually also nicely showed that when you're correcting all these big deformities, one of the most important thing is to bring the anterior column at least to 50% of its original height. Otherwise, there is cord risk. So when you are actually doing the osteotomy and you are straightening it, you must actually straighten or lengthen the column at least by 50%, and then you get a good relief of pain. Yeah. So if you do it, you must be very careful. I mean, you have to be careful about positioning. You need neuromonitoring surely. The opening is wide. It's just the standard midline. Rather than just exposing only the spine, we also excise up to the rib heads, so that once you excise the rib heads of 2 or 3 levels on both sides, and then you remove the transverse process, then the side of the body is literally looking at you, facing you very much. So that's not a big problem. So here you can see what is very important is in all these patients, there is a translation of the superior segment and inferior segment, and sometimes they are rotated also. So you can see that the alignment between the inferior segment and upper segment is different. And so if you are putting your screws in one direction, when you go to the upper end, you should not put the upper screws also in the same direction. You must see how is the body and take it, because they are all less aligned. If you have navigation, it's quite easy and then doing. So once you do it, you also put the stabilizing rod on one side, and then you remove the transverse process, and then you can see that the whole cord is nicely exposed over here. The other important thing is when you do a laminectomy, you should not do a very short laminectomy over here. If you do a very short laminectomy and then you close, then again the lamina at the superior part will come and press on this thing. What you have to realize is that even though this fusion mass is very less, you can see that this fusion mass height is actually the height of only one vertebral body, but it actually represents T11, T12 and L1. So it represents the 3 vertebral bodies. So even though this has shortened, the lamina behind 3 lamina are there. So you should never be tempted to do just one laminectomy or 2 laminectomies. In fact, if you think that you are going to do a fusion mass excision of 3 vertebral bodies, I would actually take 4 lamina out, so that even when you correct fully, they don't come into and contact and press over here. So this is very important to know. And once the costotransversectomies have been done and you are stabilized, if it is in the thoracic region, you can sacrifice 1 or 2 nerve roots very easily. It doesn't cause any problem at all. But once you sacrifice the 2 nerve roots and then lift it up, then the entire spinal column, the anterior spinal column, vertebral artery, vertebral body, everything is over here very easily, and you can easily do a decompression nicely. So in some of the very bad deformities, you will find that the whole spine is completely up like this, and when you do a wedge osteotomy over here, I mean the last you remove is this plate over here. So you maintain this thin place of bone till the very last, because it acts as a natural retractor for the cord. If you start removing the bone from here, then every instrument that you bring will be a danger to the cord, and also the epidural veins will start bleeding over a long period of time. So you remove the whole wedge, and then you keep this mass of bone till the last, and then you tap it off over here, and then you can see. So looking at from the top, you can see that the whole vertebra has been removed from both sides, and then you are ready for actually correcting the deformity. So after that, you take a suitable size cage, and then you can insert it in the front, and you use it as a lever, a fulcrum, on which you can do the posterior closing osteotomy. I mean closure of the. So here you can see then it corrects very nicely over here. Once you have done that, you also shorten the cause some compression over here, and that will also give some fixation to the cage, make it more secure, and also you get more correction over the period of time also. So correction by rod contouring, in situ bending, and by compression is there. So you put the cage and then you correct. The last bit is that because you expose the spinal cord quite a lot, it is important to protect the spinal cord, because then it is only the skin, fascia, and just the spinal cord exposed. So it's always better to put two cross plates like this, so that they are not allowing that. One of the cases where we had a 110-degree deformity and we corrected it to 60 degrees, it was a good correction, but then the patient was completely neurologically intact, but on the third or fourth day that the patient was lying for a long time on the back, and he developed neurological deficit because he was lying straight on the skin and the spinal cord. And then after we turned him around and all that, after 3 or 4 days he completely recovered. But then after that, from that time, we are always putting these cross connectors to protect the cord. So this is we have entered into an agreement with the Ethiopian government to do a lot of spine correction surgeries and to train 50 spine surgeons from Ethiopia. So that's one of the ladies who came there. The treatment for spinal tuberculosis is branding by native doctors. So they burn most of them. You can see the whole body will be completely burnt. And this was one of the girls who came. And this is her 106 degrees corrected to reasonable amount, and they all do very well. Yeah. So in the last 106 patients, we have done less than 90-degree correction. If it is 90 degrees, you can get 68 to 70% correction. More than 90 degrees, we get about approximately 50% correction. And less than 90-degree correction, we had no neurological deficit. Greater than 90 degrees, intraoperative changes without clinical deficit in the end, you can see was 4. This doesn't matter. So partial deficit fully recovered was 4, and full deficit partially recovered was 1. And this patient actually recovered only after 6 months and only partially. So you need to be careful about all these patients. Now the last one is type C. That means what we call as buckling collapse. So you can see that the whole spine has completely collapsed, and the only stabilization is by the superior bodies coming into contact with the inferior body, and the whole of the upper segment and the lower segment becomes 2 compensatory curves. You can see that the thoracic kyphosis is completely gone. From here to here it's one large compensatory curve, and from here to one large. So here also you will find that the deformity angular ratio is very high, and there is a sharpness in the apex, which is also one of the big dangers for neurological deficit. These patients, you can actually put them on a halo. So they are staying in halo, and it is a walking halo gravity assisted. So they are quite active. They will get up and walk with the pulley system. And you can see that this patient, 156, slowly over a period of time on this halo, it got reduced to 126. But even though the reduction in the halo is not so much in this case, the whole spine becomes a little mobile. And when you are operating, you can feel that it is much mobile. And 156 degrees to 76 degrees corrected, and she was quite okay. So we use the halo if it goes for a buckling collapse of the spine. So that is this is a very extreme case. In buckling collapse, the worst variety is not where the spine collapses on itself, but where it is collapsing and also translating. So it comes like this and falls on the other side. So here, if you measure your kyphosis angle, the kyphosis angle will actually go into minus on the other side. That means they are having a kyphosis greater than 180 degrees, and they are also translated round. So this is a very, very difficult process to treat. And if you look at the CT scan, you can find it's very difficult to put even the pedicle screws. But at the apex, you have a very weird combination of, you can see, one vertebral body is looking down and the other vertebral body, next vertebral body is looking up. It is gone, rotated and turned. So between here and here, you don't know where is the cord and how is the cord coming, passing through this vertebra in this vertebral foramen, the spinal canal, and coming out over here. So wherever you decompress or try to osteotomize, either from this side or this side, there is no way you can osteotomize without hurting the cord. And this patient had only one problem, unbearable pain. He had such severe back pain, he was not able to tolerate anything. And that was because of a big bursa over here and slight movement. These two vertebral bodies are rubbing on each other. So we decided to do a very different, not described before, we did this. So through a very short, actually it looks very difficult surgery, but actually it was very fast you can do if you have navigation. So we just put a very small incision over here, and you can see there is so much deformity. This vertebral body is just next to the rib here. So these ribs are subcutaneous. So we just went into this intervertebral and then took up a correct plane where it was crossing the two vertebral bodies. Without navigation, you cannot do it. You will either hit this cord or you will hit that cord, because it was in a very skewed direction. Then we put this, and then we put in a K wire, and then use the DHS reamer to go from this body into the other body, and then put in a long cage which is crossing both the vertebral bodies and fused it. And so this is the weird post-operative X-ray, but his pain was completely gone and he was quite happy with, because in these patients, they are coming completely walking and only for pain. And they are all 18 years old or 19 years old, and if you give them a neurological deficit, it's a complete disaster. So these are the many different ways of treating a healed deformity in TB spine. So proper positioning is important, as is neuromonitoring. Wide laminectomy is important. Remove the wedge, maintaining a thin layer of posterior cortex till the end. Choose an appropriate size cage to prevent kinking of the cord, and correct kyphosis by gradual correction with the careful monitoring of the signals. Yeah, so that is it. Thank you. Anything on this? Yeah, 410. Yeah, otherwise we should be going to catch the flight at 6 o'clock. Yeah, go.
So anyone has any burning questions, you can last chance to ask sir before we, yeah, we'll have a group photo with sir and then we disperse. Is it possible here, Santosh, here or outside lawn? Yeah. So faculty will have one here. Meanwhile, arrange the outside line. So everyone, each of you can assemble on the outside and the lawn. So we'll have a group picture and we'll disperse after. Any coffee there?